forward. So let me start with, we have 4 medical oncologists, we have 2 radiation oncologists, we have 1 surgical oncologist. So by and large, I think oligometastatic disease also belongs to a medical oncology specialty. So can I start with Dr. Priya? Dr. Priya, how do you define oligometastatic disease? What is the definition? What do you think is your interpretation of that? Dr. Priya? Or I cannot hear anything from that side. No, I cannot. Can somebody help me? We are not able to hear whatever is being said from there. Ghansham has muted the mic after he has spoken.
So Ullas, Priya has not joined.
Okay, fair enough. Fair enough. So Dr. Ajay Yadav, if he has joined?
Yeah, Ajay is there, physically there.
So can I know who all have joined? Dr. Ritu is not joined yet.
Ritu has not joined. Ritu, Vasisht and Priya as of now.
So who have joined? Vasisht?
Ritu, Vasisht and Priya has not joined.
Okay, fantastic. So Dr. Ajay, how do you define oligometastatic CA breast?
Yeah. Okay, thank you, Dr. Ullas. So oligometastatic breast cancer is defined when there is low disease burden, means there are 3 to 5 metastatic lesions and they should be amenable for local regional therapy, either surgery or radiotherapy.
A very important definition, they should be amenable to a local regional therapy also. That's very, very important. Does the radiation oncology, Dr. Lucy and Dr. Dilip agree with this definition?
Yes, I think oligometastatic disease, it's been defined by Hellman, and it is 1 to 5. 1 to 5 limited low burden of disease, and both in size as well as in number, which has reasonably responded to prior systemic therapy. So now we have a chance to treat it with local tools.
So from 1 to 5 reasonably responded to the systemic therapy. And so this was the concept, you were very right, it was described by Hellman initially. As recently as 1994, it is not even a very old disease. 1995 was the year I joined in medical oncology, in MBBS. So, it's not very old, very rightly said by everyone. But the point is, it has got a potentially curative treatment. I mean, that is one thing which is very, very seen. This is what was discussed at ABC conferences, Lisbon, ABC 6. And when they said oligometastatic disease is defined as a low volume metastatic disease with, up to 5 in number, not necessarily in the same or other organs and potentially amenable for local treatment, aimed at achieving a complete remission status. So, that is what the definition of oligometastatic CA breast is. And I think everybody by and large agrees to this. So let me start with the radiation oncologist, Dr. Sandeep and Dr. Lucy. Then after that, are you a believer in the concept of oligometastatic CA breast? And for the radiation and surgeon oncologist, I am going to put your answers to SWOT. We are going to discuss the data threadbare. So please mark your words very carefully.
Yeah, definitely. Hello everyone. Definitely I am a believer in the concept of oligometastasis. I cannot deny that. But fantastic. Again, as you said, it's a complicated thing. We have to see many aspects. It's not the number only. We have to see the sites, the volume of the disease, the molecular pathology of the breast cancer we are dealing with. So again, I am a believer.
Dr. Sandeep, you are a believer, and are you a believer in the data also? You are a believer in the data that adding loco-regional and or surgical thing will improve the overall survival. You are a believer in that data also. I just want a yes or no. Dr. Ravi Patnaik is smiling away to glory and said, don't fall into this trap. This guy is going to, have it. Yes, Dr. Sandeep.
Yeah, definitely. We don't have any robust data as of now. There are few randomized trials. I think one in India we have conducted. There are few SABR studies
Fantastic, Dr. Sandeep. I just wanted to know whether you are a believer or not. So you are a believer. Okay, fantastic.
Yes,
Dr. Lucy,
yes,
believer or not?
I would like to second Dr. Sandeep. Now, as the survival of CA breast is on the rise, and we are actually yesterday also in my OPD, I am actually seeing so many cases of oligometastatic CA breast, and I think it's a good way forward, to use local radiation therapies for such patients. I am strongly
Fantastic.
a believer of this concept.
You are a strong believer of this concept. So, two radiation oncologists, people say yes. Dr. Dilip, surgeon, believer in the concept of oligometastatic CA breast, that some amount of loco-regional therapy should be included.
Can I
Dr.
answer?
Dilip? Yes, please.
Yeah, I am Dr. Dilip Kar, surgical oncologist. Actually, if you tell me, are you a believer? Yes, I have to believe right now. But the way the molecular genetics is progressing, whether we are in the state of oligometastatic or whether we are in the intermediate state of developing a future multicentric metastatic disease, that is again a confusion.
So we have two believers. We have one doubter right now. From surgeonic, from a very gross loco-regional disease, we want to look at the molecular markers. Fantastic. Now let me go to the medical oncologist, Dr. Ajay.
Yeah, I am firm believer in oligometastatic disease.
Okay.
Is curable because we always try to give best treatment, and whenever it is possible, our intent should be curative.
Fantastic. So Dr. Ajay, I will start with you first. We all said, the survival of a breast cancer is increasing. You are a believer in the concept of oligometastatic CA breast because of improvement in systemic therapies, or you are a believer in the concept of oligometastatic CA breast because you want to incorporate loco-regional therapy. So, do you believe that only systemic therapies can cure oligometastatic CA breast? So, let's start with the medical oncologist first. You are a believer in the concept of oligometastatic breast because of improvement in systemic therapies, or you will like to add a loco-regional therapy there?
So there is a lot of improvement with the systemic drugs, and we can control the disease. So it is not single modality medical oncology, it is a teamwork which works, and definitely radiation oncologists and our surgical colleague, they have key role in management of oligomets.
Fantastic. So I think this is what was echoed in the ABC conference Lisbon also, where 90% people felt that, low metastatic disease, we can include a complete remission and a long survival. That is what was said in the conference also, and everybody believed in that. Now let us talk about, let's come to the, I'll come to the medical oncology later. We'll start with the surgery. Surgery is the oldest oncology branch. So I will just show you two slides here. And this was some randomized trials which have been conducted in patients with oligometastatic CA breast. The best of them, the first of them being the Tata Memorial trial, in which the surgery was done after systemic therapy. The other Turkish trial, and it was done before the systemic therapy. Again, so after the first thing is whether we should give systemic therapy once or we should give local therapy once. And I will just like to show here, if you see all the data here, the survival in Tata Memorial trial was 19 versus 21 months. In the other Turkish trial, 46 versus 38, 55 versus 53, 71 versus 65. So Dr. Dilip, the point is this a heartbreak for you as a surgeon that addition of surgery in oligometastatic CA breast has not consistently led to an increase in overall survival? See, there are two things. One, there is a development of metastatic of systemic therapies which are leading to increased survival in CA breast, polymetastatic as well as oligometastatic. Now, should you include a surgery or a loco-regional treatment to it is my question. Do you think it's surgery contributing to it? Dr. Dilip?
Can you repeat the question again, please? It is very cool.
So
let me take up the question. In a oligometastatic disease, can I take the disease with the oligometastatic simultaneously?
My question is, do you think that the long-term control or cure in oligometastatic CA breast is because of the addition of loco-regional therapies, or it is just the systemic therapies which are playing this huge part?
Yeah. The data, whatever the data till now, and for the study still now, ongoing study still now, it is clear-cut evident that addition of systemic therapy with the loco-regional therapy improve the overall survival and certain subset of patients, and the definitive PFS has been increased. So I will suggest systemic therapy plus loco-regional ablative therapy simultaneously in a oligometastatic disease which is amenable to curable.
Dr. Dilip, but the data that I am showing you over here, the Tata Memorial data and the ECOG data and the other trials data does not conclusively show. I mean, so there are small number of trials which are there, but there is no clear-cut one data which has basically shown that the addition of surgery in stage 4 disease has led to an improvement in the overall survival. There are some small studies which are there. Now, let me go to the medical oncologist on this. Dr. Ajay, if you are there, do you think the addition of surgery somewhere down the line is an important point in curing these people of disease? And if yes, which other patients you will try to include?
Sir, we are discussing about surgery of metastatic site.
We are talking about surgery for the local site as well as surgery or radiation therapy for the metastatic site. So you will have to include both, right, if you want to cure these patients.
So if a patient is having oligomets, then systemic control becomes very important. So first I will treat with systemic therapy. Then I will see the response. If there is response, then I will definitely go for surgery.
Okay. Although the data for that is what I'm trying to show, and that is what I'm trying to stir up a debate. The data for that, we like to believe in ER positive, HER2 negative disease, has an indolent disease and all. But even in the Tata Memorial trial, in other trials, there was no conclusive benefit of adding surgery in the stage 4 disease. That is one. Now, let me turn my attention towards the radiation oncology colleagues. And this is the data that they show left, right, and center about the Sabar-Comet study. And they basically show that for the breast cancer patients, there was an OS in HR of was 0.77 and the PFS of HR was 0.53. For the uninitiated, Sabar was a trial in which they gave, up to 5 metastatic sites were included, and they gave radiotherapy to all the possible metastatic sites. It was taken across all the tumors, but in the breast cancer, this was the data 28 versus 53 months was a fantastic survival. What radiation oncologists, and this then basically was fantastic. Unfortunately, this year in ASCO 2022, NRG BR002 trial was presented, in which oligometastatic CA breast with a controlled loco-regional disease and less than 4 metastases, more than 12 months without progression. So that's an ideal patient that you actually have. That is, patient has a controlled loco-regional disease, less than 4 metastases, more than 12 months of therapy without progression. These people were then randomized into symptom-based therapy versus total ablation of all the metastases. And unfortunately, the PFS and overall survival was absolutely similar. So there was no benefit of adding a loco-regional therapy as far as the NRG BR002. Now we are doing Sabar-Comet 4, we are doing Sabar-Comet 10 studies, the data of them is awaited. So I would like to ask Dr. Lucy Patnaik and Dr. Sandeep Barik opinion about their interpretation about the NRG BR002 and the Sabar-Comet data.
You see, Saber Comet, they accrued patients from all sides, from breast, prostate, lungs, so all the sides, out of which breast patients were the maximum. And the results of Saber was in breast cancer oligometastatic using stereoablative radiotherapy was very, very encouraging. That was unfortunately not carried forward by NRG, but there are several other meta-analysis conducted by the EORTC group, the Netherlands and the other 10 countries, the 10 studies, randomized control trials, which have published data in the EORTC. They have again showed that Saber provides an attractive, non-invasive modality, minimizing the toxicity of surgery in oligometastasis. So we have an attractive tool which minimizes your surgical morbidity, and it provides the similar efficacy. So we have a tool in hand which has to be utilized, but in a select group of patients who have responded well to prior systemic therapy. Sandeep?
Okay, Dr. Sandeep, if you have a point.
Yeah, Even with this data also, I am still a believer with giving local RT. Having said that, we have to specify, we need more such RCTs so that we find out which actual subset is responding and which we have to give and which we have to go ahead with only with systemic therapy.
True that. I think the data which, this is the data which slides which I've copied from ESMO 2022, which was held in Paris. And there was a live discussion after that. And the first question which was asked to everybody over there is, in spite of so many negative trials, why do we still want to conduct trials? I think the point here is it's complicated. That is why I started started my slides with, we do want to believe as oncologists, we do want to believe as oncologists, as patients that, we can get a cure. However, robust data to the addition of surgery and radiotherapy to systemic therapy is actually lacking. As Dr. Dr. Lucy said, is very attractive, minimally invasive things and all, but the robust data of increasing that survival across good 2, 3, 4 randomized conducted trials is actually lacking. However, I still think we all, in spite of all this data, everybody is a believer and we do want to add systemic therapy to it. So let's just forget about that. Let's just go to this. I think we just have 5 more minutes. There was this concept about 5 lesions. This was another data which was presented which said, how did you come at the 5 number? The less the better. Maybe if you have less than 3 mets, so this was an optimal definition of OMD, that why do you even want to have a 5 lesions? Maybe the 3 lesions which can have a better survival. So we will just go to maybe it's the lesser the better basically. So I'll just come to this case. It's a 58-year-old female diagnosed at CA breast. A PET scan was done, and before you accuse the Delhiwalas of doing more pollution by doing more PET CT scans, it was already done at Bhubaneswar. It's a right breast mass with the axillary lymphadenopathy with metabolic active disease at the L1 vertebrae. So that's the PET scan which shows it's a 58-year-old female. My question to the nuclear medicine personnel over here is, if in Dr. Saroj Sahu, with L1 lesion, metabolic active disease at L1 vertebrae, will you advocate, with how much surety can you say that this disease is going to be metastatic or something? And for the clinicians, do you want to do a biopsy of this lesion before confirming it's the only site of disease? So Dr. Saroj Sahu first.
Hello sir. Actually not required, because for distant mets sensitivity and specificity of the PET is more than 90%. So I don't think it is required to do biopsy. Straight away go to
Dr. Dilip, sir, if this disease turns out to be, tubercular or something else, we can go ahead and do surgery. We can limit the amount of chemotherapy, hormone therapy and stuff like that. Will you not like to be totally sure?
The answer to your question is single point, not required. PET CT. I won't go further.
Oh, don't do a PET CT scan. Fantastic. Sir, ab to ho gaya na. Somebody has done a PET CT scan. What to do now? That's why I wrote Spurs Center. The organizers have done it, sir. So just in case it has been done, sir, what will you do now? Dr. Dilip?
Sorry, sir, can you repeat that? We couldn't hear.
Yeah, so I am saying now the PET scan has been done. What to do now? Unfortunately, it has been done. You can't help it now. It has been done. What to do now? Will you want to confirm? Will you want to do an MRI of the spine just to confirm it by second imaging modality?
Okay. If you are asking me whether PET CT is available or not done, is not available.
It is done, sir. It is done, and unfortunately, the disease is not showing a L1 vertebra.
If the PET CT is done, you want to add more investigation on it over that?
Yes, I'm asking you this.
That only 2 investigations more than this for the bone lesion or the bone scan or PET MRI. But the bone scan sensitivity and specificity is again low than the PET CT. But PET MRI, again, I am a bit confused. So I won't go for that.
No, what I want to ask, sir, is that will you take this L1 lesion at its face value? Because you are turning a lady into a stage 4 disease. Maybe in the discussion front, the medical oncologist wants to give them a hormone therapy only, which will be a different treatment. So do you want to confirm? So let me go to Dr. Ajay Yadav. and ask him whether he wants to do a biopsy or do an MRI and confirm this disease.
Sir, if it is possible, then I would like to confirm that tissue diagnosis with biopsy.
Anything is possible, Dr. Ajay. You just have to name it. Radiation oncology. Dr. Lucy wants to ask something.
Yes, I would actually like to add to this. If you are planning for a precision treatment, for example, if you are planning for SBRT in this patient, I would definitely go for a biopsy, because in SBRT, for a curative procedure, if I go for 20 gray single fraction without a biopsy, I don't think the workup will be good enough. So even if the PET CT says suggestive of metastasis, and the next line of treatment is a curative stereotactic, body radiotherapy or SABR, I'll recommend a biopsy.
Okay, I think I would tend to agree with you, Dr. Lucy, because the intent of treatment is going to be changed. So, at least we would like to confirm this by another imaging modality, or in the best case scenario, I would want to do a biopsy from the soft tissue component. So, Dr. Lucy, I'll come to you only, or let me go to Dr. Dilip. Dr. Dilip, the surgical lesion, the breast lesion is amenable to surgery, and radiotherapy, Dr. Lucy says you can give radiotherapy very nicely. So systemic therapy first or local therapy first? And does it depend on the ER/PR HER2/neu?
Systemic therapy first.
Systemic therapy first. Okay. The radiation oncologist, Dr. Sandeep.
Yeah, I agree with sir. We have systemic therapy first.
Systemic therapy. Medical oncology will be more than happy in giving you systemic therapy. And just in case you think your job sucks, just think about this guy in North Korea who is, at a shooting range target. Now, let me let me fire these questions to Dr. Ajay Yadav now. Dr. Ajay, you are the lone medical oncologist. So, choice of systemic therapy, if it was ER80, PR80, HER2/neu negative, do you want to start with the CDK4/6 inhibitors and AI, or you want to give chemo AC-Paclitaxel followed by surgery and stuff like that? How will you want to proceed?
So, no, not with the CDK4/6. We want quick response, and so chemotherapy will be the choice.
But why do you want quick response, Dr. Ajay? You have all the time in the world. Why do you want a response?
Because CDK4/6 can be used later in adjuvant setting. You can use.
Okay, the CDK4/6 you will want to give. So that's what my point was coming about confirming it was. If you confirm it, and just in case in 10% times it turns out to be negative, you can actually go ahead and do surgery and maybe do an oncotype and stuff like that. But I would agree with you, in a curative setting, only CDK4/6 inhibitors will be unlikely to cure this patient. Next one, Dr. Ajay, I'll take 2 more minutes. It's a triple negative, PDL1 is 60%. Choice of systemic treatment. Again, simple AC-Paclitaxel first, or you would like to add immunotherapy?
4 AC, 4 Paclitaxel.
You don't want to add immunotherapy?
No.
So that is what the oligo is, somewhere between the adjuvant and the curative setting. Okay. If it is a ER/PR negative, HER2/neu positive, would you like to give PTH or PTCH?
Oh, dual blockage with carboplatin, PTCH.
So you will like to treat with a curative intent of treatment. So, again, this just in case you thought, I think we're just running out of time, and just in case you thought your life sucked out of answering all these questions, there's no one right answer. And again, it is the biology of the treatment which will finally tell exactly where we are. So this is the treatment option for the patient. Oligometastatic is somewhere in between the polymetastatic and the curative setting. You can actually go either way. You can go this side, you can go this side actually. Can we cure a HER2/neu positive metastatic disease? This is what I wanted to show. It is not only dependent on ER/PR status. You have a 8-year survival of 40% in a HER2/neu positive metastatic CA breast. You have PFS of around 16%. So with a dual Perjeta and Taxol available, we can we cure a metastatic triple negative breast cancer also? Again, if you see, the PFS here and the Keynote 355, there are certain people which will do even better with the immunotherapy in triple negative breast cancer also. However, ER/PR positive with only CDK4/6 inhibitor is going to be a slightly different ball game altogether, because in this case, I firmly believe only hormones can give you a good quality of life, but they are cytostatic drugs. If you want to have a curative idea, you need to start your things in advance before only. So just to conclude, OMBC is a distinct entry. Cure is the aim for patients with oligometastatic CA breast. At present, there is conflicting data regarding the role of RT surgery. The more I read about it, the more I'm not convinced that we can actually curing these people out. We need more better people. The exact duration of treatment survival is not known. The biology of the disease should hold great value in discussing treatment options with the patient. A role of multidisciplinary is a must in managing OMBC, and your treatment decisions should be taken prior to starting the treatment and not after you have started the treatment. That's for me a team effort, and team efforts achieve miracles, and it's not a miracle which will help us in prolonging survival, but a team approach will help us in increasing the survival for these patients. With this, thank you, and I hand it back to the chairperson. Thank you all my panelists.
Thank you so much, Dr. Ullas, for that wonderful session. Perfect start to the day. I would request the chairpersons, Dr. Padmalaya ma'am and Dr. Ravi Patnaik, to give the closing comments for this session.
Thank you, Ullas. It was a great case to be discussed. I mean, the way you put it, actually you tried to put them in all kinds of trap, but it was good that most of our colleagues and my good friend Dr. Dilip was and Lucy, they were all vehemently answering you back. It's still a debate. I really agree to you that there is nothing right and wrong in here. We cannot look from prostate data or other data as an oligomet, which systemic disease, come whatever. It is basically the systemic treatment which should be the in thing. I still firmly believe that local treatment should only be kept if really required, where things don't happen. Like the age-old concept of there is a bleeding in the brain, want to give some kind of an hemostatic. That's where I can think about. And the molecular subsets is the main thing which decides on the further course of local treatment. A triple negative, whatever you do, it totally depends on the systemic treatment. A hormone positive may be a different ball game. So I think in a metastatic setup with all the data coming in, the role of systemic treatment cannot be debated, and the role of surgery and radiotherapy should be focally kept in only in conditions where you cannot give any more justification by systemic treatment. That's my thought. I know I would be cussed for that statement, but I think this is how we look at. It's not one case which depends. It's the stats cannot be blinded. That's how we have to look at. Thanks, Ullas.
Thank you, moderator and the panelists. That was a very interactive discussion, and it made many things clear also about oligometastatic breast cancer. The last word to say is oligometastatic disease has to be treated on a systemic basis, and local therapy has to be kept for the last. Thank you.
Thank you very much, ma'am. Thank you very much, the chairpersons, moderator, the panelists. I would request the chairpersons to please continue to chair for the further sessions as we proceed towards our next presentation by Dr. Chinmay Pani, the topic being redefining the management of HER2-neu early breast cancer.
It's a very interesting topic. Actually, it's one of the burning topic I can say now that since CDK4/6 have come into the act in metastatic breast, it is the main treatment for every hormone positive ABC HER2 negative. Can it be actually put forward in a setup where we are looking in an early breast cancer which are hormone positive? Because for time being, it was always the 7 years data, 5 years data of giving an AI, giving an OFS with TAM or OFS with an AI. Is EBIMA right now the choice which we can think about? So I have very good friends, Chinmay Pani and Jaideep, Saurav, all are good chums in this. So let's hear from the medical oncology what they are debating for. I know Jaideep will always be pro CDK. It's last time when we met, that time also he was pro-debating on CDK4/6 and metastatic some 3 years back. So I think it would be a good debate from people who have been treating and who have used it. So let's hear from the speakers, how they go about against and for. Chinmay, it's all yours.
Okay, is audible? Okay. Yeah. Thank you, Ravi Bhai, and thank you, Ullas sir, my respected chairpersons, esteemed delegates, my teachers, my colleagues, and students. So it's a privilege to see you, Ravi Bhai, in online after a long time. So my topic of discussion today is redefining the management of HER2 negative early breast cancer. How to change? So it's not changing. Sorry.
If I can.
Sorry for the technical inconvenience. So I'll be discussing on the context setting and the background, then role of BRCA mutation positivity in hormonal positive breast cancer, then targeting in BRCA mutation in early breast cancer, then summarize the things. Okay, so we all know that the breast cancer is the most common cancer worldwide, and 10% are, up to 10% are often metastatic, and 20 to 30% will recur. In the early breast cancer, they will recur, they are to the pool. And almost 9% with the HER2 negative breast disease are germinal BRCA mutant. And if you see the 2020 data, the localized disease attributes only about 30% of the disease burden in India, and but in US the number is quite high. So if you see the later on, they will 30% of it could be the metastatic disease. So the first and primary intent is to treat these patients in a better and in a more precise way to have the maximal outcome. So in early breast cancer, I will not go to the HER2 disease, just see the left side of the screen. In the luminal A and the luminal B, and if there is, after doing the local therapy, if there is a high risk of recurrence, if it is not, then go for endocrine therapy. If there is high risk of recurrence, then go for the chemotherapy. That's also the plan. And in the triple negative disease, go for neoadjuvant therapy with the chemotherapy. And then if there is no pathological complete response rate, then go for the adjuvant capecitabine as per the KTEX trial. So there are some changing landscape happen in the HER2 negative early breast cancer management of late. And you talk about the keynote 522, the pembro to chemo reduce the risk of suffering from events by 37% compared to that of placebo. The 3-year event-free survival was 84 vis-a-vis it is 76%. The Impassion 031, where the atezolizumab in combination with chemotherapy improved the pathological CR, that is in 57% versus the 41. And the Monarch E, the abemaciclib reduced the risk of invasive disease or death by 31% compared to that of placebo. And so also, the 2 negative trial by the Pallas and the Penelope, where palbociclib did not improve the outcome in the HER2 negative early breast cancer. And the KTEX, I told before, the adjuvant capecitabine reduced the risk of recurrence in the triple negative disease by the 30% in the disease-free survival 5-year is 74 versus the 67. So what next? So the patient with BRCA mutation early breast cancer is a distinct breast cancer population in the terms that they diagnose in a very younger age, then it has the higher grade than that of the sporadic tumor, and more CNS metastasis and more contralateral and the ipsilateral disease. Then, if we see the percentage of BRCA mutant, approximately 5 to 35% of breast cancer patients have the BRCA mutant. It is seen in the TNBC group and the hormonal positive and HER2 negative. It is the hormonal positive and HER2 positive. It is in hormonal positive and HER2 positive, it is very less germinal, and hormonal negative and HER2 positive disease is also less. So in HER2 positive group, the incidence of the BRCA mutation is less. In triple negative and the hormonal positive group, the incidence is high. And if we see the Indian data, one is from the All India Institute, and they show that the prevalence of the pathologist mutation in the breast cancer patient is higher in the Indian patient, and it is the South Indian data by the Arun Sasachalam and they finally conclude that the BRCA, though the number are small and most in the TNBC group, the BRCA mutations identify almost in 13.6 patients. So the data are available to suggest that 50 to 80% of individuals at the risk of having hereditary breast cancer never tested, as they do not meet the NCCN in evaluating criteria for the BRCA mutations. So we all know that in the early breast cancer setting, often knowledge of BRCA status may change the decision plan in and around the surgery and also the targeted event. So in the early breast cancer, knowing the BRCA mutation may change the outlook of the surgery. And in the adjuvant treatment, BRCA status informs whether we can add olaparib in the adjuvant setting or not. So question that whether the preoperative genetics testing impact the surgical decision, answer is yes. So there is more chances of the contralateral prophylactic surgery has happened when you know the BRCA mutation prior to go into the surgery. So this is the adjuvant Olympiad trial who I am talking about for 2 to 3 minutes. It's a phase 3 study of olaparib versus placebo at adjuvant treatment in high-risk germinal BRCA mutated HER2 negative breast cancer. These are basically the stage 2, stage 3 disease, HER2 negative disease, and both the TNBC and the hormonal positive patients are there. And in the they have two groups, one in the neoadjuvant group and the adjuvant group. In the neoadjuvant group, in the TNBC, the non-PCR group, or in the hormonal positive, those are non-PCR, or those who have the CPS plus EG score more than 3. I'll discuss about this in the latter slide. And in the adjuvant, where in the TNBC, those who are the PT2 or the N1, or those are hormonal positive with more than 4 lymph nodes. So they randomized 1:1 with olaparib 300 milligram BD up to the duration of 1 year versus placebo. The primary endpoint is the invasive disease-free survival, and the second endpoint is distant disease-free survival, overall survival, and the associated carriers and quality of life. So almost the 82% patients of the TNBC come to the high group, and 18% of the hormonal positive come to this high group. And detailedly clarifying, telling that the CPS, it is a clinical stage, the post-neoadjuvant pathological stage, and receptor status, that is ER stage, then grade of the tumor. And they have given a different scoring point. From the clinical stage, from the stage 2B score is 1, then stage 2B and 2A 1, and 3B and 3C score is 2. And in the pathological stage, up to the stage 2B is 1, then 3A, 3B and 3C, it's all 1, 1, 1. And the receptor status, if the ER is negative, the score is 1, and if it's a grade 3, the score is 1, so total score is 6. So, the patient with higher CPS and EG scores relapse earlier than with the lower score. This is by the various different trial in the DFS and also the breast cancer specific survival. Then if you see the Olympiad trial from olaparib versus the placebo, the patient populations, they are all 42 to 43 years of age. And the BRCA1 mutation seen in 71, the BRCA2 mutation in 28. And the two group were very well matched, I can say. and they're well balanced between the two groups. The adjuvant 50%, the new adjuvant also in the 49%. Then whether they have taken the platinum therapy, yes or no, and the hormonal positive patients are only 18, and the 81% are the TNBC group. Then they wanted to know about the invasive disease-free survival. The invasive disease-free survival in the 3-year data was 85 versus 71, and which is hazard ratio of 0.58, and there is incremental benefit of 8.8, and which gives the sustained benefit when they analyze on the 4-year, that is 82 versus 75, and with a difference of 7.3. So it's maintained and it is significant. And when they analyze the distant disease-free survival, and 3-year data 87 versus 80 with the incremental benefit of 7.1, and at 4-year it gives a sustained benefit of 86 versus 79.1. Then they try to show the data of the overall survival. The overall survival was 89 versus 8.6, and the difference is 3.4%. In an adjuvant setting, up 3.4% in overall survival difference is highly remarkable, that I can say. And the incidence of the second primary breast cancer was halved, and the distant CNS recurrence was also low. The distant CNS recurrence was also low, and so also the ipsilateral recurrence and the local recurrence contralateral invasive disease. And the second primary, which is also a point of concern, the second primary in the ovarian has also reduced than that of the placebo arm. So they wanted to see whether this is subgroup analysis. They wanted to see whether the consistent benefit is seen across the all group or not. In the invasive disease survival, it is yes. Across the group, whether adjuvant, neoadjuvant, platinum or non-platinum, with respect to the hormonal status and BRCA status, and it is all consistent in the invasive disease survival in all group, and so also the distant disease survival, and so also the overall survival. And you all know that the olaparib we have reverse exposure to olaparib in the ovarian trial. So wanted to see the compliance and how they are taking the treatment and how they relapse, how they respond and tolerate and adverse effect. The 70% patient completed the treatment according to the protocol, and there is 25%, there is dose reductions happen in around 18 to 20% patient, the dose reductions happen, and the 10% patient discontinued due to the adverse event. And the adverse events were mild and moderate in the olaparib arm, and the adverse event of special significance like that of MDS and AML, that is 0.2 and 0.3, is not increased, and the pneumonitis is 0.2 and 0.3 is not increased, and the new primary malignancy incidence has also reduced, that is 2.3 vis-a-vis 4. So the special adverse effect of interest like that of the MDS and AML has not increased. So, and mostly the adverse event that we see, that is in comparison to the other trial of olaparib, that is consistent, like that of the nausea, fatigue, anemia, vomiting, headache, and diarrhea, and so forth and so on. So another important part is that the blood transfusion frequency, they have analyzed the blood transfusion frequency is not more, and most of the patients required only one blood transfusion, and they analyzed the quality of life. And the quality of life for those patients with neoadjuvant therapy and adjuvant therapy, the quality of life is maintained. The changes in fatigue severity has not changed the fatigue severity, and there is clinically meaningful difference in nausea and vomiting with the placebo, and was small and reserved with the cessations of the therapy. Though there is a little bit of nausea and vomiting issue was there, but that was resolved, and after the treatment is cessation for some time. There is no clinically meaningful difference between the olaparib placebo in physical and emotional functioning when they analyze. So if you see the targeted treatment in the early breast cancer, that has actually an impact of invasive disease survival and overall survival. and we analyze the data, there is only two. One is the trastuzumab, where there is a evidence, there is concrete level on evidence of the increase in the disease-free survival, invasive disease-free survival, and also overall survival. And so also the olaparib data, there is incremental benefit in the disease-free survival and also the overall survival. So the algorithm in the high risk HER2 negative early breast cancer, if it is the triple negative breast cancer, and if it is BRCA mutant, then adjuvant olaparib has a benefit. And if it is in HER2 positive and hormonal positive and HER2 negative and BRCA mutation, then you can give adjuvant olaparib for 1 year along with that of the endocrine therapy. So to conclude, so Olympia is the first to report the clinical benefit of a PARP inhibitor as an adjuvant treatment patient with a BRCA mutation, HER2 negative, high risk early breast cancer. With 9% more patient recurrence rate at 3 years, 1 year adjuvant olaparib significantly reduces the recurrence of death by 42% versus the placebo. And adjuvant olaparib resulted in the living longer with a 32% reduction in the risk of death. And more than 3.4% patient treated with olaparib arrive at 4 years. And consistent with the previous study, the safety profile of olaparib was limited and manageable. And tests for BRCA are diagnosis to inform treatment decisions and maximize the long-term outcome. So I think that's complete my presentation. So thank you very much.
Thanking Dr. Chinmay for that wonderful talk. Thank you, AstraZeneca. So, Dr. Ravi Patnaik, any comments, sir?
Can I ask you a question?
Me, myself?
Chinmay.
Dr. Chinmay, yeah.
Sir, yes, sir. I'm here.
Chinmay,
Audible.
what do you do? What do you do? You are hearing, audible?
Yes, sir.
Yeah. What do you do for a TNBC patient? I mean, this is my doubt. Like a TNBC patient who had gotten immunotherapy in the first hand, and then the patient has got a somatic BRCA positive. It's not a germline. And you know that around 3% will have a somatic mutation. And the patient has gotten a neoadjuvant immunotherapy drug, has got a CR. Would you be giving Createx, or will you be tempted by the germline data and give olaparib? If you are giving, whether it will be capecitabine first and then olaparib, or olaparib and then capecitabine?
So the first thing is that this is clinically locally advanced disease, sir?
Yeah, it's a locally advanced disease.
So locally advanced disease, you have given neoadjuvant immunotherapy along with chemotherapy. Then you got a pathological complete response?
Yeah, and it is a non-basal type.
Okay, it's a non-basal type. So you got a pathological complete response. So if you got a pathological complete response, then I won't go for the Createx. It's better to go for the olaparib. Because if pathological complete response is not there, then there is data of the Createx. If pathological complete response you have achieved, then option would be Createx. But there is a trial, yes.
Yeah, if there is a not a response.
Okay, so if
there is no pathological response.
If there is no pathological response, then we have and it is BRCA1 mutant positive, then actually we have no clarity of data whether to go for olaparib or to go for the Createx, because Createx also give us a marginal benefit of around 3 to 4%. Any opinion from your side, sir?
I agree, Chinmay. Actually, it's the interesting part here is the recent study which came in that in the Createx, the non-basal type did not do benefit by giving capecitabine, if you look at. So the catch is there. And the second catch here is somatic I'm still having a doubt whether in
Yes.
we should treat all germline and somatic like the prostate. We should treat like give olaparib, or is it only for the germline we should treat? Because the study is only for
Only
germline.
for the
They would
germline.
never say about somatic.
Somatic, yes. Thank you.
Thank you, Chinmay.
Yes, thank you, sir.
Thank you. Thank you very much. Before we proceed for the debate, I would request Dr. Ajay Yadav, our quiz master, to take up few interesting quiz questions to our audience.
So we have a good discussion on breast cancer. So we have 2 questions on breast cancer. The person who will answer, we have a prize for him. So, sir, we have 1 prize only. So who will answer first, the prize will go to him. So the first question is, according to Globocan 2025, most common cancer in women worldwide are, and these are the options. This is in decreasing order: breast, cervix, uterus, lung, stomach, breast, lung, uterus, colorectum, cervix, breast, colorectum, lung, cervix, uteri, and thyroid, breast, uterus, stomach, lung, and colorectum. No, 2 is wrong. Yes, ma'am.
Sir, option 1, breast, cervix, uterus,
Ma'am
lung,
rightly
stomach.
answered. 3 is right answer.
Dr. Lucy Patnaik. Clap, clap.
Second question, this is related to the previous talk. Which is true sentence about using CDK4/6 inhibitors in adjuvant setting in breast cancer? With palbociclib, there was no improvement in invasive disease-free survival rate in PALAS trial. In Monarch E trial, addition of abemaciclib lead to 30.4% reduction in the risk of invasive disease progression or death. In Penelope B, there was no invasive disease-free survival benefit observed with palbociclib. So, and fourth is all are true. All are true, right answer.
Number 4, all of this.
So we'll have these answers in the next debate.
Thank you, Dr.
So thank you, Dr. Ajay.
Thank you.
So over to Romila for the debate.
Yeah.
So Ravi, so for your information, Joydeep could not join because of his father's angio. So in fact, Dr. Bharat has joined.
Oh,
so
good,
thankfully, Bharat has accepted at the last moment.
Yeah.
And so Romila.
Thank you, Dr. Bharat, for agreeing to this in the last moment. And Dr. Bharat Rangarajan would be speaking in favor of giving CDK inhibitors in adjuvant setting in breast cancer. And against him will be spoken by Dr. Bhavesh Poladia, who is present here. So first we go ahead with Dr. Bharat, who would who would speak on a virtual platform. He is already with us.
Good morning. Am I audible?
Good morning. Yeah, you are.
Good morning. Hi, morning.
Hi. Thank you. It's nice to see Dr. Ravi after a very, very long time, at least virtually. And thanks to Ghanshyam for calling me today. So I'm presenting the 4 adjuvant CDK4/6 inhibitors in breast cancer. 1 second, the slides are not moving. So whatever we say, we know that patients who are on endocrine therapy for breast cancer in the adjuvant setting do relapse. And these relapses are definitely a function of the stage. So we have in stage 2 and stage 3 relapse only, stage 2, stage 3 settings. And even in stage 1, we see around the hazard for relapse is nearly 0.15%. So there is 10 to 15% chance of relapse and the maximum number of relapses happen in the first first 3 years. After that, the number of relapses go down, but we can see that even after 3 years, from the 4th year to the 10th year, and sometimes even up to the 15th year, there is a risk of relapse that continues. So how do we decrease these relapses in endocrine sensitive patients? There are multiple strategies, one of which is to add a second hormonal agent. So this is the efficacy and FDA approval for abemaciclib. So I will start my debate with the drug that is approved. So this, why did FDA approve this drug, abemaciclib, in combination with endocrine therapy? This was based on the Monarchy trial, where the primary endpoint was the IDFS, that is invasive disease-free survival, which was a primary endpoint, and the trial did meet its primary endpoint of improvement in the IDFS. So what are the other trials in this setting? The other trials, we have 3 more trials: the Penelope, the Palace, and the Natalie. The Penelope and the Palace trials have actually been negative trials without significant benefit in the IDFS. This question was asked as a quiz question in the last, after the last session. There was no IDFS benefit. But we must not look at these trials because these are highly different trials in terms of trial design. And we have an ongoing trial, Natalie, with the ribociclib, which is having a more interesting design and most likely will show the best benefit in the future times. So let's come to the Monarchy trial, which is, I think, the most important trial as far as this debate is concerned. This trial had 2 cohorts, one cohort of more than 4 positive axillary lymph nodes, or 1 to 3 nodes, which with a risk factor. The risk factor could be histological grade 3 tumor, or a tumor more than 5 centimeters, that's a T3 tumor, or it was stratified for a Ki67 more than 20 as per central testing, when it was not grade 3 or when the tumor size was less than 5 centimeter. It was randomized abemaciclib 150 milligrams twice a day for up to 2 years. The duration, please remember, was 2 years in this trial. And the control arm was endocrine therapy as per physician choice for 5 to 10 years. Extended hormones or 5 years of hormones. And what were the disease statistics? The disease statistics were fairly well balanced in all the groups. The number of lymph nodes positive was nearly 40%, 1 to 3 nodes, that is N1 in 40% of patients, and nearly 60% of patients had in both arms more than 4 nodes positive. So this trial actually had a large number of high-risk patients who either had more than 5 centimeter or high Ki67 or high movement positivity. Sorry. So what is the primary analysis? That is the IDFS. So it was planned at a median follow-up of 19.5 months, when 25.5% had completed 2 years of treatment and follow-up, while 58% were still on this treatment. And it clearly showed that there is a significant improvement in the IDFS in the patients who received abemaciclib along with endocrine therapy, with a number of events of 163 in the abemaciclib arms vis-a-vis 232 in the endocrine therapy alone arm. So the IDFS, the invasive disease-free survival, was significantly better, numerically better and significantly better, with a great hazard ratio of 0.713 favoring the abemaciclib arm at 2 years. Now, what about the secondary endpoint analysis based on distant relapse-free survival, which is on the left side, and the IDFS in high Ki67? There has been improvement in both these parameters. If you look at the high Ki67, the delta is even higher. There is a delta of nearly 4.5% difference in the high Ki67 arm, with 91.6% IDFS seen in the abemaciclib arm versus 87% in the endocrine therapy alone arm. The DFS also showed a robust difference of 3% between the 2 arms. This is a secondary endpoint, that is distant relapse-free survival. So metastasis even at early stage of 2-year follow-up was significantly better than the abemaciclib arm. So when we look at Monarchy, we find a 3.5% absolute improvement in 2-year IDFS. The improvement was nearly 4.2% when the Ki67 was high, and the absolute difference in 2-year IDFS of 2.8% is definitely significant in the and clinically meaningful in the in the clinic. Now, when we look at subgroups, there were no statistical interactions, and although there is some data regarding OS in the low key 67 arm. If you look at the entire trial, mostly almost all subsets of patients, regardless of number of nodes, histologic grade, primary tumor size, prior chemotherapy, menopausal status, age, and tumor size favored the abemaciclib arm. Now, coming to the next trial, the Natalie. The Natalie has a very unique design. First of all, the Natalie has allows both men and women, which is very important because there are men with this disease. Ribociclib dose has been reduced to 400 milligrams so that there will be fewer breaks, because breaks may be associated with poorer outcomes. So to ensure that there are no neutropenias, no breaks in country, and more consistent therapy, ribociclib is at 400 milligram, 3 weeks on and 1 week off for a period of 3 years. This is 1 more year more than the monarchy. So what makes the Natalie promising are these parameters, and that Natalie is yet to be published. Now we must remember that the 3 arms we see mixed results. Pallas and Penelope are negative, whereas monarchy is positive. What are the high risk? What are the reasons? Most likely there were more higher risk patients in monarchy, and there was a large rate of discontinuation in Pallas and Penelope, and the duration of therapy. More than anything, abemaciclib is a much more stronger and more pan CDK inhibitors. That is, there is more than CDK4/6. It has got 3, 9, and more off-target inhibitions, which actually benefit patients and are more important, in obeying the resistance to endocrine therapy. So we must not make comparisons between the 3 trials and say that we are negative, so we have to throw all the CDK4. Splatin are the same. They are not the same. We know in germ cell tumor, in lung cancer, so splatin is better. They may be same in ovary, but this is like, you should not cross compare between 2 different agents and say that all CDK4/6 inhibitors are out. CDK4/6 inhibitors are definitely an important form of therapy, and properly trialed. Even in the future, if we have a proper trial, with generic palbociclib coming with a different dose, maybe a lower dose, longer duration, we may see good significant benefits in a differently designed trial, even with palbociclib. But as of now, definitely monarchy shows benefit for abemaciclib. OS data in adjuvant breast cancer may take a decade to mature. And so we should not keep saying we have these WhatsApp group fights about OS data. OS data is immature. OS data is not negative as of now. It is immature. And we should not be waiting for the OS data to mature before we offer our patients the benefit of abemaciclib in endocrine positive women. Natalie, with a longer duration and better tolerated dose, may offer a new therapeutic opportunity. Thank you.
I request Dr. Bhavesh to kindly come on the stage to speak against the topic. Let's see how does he defend. And Dr. Ravi, we would request you to give the expert comment at the end of this, as Dr. Saurabh is not available, unfortunately. We would like to have your expert.
I also have a few rebuttal slides. Sorry to break in. I also have a few rebuttal slides at the end.
I'm sorry? Come again?
Yeah, Bharat, go ahead.
No, I said I have a few rebuttal slides after the session, after Bhavesh.
Saurabh is not there, is it?
Don't have Dr. Saurabh, sorry.
I think Dr. Ghanshyam will do the final judging and special comment.
Maybe Dr. Ravi is the right person.
I'll request Dr. Ghanshyam to do that. So, good morning to one and all, and I'm Dr. Bhavesh. At the outset, I would like to thank Dr. Ghanshyam for giving me this opportunity. So, let's jump to the topic, and warm welcome from my center, that's Thangam Cancer Center in Namakkal, Tamil Nadu. Okay, so I'll be talking actually against the motion. So I would not be saying to be the proponent of CDK4/6 in this setting. That's the adjuvant setting of early breast cancers, ER/PR positive. So Dr. Bharat has done his fight. Let me fight him back. And finally, instead of Dr. Saurav, I think Dr. Ghanshyam Biswas will give the final word, what he thinks. So we have been seeing this since last 20 years till 2020. Before that, the tamoxifen, AIs, ovarian suppression, extended 5 years, 7 years, 10 years of hormone therapy and chemotherapy. This all has shown improvement in the overall survival. So what was the use of doing this CDK4/6 inhibitor? I am actually thinking in that aspect. Just because something is working in metastatic setting, it is not necessary that it is going to work in adjuvant and neoadjuvant setting. And this is a typical example that we are focusing only on the endocrine resistant patients that will be relapsing in the first 2 years of their endocrine maintenance. And we can see that different trials have already been trying to answer that, but unfortunately out of 3 available trials, 2 are negative. So I don't know what to say. I mean, here itself it is in majority, definitely it is a negative trial, and probably CD4/6 inhibitors should not be used at all. So we can see the first trial, which is a PALAS trial, and it actually included all stage 2 and stage 3 patients, hormone positive patients, and palbociclib was given with endocrine therapy for 2 years versus the standard of care. And what happened? Dr. Ghanshyam, can you see 2 lines here? I can see only 1 line, I think. So there is hardly any difference. Dr. Bharat, so Dr. Bharat, maybe you can use your magnifying lens. Probably you will find some difference in between. I cannot find any difference. So it's actually of no benefit at all to use a CDK4/6 inhibitor, including both IDFS as well as DRFS. PALAS did not include any clinical criteria or divide into high or low risk. So you can see in the subgroup analysis again, there is no difference at all in both low or high risk clinical groups. Coming to the monarchy, what Dr. Bharat was talking with so much passion, but you can see that the shift has been multiple times, starting from the intention to treat, coming to cohort 1 and 2, and finally cohort 1. So it is actually you're torturing the data probably. So somehow if you keep torturing the data, it will come out with some result somehow. So this again, abemaciclib is being used for 2 years with endocrine therapy versus the standard of care. And here also we can see there is a very small difference in the IDFS at the end of 2 years. Even the updated is showing almost similar difference of 3 to 4%. But I just wanted to remind that monarchy trial wanted to see the IDFS at 5 years. So we are yet to see what happens at 5 years, and I'll probably predict what is going to happen at 5 years. So this is the data which Sir Dr. Bharat presented, and you can see how they have manipulated or shown the difference. You will see the Kaplan-Meier curve always starts with 0. Where it is starting, just see. It is starting at 70. Just to magnify the difference. Actually, that is not a major difference. It is a 3-4% difference, that also to a subgroup analysis, and they have manipulated the graph to show a big difference, a huge difference actually between the 2 modalities. Coming to the third trial, that is Phenilop B. Again, here palbociclib was used for 1 year, and again this is what I was going to come. This is the only trial which has a follow-up of more than 42 months. Median follow-up is 42 months, which is much higher than the other 2 trials, which is having less than 2 years of median follow-up. This is what probably is going to happen. You can see there is a difference which starts at the end of a year, maintained at 2 years, 3 years, but what happened at 4th year? It is actually almost crossing, and I think in 5th year, the standard of care is better than the intervention arm. So probably even monarchy is going to meet the same fate after 3 years, 4 years or 5 years. So I am not the proponent of CDK4/6 at all over here. Now something interesting, or everybody wants to know what is happening with Nutley. So Novartis people have been a little smart. They have actually selected a very high risk population, that is one. Second, the intervention is for 3 years, not 1 year, not 2 years. Probably they have understood that after giving 2 years, people are crossing over and they are actually becoming worse after 4 years and 5 years. So they want to give this therapy for 3 years. So let's see what happens. We don't know the data yet, but in future we'll have some data and we'll have clarity on the third molecule of CDK4/6 inhibitor. So this was about the efficacy, which is not very impressive according to me, and probably in future it may actually show that it is worse. Coming to the toxicity, we all know from our metastatic experience of metastatic breast cancer in hormone positive, abemaciclib is not a simple drug. It comes with a lot of toxicity, especially diarrhea, explosive diarrhea. And mind you, even in this adjuvant setting of Monarch E, there was one death because of diarrhea. Do you want a patient to die in adjuvant setting because of diarrhea? I don't think, nobody wants to accept that. So it's not a very simple drug to use. It comes with its own toxicity, and Dr. Bharat told about the discontinuation rate, and he nicely summed up both Palas and Penelope into one, but you can see the discontinuation rate was almost similar in Monarchy and Penelope B. It was definitely higher in Palas, but the other two trials were similar this thing. Even completion rate was almost similar. This is again a discordance at the year of 3 years DFS. How come the control arm is showing 83%, whereas in other two trials it is 88 and 77%. So the control arm should remain almost similar outcome, but it is not the way it should be. So there are multiple different questions. First is we have to understand what is high risk. Palas, people have been adherent to the regimen what was planned for. Abema is showing difference because of the separate molecule, but I think in metastatic setting all have almost same HR of almost 0.5. Duration will be matter, and we have many questions on this, and there are future trials which will address that. And coming to adjuvant PARP, I will not go into the detail because the lecture was taken previously, and this is the trial where it is showing improvement in overall survival, and which has remained persistently positive over a period of 3, 4 and beyond that. So my question to Dr. Bharat will be, if suppose in future or maybe in Monday a patient comes to you with early breast cancer for adjuvant setting and patient is germline BRCA mutated positive, what are you going to offer? Olaparib, abemaciclib, or maybe your patient is affording everything under the sun, a diamond merchant, and you want to maybe give combination of both olaparib and abemaciclib. I don't know what you are going to do. We are actually speaking about de-escalation of therapy in so many patients who are hormone positive. Even node positive patients, we are trying to de-escalate the therapy. And here we are talking about escalation of therapy without a proper biomarker. So the precision of evidence needed to practice precision medicine is always required. And this is the one where the RS score, it is a combination of both clinical as well as a genomic susceptibility. And this is a little combination of both the two and gives a better idea. So should we follow this or should we follow something which does not have a valid biomarker? So this is what has come. We want to de-escalate the therapy in patients, not to give chemotherapy. And here we want to give a CDK4/6 inhibitor, which is not easy. It's very toxic. So I'll stop here and I would ask Dr. Ghanshyam what he thinks about this.
So before the expert comment, Dr. Bharat had some slides to share. Okay. Some if I'm not mistaken, Dr. Bharat. You wanted
yes.
To, yeah.
So I am here. So the thing is, wonderful, overview of data by Bhavesh. But unfortunately, I think everybody, all of us are confused at the end of it. So let us understand one thing. We are talking about use of a specific agent. Now this slide he showed, yes, it starts at 70, but we have not, made the delta. The delta is very clear. It is 3.5% absolute improvement in IDFS. Now let's look at what this 3.5% is in breast cancer. Monarch OS data is immature, as he said. We agree with that. I am not arguing that, but let us look at data as it stands today. 2-3 things, some perspectives we have to have is, this slide he showed. What is the delta here when you switch from tamoxifen to AI? The delta is 3.6%. Wherever you start at 75 or 70, this is the delta that you get when you switch from tamoxifen to aromatase in postmenopausal. Let us look at soft in text 4% absolute improvement in DFS. This is what soft and text had, over exemestane and tamoxifen. And the absolute improvement in freedom from distance-free survival was only 2.1%. So these sort of deltas are, and there is no overall survival improvement when you look at exemestane and tamoxifen with OFS. So whenever or look at extended endocrine therapy, again it is 2 to 4% absolute DFS benefit. So what I wanted to say is incremental benefits in breast cancer has always been to the tune of 2 to 5%, whether it's even from chemotherapy in endocrine breast cancer. This is the magnitude that we see in terms of IDFS, in terms of DFS, in terms of OFS. This same magnitude is seen with abemaciclib, and so let's not take that data away. Throwing out the baby with the bathwater should not happen. The same magnitude that has been there, AI versus TAM, OFS versus no OFS, extended endocrine therapy, even chemotherapy in hormone positive, this is the benefit that we say. So evidence actually favors CDK4/6 inhibitors, and when I say CDK4/6 inhibitors, specifically abemaciclib, we should not confuse again and again metastatic breast cancer and early breast cancer. In metastatic breast cancer also, we know that abemaciclib is better. We know ribociclib is showing overall survival advantage in first line, whereas palbociclib is not shown. So we should not compare MBC and EBC. We should not compare palbociclib and abemaciclib with the data as the trial data shows today. Now, the cohort is not torturing the data. Cohort was pre-planned. So we have to, accept that data. As of now, we have to accept monarchy data for CDK4/6 inhibitors, which shows definitely DFS benefit and IDFS benefit for women. So the question is, it is giving a benefit to the patient to the tune of every other intervention that was seen in hormone positive breast cancer over the last 2 decades, over the last 20 years. So I think we have to go with it for now, go with abemaciclib for now. And lastly, he asked me about adjuvant PARP. Now the question is, adjuvant PARP actually works only for the GBRCA, which is, a very, very small percentage in HER2 hormone positive, less than 5%. Adjuvant PARP has more side effects than abemaciclib. And of course, it has not much benefit in the subset of hormone positive disease. Yeah, so with that, I will stop my rebuttal. Thank you.
We are running short of time. Sorry to interrupt. Now, I would request Dr. Ravi Patnaik to give his expert comment and conclude the session of debate.
Vishwas not there. Bhavesh wanted his, he already bought the expert, I think.
Dr. Ghanshyam, please.
Okay, I agree that both the speakers were tooth to nail kind of a thing, but the data has to be taken into account. The most important part of this whole, all the 3 drugs, if you look at, the recurrences happen in 2 years. The failure of Pallas and Penelope is because it was only for 1 year. So that is what you have to look at. You cannot, of course, say that this drug was failure, so all the CDK4/6 won't work for it. It's the same way as you say that nothing works adjuvant in renal cell carcinoma. It is not that Pembro works for that, but the other drug may not work. Other TKIs may not work. So somewhere down the lane, we have to look at this study that Abema had taken very specifically for 2 years, which is the period when there is a lot of recurrences which can happen. It also has looked at a high-risk group. It has not taken everyone. It has taken a high-risk group. These are the 2 things which I think should say that Abema has a benefit as an adjuvant. Second thing which we also have to look at, what patients are we looking at in our practice? Most of our patients are locally advanced breast cancer. No one comes with a stage 1 disease nowadays, irrespective of how much we try to screen and talk about. People still, we see a locally advanced breast cancer where we can get up to 1 to 3 lymph nodes. We have almost a T size of 5. Of course, there is a debate on the key 67 scoring between different labs. Some may score 2%, some may score 20%. So all taken into account, I as a clinician would think that if patient is affordable, patient can take it, or the healthcare system doesn't have a problem with it, a high-risk patient should be given the benefit of giving an adjuvant treatment with an CDK4/6. explaining about the side effects, explaining about the paucity of the data, and actually, as Bhavesh has spoken, that this is no long-term data has been given, but still we have to explain to the patient, because tomorrow a patient should not come back to you and say that you did not give me this option, that I could have taken abemaciclib or I could have taken the other drug. So I think, Bharat, I still will stick with you. Sorry, no offense. I will still stick with Bharat, that I would go with an adjuvant CDK4/6 in high risk group.
So thank you, Ravi. So I have a certain point. So there is a case for everybody in this country. And as you rightly said, most of our patients are locally advanced. So tomorrow morning, if I have a family member who has been unfortunately diagnosed with this subset of disease, and you know that in spite of a good biology, so there is a good chance of a recurrence. So there was nothing for those patients. So I think this data, though it has a positive impact in a high-risk population. So as you took an example of RCC, so we had a debate yesterday. Again, so there is a case for everybody. So RCC definitely on a high risk, so that you will use sunitinib or pembrolizumab. So there are a few patients who are going to benefit. So these are all come from a clinical trial. So I think, so both the other drugs have failed because their subset of patients were different. And coming to an abema, so now we have understanding this, all three drugs of the same class are not the same drug actually. So they have a class effect, but again, the responses, the way they are actually performing, and the toxicity. So we have talked about abemaciclib, diarrhea, but I'm using for last 1.5 years too now. So diarrhea is not a problem at all for our patients, I don't know. So most of the patients has taken loperamide, they are still to use these drugs. So our patients are definitely behaving different. So we are in a good time that so much of exciting things are happening in cancer, and that too especially in breast cancer. So I rest my case that, so there are a patient population who are going to be benefited. So both are right, because so we are talking about a country, so where we are moving into a government scheme, even if we have a high risk patients, so they won't be offered a free drug from the government. Thank you so much.
Thank you. Thank you, Dr. Viswas. We come to an end to this debate session. Next, we take up with the presentation of Dr. Chinmay Pani, Optimizing Therapy in HER2-positive breast cancer.
Hi, Chinmay.
Hi. Yes, sir.
Yeah.
I'm not able to see you. Okay. Good morning, everyone. Thanks, Dr. Ghanshyam, to give me the opportunity to speak about this topic. Thanks, Ravi Bhai, for moderation, waiting for a long time since early morning, and respected my all delegates who keeps trying to learn in the early morning. Thank you very much. So let me start the topic. So again, sure. Yes. So we all know that trastuzumab and pertuzumab has definitely transformed the treatment landscape and the standard of care in the HER2-positive breast cancer in 3 different settings. In the neoadjuvant, by the Neosphere data, the addition of PER2 to trastuzumab plus chemotherapy improved the pathological complete response from 31 to 49%. In the adjuvant trial in the high-risk breast cancer, that is additions of pertuzumab plus trastuzumab plus chemo reduce the risk of recurrence or death by 23% compared to that of the placebo. And in the nodal positivity, it has the recurrence rate has been more reduced. In the metastatic, the landmark trial by the Cleopatra, the addition of PER2 plus TAS2 plus chemotherapy increases the progression-free survival from 12.4 to 18.5 months versus the placebo, and the overall survival is also significantly improved. So if we look into the treatment paradigm in the newly diagnosed HER2 positive breast cancer, if it is T1 and N0, and post-operative, if there is a nodal positive, then there is definitely a role of trastuzumab plus HER2. And if it is the high risk early disease, that means the tumor is more than 2 centimeter and the nodal positivity, and post neoadjuvant chemotherapy, you do a surgery. And if there is complete pathological response, then go for trastuzumab plus HER2 as a maintenance. If there is residual disease, then go for the TDM1 as per the Catherine data. So where the topic come, see, as these patients are in long term for 1 year, and they require the infusion of trastuzumab and HER2, and it creates a unique challenge. The unique challenge of the long infusion and observation time and congestions at the clinic, because they are frequent comer to the hospital, and the challenges in improving the resources utilizations, and the placement and maintenance of a indwelling catheter as a former chemo port of the PICC line, and challenges in the venous access in some other form. So here comes the FESCO. Is pertuzumab, trastuzumab easy to go? Easy to go. This is the first formulation of oncology to combine 2 monoclonal antibody pertu plus TAS2 in 1 vial for the subcutaneous injection for each of the patient. This contains the 2 antibody. It is formulated along with recombinant human hyaluronidase, and it is a ready to use, gives in a subcutaneous dose in a very short time span of 5 to 8 minutes. So, so we all know there is a synergistic addition of the PER2 plus TAS2, and that is due to the dual HER2 blockade. And so additions of hyaluronase is an endoglycosidase used to increase the dispersion and absorptions of the co-administered drug when administered subcutaneously. So when actually we're giving it subcutaneous, it allows to give the subcutaneous dose more than 1 ml higher volume, and after the subcutaneous administration, the architecture of the skin is deformed within 1 to 2 days due to rapid clearance of, and this is due to the recombinant hyaluronidase. And this, so it increases turnover, so the skin comes to the normal very quickly. And this is how the pictures come. If you give the injection before and after, and without recombinant hyaluronidase, it will be swollen. And if you give with hyaluronidase, and it is actually dispersed, and within after 2 days, it becomes normal. So what is does the pharma, we have a lot of questions in our mind. Does the pharmacokinetic the same? Does the equivalence has been same? And does the patient preference and the healthcare preference has been same? So that's the reason we have a lot of trial. So finding and confirming the dose of PER2 and pertuzumab and trastuzumab within the FESCO. Then FESCO, the recommended dose is the pertuzumab dose is 1200 and the trastuzumab dose is the 600, that's the loading dose, and the maintenance is both are in the 600 milligram. And the pharmacokinetic efficacy and safety preferences, we have 2 trials. One is Frederica, published in the San Antonio, and another is Francicia, and it is in the ESMO 2020. So come to the dose finding study. It's a very complex, I will not go into the detail of the study. So initially the phase 1B, then come into the phase 2 trial, where there are 3 cohorts. So one cohort, the pertuzumab alone, and they have used separately. The other cohort is the pertuzumab and herceptin, they are co-administered. And the third cohort is pertuzumab plus trastuzumab in the fixed dose combination. And they initially find the dose defining trial, and they got the dose defining trial, and that's how the loading dose and the maintenance dose has been designed. And this is, and whether they have been co-administered or they mixed in the fixed dose combination, and that's the phase 2 trial. And it summarized that the selected loading dose of 1200 milligram of PER2 subcutaneously and the maintenance dose of 600 milligram of PER2 subcutaneous to use in the FESCO. And the pharmacokinetic data also favors this, and this dose finding process used for subcutaneous dose of pertuzumab is similar to those of successfully drug, that is subcutaneous MabThera and subcutaneous Herceptin. And safety profile, there is no new safety signal observed. So come to the phase 3 data of the Frederica, which is a non-inferiority study assessing the pharmacokinetic efficacy and safety of the IV versus the subcutaneous combination. There's 2-arm study where the chemotherapy arm is well balanced. Then later on with chemotherapy, they have given IV formulation vis-a-vis the subcutaneous formulation. Then they go ahead with surgery, then go ahead with the maintenance, which is a proper of what you do in a routine clinical practice. The primary endpoint was the non-inferiority of cycle 7, but that is pre-dose 8, cycle 8, the serum concentrations of the pertuzumab, that is CTRA. And the secondary endpoint was the serum concentrations for septin, that is in the CTRA before the 8 cycle. And the PK endpoint, the key focus, and what is the CTRA? This is a TRA plasma serum drug concentration, the concentration measured at the end of the dosing interval, and which actually associated with the clinical outcome. And the AUC also represent the clinical outcome, that all we know. And the Cmax actually the maximum drug level concentration, which actually doesn't matter much in the clinical outcome. So, and when they find out the CTRA concentration of serum concentration TRA of the pertuzumab in the both group, it is 72.4 versus 88.8. Actually, it is a little bit high. And the second endpoint of the Herceptin data is almost 43 versus the 57.5. It's a little bit high. So the second was whether the response was same or not. The pathological complete response rate was 59 versus 59, and when they analyze into the body mass index, the pathological complete response rate, and in the normal individual, it is same, and the other one, it is comparable in the overweight and the obese. With the little bit change in the obese, and in the underweight there is a little bit difference in the underweight, but in the normal individuals and the overweight and the obese, so almost it is comparable. Then the safety profile, there is comparable to the IV with the subcutaneous formulations. The incidence of adverse effect of the event, that is the diarrhea, is comparable. The cardiac was a special interest that we have, and it is 16 versus 16.5, both are almost same. And so there is no significant or meaningful difference in the cardiac safety between these two by the incidence of the heart failure or the LV ventricular ejection fraction decline or the secondary adverse cardiac event. They're all comparable between the two. And so the subcutaneous dose as non-inferior pharmacokinetic versus the pertuzumab plus IV with the comparable efficacy and safety that this data shows. Then finally, so does the patient preferences, what is the objective in the point of the patient, in the point of the healthcare provider, and in the point of the healthcare utilization and the cost? So this Francisca study, the phase 2 study, assessing the patient preferences, this is a crossover post-neoadjuvant or the adjuvant therapy. When they go ahead with maintenance, they try to cross over the IV to subcutaneous and the subcutaneous to IV, and they follow the treatment plan. And the primary objective of the patient preferences to the fixed dose combination in the subcutaneous. So finally, they find it out. The patient preferences was fairly strong for the majority of the patient. 93% patients prefer the subcutaneous, and the main reason of the subcutaneous preferences that they have less time in the clinic and more comfortable in the administration. It's the ease of administration is better. And then the satisfaction group, the satisfaction level of the patients was very satisfied and satisfied in the subcutaneous group than that in the IV arm. So, and treatment has no impact on the patient healthcare speaking time. They try to analyze whether the patient is talking to the healthcare professional more, and the most patients had more than enough time to talk with the healthcare providers and during their treatment time period. And majority of healthcare provider also felt the switching from IV to subcutaneous because of it saves time and the less resources as required. So it was because it's the quickest and less resource uses and result in the less drug wastage, because it comes with a 15 ml vial and 10 ml vial. Usually there is no need to throw or no headache of storage of the product. And the adverse event before and after switching are similar with no new safety signal. So 85 patient, to conclude, it has a high patient satisfaction rate, high the healthcare perception in the time of the, in the form of the time and the resource impact, and from the safety point of view, it is also quite, quite safe. So what are the practical considerations when we are giving the subcutaneous in the real world? So the first point is that the patient and the caregiver should be comfortable, because you are giving subcutaneous over the period of 5 to 8 minutes. You have to be, the patient should be in a stable position, and the healthcare provider who is giving the subcutaneous should be also in a comfortable position. And the second was that it should not be given in the abdomen, should be given in the thigh. And so do not split the doses or the syringes between the two sides. It should be given the one side at a time. And the new injection site should be given, it should be 2.5 centimeter apart from the previous site. And the chosen area which is having healthy skin as per the guideline of the any subcutaneous regimen. And you should remember or record the site so that you will not reinfuse at the same site again. And you should give in a proper position, that the 30-degree angulation of the skin, and pinch the skin and put in the injection in 30-degree angulation, so that the space could be created to accommodate the volume of 10 ml in the maintenance and the 15 ml in the induction regimen. And keep the patient on observations for 30 minutes, and that will be perfectly fine. So 5 to 8 minutes of injection and preparation time of 5 to 7 minutes total. And then you give the injection, then you allow the patient for 30 minutes. So total duration will be 40-45 minutes, maybe 1 hour. So and it can be given not only in the daycare but also in the OPD space, and that is also convenient for treat and convenient for the patient and both for the healthcare provider. So it actually means a grade for the healthcare provider, and so also for the patient, and it provides the benefit in the time and reductions of the patient and the healthcare burden, and so also in the cost, because shorter time of observations of the FESCO reduces the burden of the patient and the caregivers and the provider, and it has less invasive administration with single subcutaneous injections and not like the IV, and fixed dose combination may help to reduce the risk of the dosing error. So there is no questions of the dosing error, because everything comes in the fixed dose combination, and reduces the time required for the drug preparations and administration, and also there is less chance of the storage of the drug, and no utility for putting the PIC saline or the chemoport for a long time, and so also it has good oncological safety. And so also there is no new safety signal. And so to summarize, that FESCO is the first formulations in oncology to combine 2 monoclonal antibody per 2 and trastuzumab in one vial for subcutaneous injection, and offer a faster and less invasive method of administration compared to that of the IV formulation. It has the serum concentrations of the pertuzumab and trastuzumab before 8 cycles, means after the completion of the 7th cycle was similar, and the pathological complete response rate was identical between the intent to treat population in the two groups. And the majority of the patient preferred the subcutaneous formulation, and regardless of sequencing, and the majority of healthcare providers also wanted to switch from the IV formulation to the subcutaneous formulations, and that is the reason it is now approved both for the FDA and the EMA approved for the same indications in HER2 positive advanced breast cancer or high risk breast cancer, and without any combinations of chemotherapy that are providing. Thank you very much.
Presented Dr. Chinmay. Any questions? So can we please proceed to our next presentation by Dr. Chandrakant, MV. He'll speak about fixed dose combination in breast cancer.
So, good morning everyone. So, I would thank Dr. Gansham for this opportunity and for inviting me and having me here. So in this coming 10-15 minutes, I will speak on a molecule called COMCAPC. You can go to the presentation. So COMCAPC is an Indian molecule where there is a fixed dose combination of capecitabine and cyclophosphamide together. This is basically addressed in breast cancer. So this is, the name is COMCAPC. It is combination of capecitabine and oral cyclophosphamide. So we will look how this idea was, it was how idealized and how it got matured and what is the data we have and where best we can place it. So in the meantime, they present, I will say about this molecule. So when you are combining two drugs, so there are some basics that you need to follow. Yeah. Okay. Yeah. So this will be the sequence of my presentation. I'll say how COMCAPC was initialized and then how it came through the research, what are the trials we have, what is the evidence, and then I'll go through why should we be combining capecitabine and cyclophosphamide, why not other chemotherapy partner, and what is this metronomic therapy, and then what is the existing data and what are the challenges we have in combination, and what is the clinical study data we have, phase 2-3 results, and what are the advantages of this combination and what are the final conclusions we can have. So we all know metastatic breast cancer, especially if you look into the triple negative breast cancer where we are struggling to have a target, except those 10%, 15% patients where we have a PARP inhibition being there. Otherwise, to have a target in triple negative is difficult, but as such metastatic breast cancer, if you look into chemotherapy, we have anthracycline and taxane. After that, after they become resistant, we have hardly any molecules that bring significant impact. So this is the journey of data for COMCAPC you have from 2007, and then the SWOG metronomic data, and then comes the Penelope data, and then comes the INTAS research trial that got its approval. So capecitabine is a preferred drug. This is because it's an oral drug. It has good single agent activity. And we have seen capecitabine combined with other chemotherapy drugs. For example, platinum, 5-FU. So it is known for combining with other drugs. Similarly, cyclophosphamide, there are good data. So therefore, as it has a good single agent activity, it is oral drug, its dose can be easily modified. For these reasons, capecitabine is sort of an ideal drug to look at partnering with other drugs. So if you look into why cyclophosphamide is the partner chemotherapeutic drug and why not others, this is the slide that actually addresses why cyclophosphamide was used as a combination. So if you look into the way capecitabine acts, capecitabine is sort of a prodrug for 5-FU. It gets into the, it gets converted to the active metabolites, that is 5-DFUR and 5-FU. So this particular conversion from 5-DFUR to 5-FU is basically inside the cancer cell, and it is mediated by an enzyme thymidine phosphorylase. So this thymidine phosphorylase is sort of upregulated in cancer cells by cyclophosphamide. So because of this upregulation of thymidine phosphorylase, this combination of capecitabine plus cyclophosphamide is sort of synergistic than just additive. So that is the rationale for combining cyclophosphamide with capecitabine, because cyclophosphamide upregulates thymidine phosphorylase. So because of this, CAPE and endoxan are combined together. So well, when you combine two drugs, you are not looking at just cytotoxic activity, or you're not just looking at direct killing of cancer cells. You will also look at anti-angiogenic effect. You will look for immunomodulatory effect and possible indirect endocrine effects. So you're not just looking at cytotoxic activity, you will also look for activity beyond cytotoxicity. So these are some data where they said metronomic therapy is not just cytotoxicity but also has anti-angiogenic and also immunogenic properties. So, so these are some data that say about the efficacy, and these are the drugs that we use in metronomic chemotherapy, including capecitabine, cyclophosphamide, methotrexate, etoposide, temozolomide, and celecoxib. And then, so what is this metronomic chemotherapy and how is it different from normal chemotherapy? Metronomic chemotherapy is we use small frequent doses of chemotherapy on a continuous basis. This is what is metronomic. Small frequent continuous dosing is what is metronomic chemotherapy, and it has activity beyond cytotoxicity. It causes anti-angiogenic effect, it upregulates PD-L1 or it has an immune modulatory effect and so on. So these are some multiple trials where they have looked into the combination of capecitabine and cyclophosphamide, and this is some Indian data. So but unfortunately there are no randomized phase 3 trials and there are no pharmacokinetic data. There is no confirmation of synergism. So to address these issues, the challenge was taken up, and a phase 2-3 clinical study of a fixed dose combination of capecitabine and cyclophosphamide was used. The fixed dose of both of these was used because their clearance was independent of the body surface area. So these are the strengths of the fixed dose combination we have commercially. So capecitabine is available as 700 milligram and 30 milligram cyclophosphamide, and the other strength is 420. So these are the two formulations we have. And this particular trial had two parts. The first part was where they looked into these three doses, group 1, group 2 and group 3. And what we could understand was, if you look into the response rates, it was group 2 and group 3 which was actually efficacious, or it met or it crossed the futility endpoint. So it is basically the group 2 and group 3 that is sort of accepted, and that is what we use in practice. And this did include metastatic breast cancer patients who had received at least one line of chemotherapy, either anthracycline or taxane, and this did exclude patients who had CNS disease or who were deemed to receive hormonal therapy or who had received more than one line of chemotherapy. So the primary endpoint was overall response rate, and the secondary endpoint was the clinical benefit rate or the disease control rate. And this is how the trial design was. The part 1 looked into the 3 doses, and it was group 2 and group 3 that was actually there, and then the part 2 had 78 patients on in the each group, and that looked into the efficacy. So and this is the demographic characteristics. You can see that it was well matched. It did include performance status 2 patients also, and then this is the response rate graph, where you can see that the overall response rate in the group 2 and group 3, you had a response rate in the ITT population around 87 and 84%, which was great. So you can see the disease control rate was above 85%, either it was group 2 or group 3, and then the response rate was on 25%. So this is the per protocol population. Even here you can see the disease control rate nearly 89 and 87%. So the toxicity was sort of well manageable. I'll just show you the toxicity in comparison to the other trials. So the most concerning toxicity with capecitabine is hand-foot syndrome, which is significantly less with this particular combination. So these are the comparison with the published data. What you can notice, the neutropenia part and the hand-foot syndrome are significantly less with the combination of capecitabine and endoxan. So capecitabine and cyclophosphamide have non-overlapping toxicities. So cyclophosphamide does not cause hand-foot syndrome, and cyclo causes more of neutropenia. Capecitabine does not cause neutropenia. So because of these non-overlapping toxicities, this particular combination is very effective. And very importantly, it's very tolerable. You can note that there are hardly any grade 3-4 side effects, and grade 1-2 side effects are also in single digits. So this particular combination is well known for its excellent tolerance, easy dose titration, and low pill burden. For example, if you have to give single agent capecitabine, you have to use at least 6 tablets a day or 7 tablets a day. If you use this combination of fixed dose Comcap-C, you can come down to 2 or 3 tablets a day. So the pill burden is less, the hand-foot syndrome is less, the neutropenia is less, the tolerance is good. So because of this ease of usage and excellent tolerance, this particular combination is sort of impressive. However, there are challenges because there are no randomized trials and there are no PK data, and there is no confirmation on synergism, and we don't have a comparison with single agent capecitabine. So we don't know, but if you look into the quality of data, the quality of live data looks like Comcap-C has a better toxicity profile compared to oral capecitabine. So, so this is important when you use the combination of capecitabine and cyclophosphamide. The concentration of capecitabine goes up. This is because cyclophosphamide upregulates the thymidine phosphorylase enzyme and has a synergistic effect. Therefore, this combination is rational. So, well, so these are the challenges when you have two drugs combining. There are a lot of challenges. One is the chances of impurity, the particle size, differential release, and however, Intas went ahead and did overcome these challenges, and you can see how the Comcap-C tablet looks like. It has an outer capecitabine layer and an inner cyclophosphamide, and so Intas has received a patent for the particle size. It is, I'll just show you the particles, and this is the patent for which is in process for the tablet, in tablet. So there is a tablet inside tablet, and you can see the size of Comcap-C tablets, which is easily usable, and the pill burden is less, the toxicity profile is better, and has the response rates and disease control rates in par with the historical clinical trials. So this is how Comcap-C looks like, and this is the DCGI approval. And with this, so I have been using Comcap-C in my patients. I have used it in triple negative breast cancer metastatic setting. I have quite a number of patients being there, having an excellent response. The key for this particular drug is its excellent tolerance. The hand-foot syndrome is negligible, neutropenia is negligible, less frequent follow-ups. So the pill burden is less, the compliance is good. A lot of patients being there on this particular drug, showing excellent efficacy. So we also have used Comcap-C in indications other than breast cancer. We used in GI cancers, upper GI cancers, colon cancers as a maintenance therapy, where you want less toxicity in this particular setting. So this drug comes handy in situations where you would expect good toxicity profile. So this is one of the unique combinations, from the Indian origin, having this fixed dose combination of cyclophosphamide and capecitabine, having a synergistic activity with a reasonably good clinical data, and can be used in day-to-day practice. So I would thank all of you for your patient listening.
Thank you for that wonderful talk, Dr. Chandrakant. I think we have some questions.
So, Dr. Chandrakant, do we have Indian data on this combination?
Pardon me?
Any data on our patients, Indian patients, for this combination?
Yeah. So this is Indian trial, no? So Dr. Ghansham is the highest recruiter for the trial.
So I was the main PI. So as you rightly said, because we had 2 cohorts, so we wanted to have the test of the hypothesis. So the first one with the lowest dose was taken out, and second and third dose were actually benefiting. Then we found out that the highest dose was creating probably more toxicity, so that zeroed down to 700 plus 400, 700, that is 1800 dose. So it is a good drug as an oral medicine. So we have moved into an OMCT in like head and neck cancers. So breast cancers, there are many patients who may not be affording for a CDK4/6 inhibitors. Though triple negative, we are using capecitabine for a longer time now. So these are hormone positive patients also. The only we can say the critics about this trial was that, so when this trial got started, so nobody analyzed the receptor study. So how many were actually triple negative, how many were hormone positive. But because it was a trial of metastatic disease with therapy, and who will probably go on for oral therapy, right? Because across all trials of capecitabine, these mainly are patients of triple negative followed by hormone positive. There are hardly any patients on HR2 positive disease. So still a good drug. So I think this will come importance if we, in the adjuvant setting where we are using capecitabine for 1 year, and we have seen that even with the metronomic dose, not standard dose, there are many patients who cannot continue for a year, right? So Intas should take that as a trial sort of, because I've been using offline, though it should not be, because we are adding another drug, cyclophosphamide. We don't know in long run, because in a curative intent, a long time use of a cyclophosphamide may cause a second malignancies also. So that can be a trial, a prospective trial for Intas to do in an adjuvant setting. So this was because many patients, and you will agree that many patients may not be able to complete capecitabine for a year or so.
So out of all the combination trials we have, I mean, this is a trial which is the highest number of patients, like 78 in each arm. If you look into all other global data of Japanese, they have hardly had 40 patients around. So this is one of the largest trial we have, and this is the best data we can have in our setting.
And the beauty is the size of the molecule, as MB said. So they got patent for that combination. So after combining both of these drugs, the size has actually come down. So the pill burden, according to one of the studies got published in BMJ and BJC also, that it's very important for those patients who want a long-term therapies, and especially in a country like us or many others where many patients are on anti-diabetic, thyroids, hypertensive medicine, for dyslipidemia. So burden of pill is also an important factor.
Thank you. Thank you, sir.
Thank you.
3 tablets. So
14
2
days.
on, 1 week off, because it is kept. The size of the molecule is much lesser than, almost 30% less than a capecitabine size. Fixed drug combination, and this is supposed to be world's first in the.
I would like Dr. Ghanshyam to kindly present this. I request Dr. Sunil Agarwal to kindly take up with the next presentation about chemoport insertion. Sorry. Should I go? Yeah, please, please.
So, after a long time, like surgical topic, it's good. So, can I have the privilege to change the slide, or you are going to change the slide? You are going to change the slide. Okay, I will be a little bit fast, so keeping the time in mind. So, good morning, everyone, respected chairperson and my dear colleagues. First of all, I'm really thankful to Dr. Biswas and his entire team, which include me also, for giving me an opportunity to present this important topic, which is very dear to both the medical oncologists and the surgical oncologists. Because for medical oncologists, it's a lifeline, because they want to give the chemotherapy. That's the main channel right now, nowadays. And for a surgical oncologist, definitely it's the maximum number of daycare surgery which a good surgical oncologist used to do. And secondly, to the Bird India Limited, who has given me and entrusted me to present this topic. So thank you very much. To begin with, this chemo port, next slide. So the chemo port is something different when a medical oncologist, surgical oncologist used to see it. A medical oncologist see the chemo port only as a device where they can place their chemotherapy and can safe delivery of the chemotherapy to the systemic circulation. They don't bother about what kind of port is being used, which way somebody has used. If any problem occurred during the access or giving the chemotherapy, you are gone. You are gone in the sense surgical oncologist is a no more in their picture. Either they will give it to some other surgical oncologist or they will prefer to put a PICC line. And for a surgical oncologist, it is a lot more to think about that one, what kind of port they are going to use, whether it is a pre-attached or you have to attach it, whether it's a titanium or a plastic one, which way somebody is used to put, whether in a jugular or in a subclavian, so whether they can get an access to the ultrasound guided or maybe the CR. So a lot of things are happening in the surgeon's point of view when he thinks about the chemo port. Now coming to the young surgeons, those who are present over here, I can see some young surgeons are over here. They do have some questions regarding the chemo port, like indication, contraindications. The next important thing is that what will happen if something goes wrong, if they cannot have an access to all the sites which has been conventionally been mentioned. And finally, the industry people, definitely they will be looking forward to see, to promote their product as their best one and the unique one. So keeping all those 4 views in mind, I will be presenting within this 15 minutes and grabbing your attention. So this is the disclaimer slide from my side. Next slide, please. So I will be presenting in these few headings, what is the chemo port, the difference between the advantage and disadvantage between the PICC line and the chemo port, and the subclavian versus jugular one, and what will happen if we cannot get any access to both of these things, complications and the conclusion. And we will definitely get an input from the audience also regarding some of my personal experience which I am going to share about this one. Next slide, please. So this is the type of access, the central and the peripheral access, as you all know. Next slide, please. So this is the port. Port is a placement, safe placement of the chemotherapy, where a place where can a safe, regulated way the chemotherapy can be delivered into the systemic circulation. That's what the name chemo port has come up. Next slide, please. So these are the types of catheter. Has been single chamber and a double chamber and a powered one. Next, I'm just quickly going through because these are all been known, I hope so, in this August gathering. Next slide, please. Next. So these are the indications where there are theoretical indication, but the main indication is where the long-term chemotherapy has been required, where the peripheral access is not been possible. Next slide, please. So these are the contraindications where there is a thrombosis is there, where low platelet count is there, where systemic infections are there. So these are the few contraindications are there for placing the chemo port. Next slide, please. So here comes my second point, the difference, the advantage of chemo port over the PICC line. Definitely it has got a lower infection rate and the improved lifestyle is there, the comfort is there, and increase the privacy and the appearance, and long-term health benefit is there because you can use it for 3 years and more for this chemo port. Next slide, please. So here comes your patient to you. So what is your aim? Being a surgical oncologist, what is your aim? Aim is to give the least discomfort to the patient and give maximum benefit in delivering the chemotherapy, keeping in view why a medical oncologist has sent a patient to you. That's a safe delivery of the drug. That's your main aim. So to fulfill the main aim, next slide. So to fulfill the way, you have to choose the right quality of port. Now you cannot choose the right quality. It is the port being used by your sisters. So according to that, you have to choose your port. So what is that? You have to do in such a way that it is easy to palpate. It has got a large septum so that easily the needle can be pricked. It has to be stable because a lot of ports are coming which is having only 2 sutures to fix that one. So it should not get flipped, and ability to withstand the numerous access and ability to deliver the drug very nicely, and you can aspirate the blood and can do the blood investigation through the same chemo port also. Next slide, please. So keeping in this view, what do you consider? That's the point where you consider from the surgeon's point of view, that's the size of the port you want to. Some chambers are coming very small, some are coming very pointed kind of things. Don't go into the fancy one. Take a big chamber where the large septums are there. It should be titanium or plastic. That depends on your prospective's choice. The shape, the needle puncher, type of catheter, definitely silicon is the best one. And the pre-attached or the attached one, that's your preference. Next slide, please. So next slide. So these are the tray which a surgeon used to see when he used to put the chemo port. Next slide. Now here comes the action of a surgical oncologist. So you want to put the catheter tip at the SVC and the right atrium junction. Next. So so these are the few pictures where ideally the things has been pushed. This is the picture of putting a jugular vein, and I will be showing this one in a video presentation. Next slide, please. And next slide. So that's an ideal picture for a chemo port which has been inserted through the same IGV, and you can see the angle. It should be an obtuse angle, just to show that one. And now comes some videos which is having my personal experience, subclavian versus IGV, pre-attached versus you have to attach during the surgery. So these are the few experience. So you have to be fast enough. Sir, you have to be a little bit fast enough. So I'm just showing in a subclavian one. First the subclavian one which I'm going to put. And that's the catheter one. Next slide, fast please. Fast move. So seeing in the C-arm where my catheter tip, where my guide wire tip is there. Next. Move. So that's the port placement where I'm putting. So you can see that I have already made the second intercostal space where the junction of the SVC and the right atrium is there. So I'm just putting the port. So now you can see in this one, this is not a pre-attached chemo port which I'm putting. That means pre-attached. I'm putting the catheter first, and then later on I'm putting it with the drum, and then I'm attaching it that one. So that's the video which I'm going to see, and see what is the practical problem which is occurring. And I tried myself to modify this one. So that's the drum which I'm fixing. Next, fast please. Fast. So fast. So these are the things. Fast. Go to till the last one. So that's a tunneling. That's the thing. So see, this is the thing which I'm putting over on the table. That's not a pre-attached one. So next, move forward. Sorry, I don't have an access to forward it. Move forward. So see, I'm pulling out the catheter and putting it fast. Forward it, please. Forward it. Forward. So this is an unedited one. Forward it. So this is I'm putting. I'm fixing it. Fast. See the mosquito which I put. That's the thing, because I am in the fear whether there will be proper things which I can fix it or not. So I'm little bit putting it this one, and then I'm fixing this one, and then I'm pushing this one. So there will be, finish it up and play the next video. So there are chances of two kinks might be there, where at the port side and at the angle side. So there might be two things are there. And this is the second video where I'm showing a pre-attached one, and I'm going retrograde. That's the first one which I've done with an antegrade one, and this is one I'm going a retrograde one. So fast forward. These are all the instruments been showing. So go, move fast, please. Go fast. So that's the things where the cricord, that's a marking clavicle is there, 2 centimeter below my port placement things are there, and that's the cricord cartilage, and that's a sternocleidomastoid is there. This patient is having a biopsy site is there, but never mind. And move forward. Forward, please. Please go last. Go last, please. Lack of time, please go last. So see, this is you have seen this one as a prefixed one. I've fixed the line with the port one, and attach the tunneling one with the catheter, and I'm taking it out. Fast, please. Fast, fast. So I have taken it out, and then I'm just pulling it and keeping it and pushing it inside the IJV. So that way, the whole tautness is there, and there is absolutely no kink is there. You should be very, that's a thing which I learned from my own experience kind of things, but I need to get an comment from the audiences also. So next, come to the slide, please. So this is one patient, which is a lymphoma patient, 25-year-old patient. He's been, the medical oncologist told me to put the catheter, central line, the chemo port. So, and this patient is also having a right atrial myxoma is there. Now I am in effects, where to go? I called my cardiologist, like, should I go and put it into the SVC? So he said, no, you cannot go. I said, where then I can put? So he said, like, okay, you can go till the brachiocephalic. I said, okay, I'm having a C-arm, I can put it in the brachiocephalic since the things are down there. So I tried to put it from the right brachiocephalic, so things are not going. It is going from some distance, and then it is not going. I don't know why it is not going. Then I tried to put it from the right IJV. It is not going. Then I tried to put it from the left side. I said, okay, some length it will go, some more length is there from the left side, it will go. See, on the left side, it is going on the opposite side. Opposite side, it is going. So then I tried from the left subclavian. Then I couldn't put the photo over here. In the left subclavian, when I put the guide wire, it went through all through round, and I see in the diaphragm, the guide wire is there. I said, what has happened? I couldn't put the photo over here. So I found out it has gone through the internal mammary vein and gone till the diaphragm. And it is not going forward. I tried many a times. So finally, next slide, please. So I put the catheter in the femoral vein. I don't know how much. I do love to have listen the experience of my surgical colleagues, those who are here. So I put it in the femoral vein. This is the third patient which I put, and this patient is now receiving the chemotherapy. Come on, change the slide, please. Next. Next, that's the femoral vein which I marked it, and I attached it with the fossa lata so that the drum should not get flipped. Next, please. So that's the thing I'm checking whether the things have been done or not. Next. So next. So that's the port size where they put. Next. So thing of seeing all those kind of things, these are the few complications which I have seen, and I've seen maximum number of complication occurs in the when I put it in the subclavian. I do want to get it from the audiences also. That's a fracture you can see. That's a pinch of effect. I think so. Might be there because it is quite medially been placed. Next slide, please. So that's a fracture of the, next slide, please. Next slide. So that is also a fracture occurred in the IJV also. Next slide. Next. So that's a fracture one, which the previous slide, please. And this has been retrieved by the cardiologist by doing the, through the retrograde method by angio. And they have removed the next part. This part has been removed by the surgeon, and that part has been removed by the cardiologist. Next slide, please. And see, this patient, luckily, which we have got a norm that before removing the chemo port, suppose somebody is coming, we do an X-ray. So when we do an X-ray, before removing, we found out this one. The drum is there, but there is no catheter is there. So we are lucky enough to get a blame on the OT table. So what we did is that, on the, we removed this one. We talked previously to the cardiologist. The cardiologist said, okay, you go ahead with removing this one. We will take care of that one. And we counseled the patient beforehand also, like, okay, this has happened before. This is not due to, because otherwise the things are on the other way around. Might be something will occur. So that's a practice, that's a good practice in the sense to get a X-ray. Next slide, please. Next slide. So that's a pinch of effect. So that's in the subclavian vein if you put it in the more medial aspect. Next slide, please. So that is the complication during insertions. Next slide. During accessing like extravascular infection, and this is after accessing that's the exposure of the port. Next slide. So chemoport is a safe and effective method for a long-term venous use. So that's all from my side. I just
So thank you, Dr. Sunil. So I hand over to Padmala Madam for her comments.
Thank you, Sunil. Very nicely explained. For the new surgeons who are going to put the chemo port, I just would ask you one question. Suppose it's a very bulky patient. Where would you like to put the port?
I mean, I would love to put the port in a IJV one, but for my sisters and the medical oncologists for convenience, I used to make the port access very thin.
Yeah.
And I hitch it and put it at the anterior aspect so that it should not be getting into deep down, because the bulky patient is there. You make the pocket, put it at the down one, and then it will be a kind of a gap will be there, and there will be a lot of secretions will be also be there. So what I used to do is that I put it from the away from the port. I pull the this one the pectoralis major muscle, so that the port access will be on the anterior aspect, and it will be an easy one. That's a method which a desperate method to give a good access to the sisters and the medical oncologists.
Yeah, basically the flap should be thin over the.
Correct. Flap should be definitely thin.
Okay, thank you. Any questions from anyone?
Yes, Dr. Dilip.
Question, Sunil, in that case when you got a failure, the femoral line, why didn't you go for an open approach? Open the IJB and put a catheter. That is, I could have done in that case, taken incision, approach the IJB, put the catheter, safest, easiest, rather than changing 3 places and going to femoral. I have put one femoral. The only problem is the pulling of the things, and sometimes very painful, sometimes because the inguinal region is quite nearby and migration of bacteria are quite high. I would have suggested that open technique.
So that's a good suggestion, but this patient is having some sort of superior vena cava syndrome. It's a bloat up kind of things, having a respiratory problem. My anesthetic people are saying, no, we are not going to give you anything. Whatever the easiest way you want to do, you do it. And my medical oncologist, because everything has bloat up, they don't have any access. So it's a desperate, it's not a standard one. It's a desperate, that's why. Because SVC syndrome is also one of the relative contraindication for putting the chemo port into the central line over in the. No, I mean this is not a clear-cut case of SVC syndrome. He's having a respiratory problem, a bloating up kind of face is there. So I do try, I just try say like, since ultrasound is there with me, I've got an eye, so why not to try with this one? So in that way I've tried, but yes, definitely your suggestion is a good one.
Thank you, Sunil.
So one more. Sir, Dr. P.K. Das and Dr. Sarangi is there. Sir, what is your experience in putting this one in the peripheral, in the chemo port in the femoral vein?
Femoral is not very common because of known reasons of infection and inconvenience to the patients. And as Dilip said, if you cannot access by this blind method or guided method, you can always go through a little nick and go to the IJV. And in that case, you can, in case there is not possible, then you can go for PICC line also. But PICC line problem is a lot of maintenance. Every time you have to flush it. So that is a disadvantage. But I see many centers, they go ahead with PICC lines, and their rate of chemo port insertion is very, very low. But chemo port insertion is, on the contrary, is good for the patients and easy to operate by the sisters also.
Okay.
Thank you, sir. Thank you so much.
Sabda Pranam Samavati Suddhi. ବସିଛି କୋଶଲ ଟାଇମ୍ର ସମ୍ପାଦକ ସଞ୍ଜୀବ ମହାପାତ୍ର। ଆପଣଙ୍କୁ ରିକ୍ୱେଷ୍ଟ କରିବି ସାମ୍ପ୍ରତିକ ପରିସ୍ଥିତିରେ ଭାରତବର୍ଷରେ ପଞ୍ଜାବ ଭଟିଣ୍ଡା ଜିଲ୍ଲା ପରେ ଓଡ଼ିଶା ରାଜ୍ୟର ବରଗଡ଼ ଜିଲ୍ଲା ଜରାରୋଗ୍ୟ କ୍ୟାନ୍ସରରେ କବଳିତ। ସେଇଥିପାଇଁ ଆଜି ଯେଉଁ ମିଟିଂର ଯେ ଆୟୋଜକମାନେ ତାଙ୍କୁ ଅନୁରୋଧ କରିବି ବରଗଡ଼ ପାଣି କିଛି ଚିନ୍ତା କରନ୍ତୁ ଟିକେ।
Thank you.
So the next topic would be taken up by Dr. Ghanshyam Biswas. It was initially being presented by Dr. Soumya, but his throat is not doing very good. So Dr. Ghanshyam Biswas has taken it up. He would present Ujjvira, where does it stand in 2022? Thank you.
So good morning. So Ujjvira, so we are talking about a biosimilar or a generic TDM1. So where does it stand in 2022 in HER2 positive breast cancer? So the HER2 space over a last decade has been increasing. So there are at least 8 drugs, FDA approved drugs in the space. So out of which, so trastuzumab, the original and the biosimilar, lapatinib, the original and the biosimilar, and now for last 2 years, the TDM1, the original and the biosimilars are available with us. Rest 5, if you at all need any of the other anti-HER2, so probably you have to procure them for a particular patient, so you have to have an import. So that's the barrier as of now. So we understand that many of us have consumed all the 3 available drugs with us, and then we struggle to get the 4th or the 5th anti-HER2 agents for our patients. Unless and until we have a clinical trial in any part of this country and we are getting enrolled. The good news is that the same group, Zydus, is coming up with the biosimilar pertuzumab. So we have already started trial in my center. So we have 3 patients at this moment for pertuzumab. So that's a good news that another 2 years or so, so we'll see pertuzumab biosimilar if it really matches to the innovator. So we'll have another biosimilar from 2 years from now. So TDM1, so it was said that copying a cytotoxic is much easier. Then came copying a monoclonal antibody was again a bit easier. So when we have the first biosimilar rituximab followed by trastuzumab and then bevacizumab. And it was said that it is almost impossible to have a copying or an ADC because it was probably the toughest for any researcher. But now you see, so for 2 years, the world's first biosimilar TDM1, which is us, and now we are moving ahead with many other TDM till the patent gets off. So for a country like us, for innovators, for researchers, so I think it is nothing is impossible for this country. So what is an ADC? So it has 3 components. So one is an antibody, that is a trastuzumab. The second is a linker, so which is basically a thioether linker. And the third drug is a DM1. So trastuzumab is conjugated by a thioether antimicrotubule agent, a DM1. So what it does, targeted intracellular delivery of DM1. So DM1 is internalized via endocytosis, and this DM1 inhibits microtubule assembly, so leading to a programmed cell death. So what are the approvals for this ADC, that is TDM1? So first approval came in 2013, so almost a decade back. in a metastatic breast cancer post-progression on trastuzumab. So 2019, we got an approval in an adjuvant setting. Suppose for a patient, either a trastuzumab or a combination of trastuzumab and pertuzumab as a neoadjuvant, and patient landing up with a residual disease. So it was an adjuvant approval. So in India, we got the TDM1, the biosimilar, so almost 2 years back, and then came in the clinical use for last 1.5 years. So this was the clinical trial. So you can see, so I am a part of this. We had 7 odd patients in the trial, and this got published into a clinical breast cancers. So where we looked into the efficacy, overall response rate at 24 weeks, safety because it was our first biosimilar ADC, second and third point was the pharmacokinetics. So it was only for 1/3 of the patients. So after 170 patients, 50 were actually sampled for PK studies and definitely anti-drug antibodies. So to conclude from this randomized trial that demonstrated biosimilarity between Usbira, the biosimilar, versus the Kadcyla original in patients with HER2 positive metastatic breast cancers with respect to efficacy, safety, pharmacokinetics, and the immunogenicity. So coming to the adjuvant space, so the most talked about trial is a Catherine, so where more than T2 disease or a disease with node positivity. So today's regimen is that you finish off chemotherapy, you give a good amount of anti-HER2 agent, so either a dual or a single anti-HER2, and the patient is subjected for surgery. Post-surgery, if there is a residual disease, then these patients should be offered a TDM1 for 14 cycles. There is another trial of attempt, so that may not be clinically relevant at this moment because the investors or the drug manufacturer people, they will try hands on everything that's possible to make it more viable when the cost involved for any research is such a huge. So the Catherine, which is basically for an early breast cancer or a locally advanced breast cancers, so where the patient was randomized to TDM1 of a usual dose for 14 cycles versus continuation of trastuzumab, where the patient has completed the neoadjuvant protocol post-surgery if there was a pathological residual disease. The primary endpoint was invasive disease-free survival, and the secondary endpoints were there. So you can see, so the delta of benefit was 11% in favor of a TDM1 for a residual disease, and you can see a HR of 0.50, so which is a good thing for a disease like HER2 positive. So you can see on the TDM1, so distant recurrence was less as compared to patients who continued on trastuzumab in a residual disease. Locoregional recurrence was less, contralateral breast cancer was less, even death without a prior event was also numerically less in favor of a TDM1. Coming to a secondary endpoint, which was a distant disease-free recurrence, again you can see favoring TDM1 as compared to trastuzumab and with a hazard ratio of 0.60. So if you come to the forest plot, you can see, so all characters were in favor of a TDM1. To note whether it is a hormone positive or hormone negative, so TDM1 did best. Whether patient received trastuzumab alone or a trastuzumab pertuzumab, which was around 18% patients. And you can see, so these patients got benefited with a changeover from trastuzumab to a TDM1. So So the Catherine, you can see, so trastuzumab versus a dual anti-HER2, so you can see more than 10% benefit. So with any of these drugs in combination, so when you changed over to TDM1. So the yardstick in oncology is an overall survival. So gaadi kitna deti hai, that is more important rather than the makeup. So ultimately you can see hazard ratio of 0.70 means there is a 30% reduction in death. So when you have switched over to a TDM1 in a residual disease. So TDM1 comes with certain toxicities. So nausea and vomiting because it has a chemotherapy built in it. Second, a thrombocytopenia can be an issue. And third, elevation or a derangement of SGO to SGPT can be an issue for certain patients. So coming to an attempt trial, so which probably the investors and the researchers wanted to see, so if this drug can be put upfront. So and this trial showed that TDM1 may offer an alternate therapy to TH. There are patients in our clinical practice who doesn't want chemotherapy. So all said and done, मैं chemotherapy लूँगा ही नहीं. So probably in patients with early disease, so can be a candidate for this, but this is again is an individual basis, so that cannot be taken as a level 1 evidence on a. So if you come to the NCCN guidelines, you can see for a HER2 positive, so TDM1, so there is a category 1 for those patients who have a residual disease post exposed to either a single or a double anti-HER2 agent. So this is what the present policy of a HER2 positive disease. Small disease, early disease, the patient goes under the surgeon's knife and then followed up with a systemic therapy. So there has to be a component of an anti-HER2. So either you give for a shorter duration or for a standard duration, so it is still a debate. For disease which is more than T2 or a node positive, then that should be evaluated by a medical oncologist, give trastuzumab or a dual agent with chemotherapy, and then the patient is evaluated for a surgery and look for a PCR. And if PCR, no PCR, then probably it's time, if somebody can afford, then patients go for a TDM1. So this is how we're moving to our MBC, which got the first approval. So most talked about in a MBC is our EMILIA trial. EMILIA is basically somebody was exposed to a trastuzumab base in either adjuvant setting or in a metastatic setting. So they automatically became a candidate for a TDM1. So there are other trials like Theresa, which have looked beyond second line. So there are patients, third line, fourth line, fifth line, they got benefited with the TDM1. Camilla actually looked at this drug, TDM1 is also active in the CNS. Marina trial, again, so this is can be a case where the patient doesn't want chemotherapy or not a candidate for a taxane, so probably a case where you can use an upfront drug. And definitely today we talk about RCT, randomized control trial, versus real world evidence. So this was how things have evolved. So hardly 1-2% when the patient, in spite of all supports from the Roche as a PAP, but today with the generics available, so we have at least increased numbers of patients getting the benefit of TDM1, but I think so it has to go a long way because still it is costly for many of our patients. So this is the EMILIA, as I said, so it was compared in a second line TDM1 versus capecitabine and lapatinib. So we saw that PFS benefit is there, OS benefit is there with TDM1 as compared to capecitabine lapatinib. But if you see the toxicity, so capecitabine and lapatinib, which is an oral drug, comes with a huge toxicity of nausea, vomiting, with diarrhea, and with the hand-foot syndrome. So discontinuation around 6% even with the oral pill. So Theresa, beyond second line, you can see there are patients in the third line, fourth line, fifth line getting benefit of this anti-HER2 agent. So 3 months benefit in PFS, 7 months benefit in OS, so when these were used beyond second line. So CNS activity, so because we know that CNS is a sanctuary site for HER2 and triple negative. So in HER2 space, we know that trastuzumab doesn't penetrate. So we know that lapatinib has an activity, and the other generic that is available, a biosimilar available is TDM1. So this trial showed that patient has a good control of intracranial disease, and that came out from this trial, Camilla trial. So brain lesion in syncage was observed independent of overall response. And this is in the upfront setting. Suppose the patients who are not a candidate of taxanes, so there can be a case for TDM1 upfront. So in nutshell, we can see there are lots of real world evidences. I think Zydus can collate, so they have good number of patients on their brand now, so we can collate and showcase our own real world data. So that's there as a second line and also beyond. So today you can see the guidelines for NCCN, ASCO, ABC, so everywhere TDM1 has been approved. So the unmet need is that still we have to go a long way for treating HER2 patients, because it's almost 1 out of 4 patients will have a HER2 disease, and even with the generic or the biosimilar that's available, so it doesn't reach to many of our patients. Thank you, ladies and gentlemen, for a patient hearing. Thank you, Zydus, for sponsoring this.
So most of them will have almost 50 to 60% patient will do have a good response and they'll undergo surgery. But there are some 5%, 10% patient in practice who are not responding. So for them, you want to do surgery, and post-op HPR comes as YPT4N3, and you want to give TDM at that time, or in practice you want to put TDM1 upfront in a neoadjuvant setting and see whether they are responding.
So you are right, Bhavesh. So I think, suppose there is a patient of, because in our country, in many of the labs, so we still struggle to have the basic receptor study, right? So if you have a patient of ERPR negative, HER2 positive, and you have rightly put on the protocol, if you see no response, and if you have given a standard brand, so I think, so there are many patients, at least in my 22 years I've seen, you check, so it might turn out to be a triple negative. There are patients of ERPR positive, HER2 positive, triple positive, which constitute 9%. So you might be seeing that this patient is not a HER2 positive, right? So, but you do see patients where the responses are suboptimal. If there is a gross disease which is clinically evident, I don't think that switching over will be benefit. So in these patients, we should go for an early surgery, and then probably we need to look into a different biology. If somebody who is clinically not visible, only you are looking at a PAT-CR, and today, so you must agree that in our group, medical oncology group, so now there is so much of talking about a PCR itself. So now we are doubting even PCR as a yardstick. So it is an exciting time, I can say. So I don't have an answer to every question that is there, but so probably we have to come a long way, because the disease has evolved, the heterogeneity has itself is evolved, and the treatment is absolutely in a liquid state at this moment. So we don't know what is right, what is wrong. So probably we need to have a tumor board putting into molecular people, because there are lots of crosstalks happening even with a disease which looks so innocent.
So as we come to an end to the breast cancer session, we would like to extend our thanks to both the chairpersons, Dr. Ravi Shekhar Patnaik and Dr. Padmalaya Devi ma'am. Can we have some comments from Dr. Ravi? If he's there online. He was with us on the virtual platform. So we would like to give a small token of thanks, memento to Ma'am Padmalaya. So we now proceed towards the inauguration ceremony of this particular summit. Can I please invite the dignitaries to the stage? The organizing secretary, Dr. Ghanshyam Biswas himself, Dr. Surendranath Senapati, Dr. Soumya Surat Panda, Dr. Sunil Agarwala, Dr. Lucy Patnaik, and Professor Dr. Lalatendu Sarangi. Please join the stage for the for the inauguration. So, we have a brief small moment of prayer, a divine moment.
या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या ब्रह्माच्युतशङ्करप्रभृतिभिः शुक्लां ब्रह्मविचारसारपरमाम् आद्यां जगद्व्यापिनीं वीणापुस्तकधारिणीम् अभयदाम् जाड्यान्धकारापहाम् हस्ते स्फाटिकमालिकां विदधतीं पद्मासने संस्थितां वन्दे तां परमेश्वरीं भगवतीं बुद्धिप्रदां शारदाम्।
So now I would like to invite Dr. Ghanshyam to present his welcome address.
Still we are before 12, so good morning seniors, friends and colleagues. Respected Professor Lalatundu sir, Senapati sir, colleagues on the dais and off the dais. So we have come on to the inauguration of 4th Indooncology Summit. Unfortunately, Governor declined because of the President's visit, and yesterday late evening we got a call from AIMS Director declining because of a government urgent meeting at 11. So the Indooncology Summit started their baby step in 2018, and in these 5 years, so 2018 and 19, we had a physical meeting. 2020 we could not have because the first episode of the COVID pandemic, and last year 2021 we had a virtual mode, and the 4th episode we are at 4th episode, which is supposed to be a hybrid. And so thank you everyone who made it possible for this scientific feast. So cancer care era of precision. So we have come a long way in last 4 decades from a basic understanding of cancer and lots of complexities in 2022. The same disease which probably many of our seniors have seen has gone through a sea change in understanding in regards to a treatment armamentarium and a sequencing of treatment. There are many diseases which has probably a many-fold understanding and treatment to choose from that's available with us. So this summit has been not only a clinician, so this is probably unique in many ways. We have always invited on every day, you can see there are scientists and basic researchers who gets involved, because ultimately what we are using today has come out of a basic research and understanding of this disease. So once again, thank you for joining and making it happen. And so we have full day today and tomorrow also. So let us make it successful and conclude in a better way. Thank you so much.
Thank you. Now we would proceed for the lighting of the lamp, please. I would like to invite all the dignitaries to please come for the lamp lighting. Can I please request Dr. Surendranath Sarnapati, sir, to take up on the felicitation address?
Good morning. The chief guest of today's program, Dr. Lalatendu Sodang, the director of HPGIC Cuttack. Organizing secretary, Dr. Ghanshyam Beswas, professor, medical oncology, Sama Hospital, and also director, Sports Hospital. Dr. Sunil Agrawal, Professor Samya Surat Panda, professor and head of Sama Hospital, Department of Medical Oncology. Dr. Lucy, our associate professor, HPGIC Cuttack. And the man behind this show is Mr. Rudra. This is the 4th Indooncology Summit being organized by the International Association of Oncology with BioLink. This is a unique forum because what we see here, this is a platform where the different stakeholders of cancer care, they gather here and also exchange their knowledge from laboratory to bedside. And ultimately the aim is to have the better therapeutic outcome, I say. It's not the treatment outcome, it's the therapeutic outcome. I know that few delegates are from outside the state, and mostly whatever information I gathered, both offline and online, more than 270 delegates have been conglomerated here. And it's due to the constant effort of the organizing secretary, none except Professor Ghanshyam Beswas. I can highlight here a few points about the development of field of oncology in the state of Odisha. Odisha, it's a land of Lord Jagannath, the place of peace, harmony. And here, the development that we have seen in few years, and also with the dynamic leadership of Dr. Lalatendu Sodang of the Director of Cancer Institute. Odisha is the only government who has declared that the cancer is a notifiable disease. Besides this, in this state, we render the services of chemotherapy in all the districts of our state. And regarding the infrastructure, it is well equipped, and 11 centers are coming up with the radiotherapy facility and also the cancer care at the different places. To highlight here, this state also gives the technical or education, the MCH in surgical oncology in HPGIC by the leadership of Professor Padmana Devi and also Professor P.K. Das and also Professor Swadip and his team. And also at the Sam Hospital by the Dr. Agrawal and his team. Besides that, the HPGIs also give the MCS degree to the students in gynae oncology. And the Sama Hospital also gives the DM in medical oncology. So this is the development regarding the education. And regarding the manpower or the talent pool, HPGIs also update the doctors from the periphery so that we can also deliver the services at the periphery, not only at the centers, at the periphery also. And to highlight here, our state is representing at the national level. To mention few points, few names here, Professor P.K. Das, he is now the president of Indian Association of Surgical Oncology. Dr. Bhagyalakshmi Nayak, she is the secretary of the Indian Association of Gynae Oncology. Professor Jita Parija, she is also representing as the vice chairman of the Indian Association of Gynae Oncology. Dr. Janmaja Nayak, he is also the treasurer, and also few peoples also represent from other different national organizations, and not at the last but not the least, myself is being elected as the president of Association of Radiation Oncologists of India this year. So this is the achievement of our state. Friends, we have developed a lot in our infrastructure, but the basic thing that we have to render proper services and also to the patient who are at the interior parts of our state. And that is only possible. However, I have gathered that the knowledge of our colleagues or the stakeholder, definitely I know that the OSA has also given a good services, or it also responsible for increase the knowledge of our colleagues. And also this Indo-Oncology Summit with the leadership of Professor Ghanshyam, definitely the teaching and also treatment aspect of the cancer in our state will be improved. I know that a lot of delegates are from outside our state. Friends, you can enjoy your stay here, both in academic as well as the beautiful place, Odisha. At least have a visit to Puri, the Lord Jagannath temple, and also you can enjoy. We know there might have some shortcomings. So if any shortcomings are there, you can excuse us as a chairman of the Indo-Oncology Summit. Thank you once again. Thank you.
Thank you. Thank you very much, sir, for that warm speech. I request Dr. Sunil Agarwal to kindly address the meeting.
Respected teachers on the dais, I must say that these are my teachers only and my colleagues. So first of all, I must congratulate to Dr. Biswas. You know, we are having a lot of forums in our state, like our Onco Club is there, Odisha Society is there, but we don't have a dedicated things which usually used to do a conference kind of things. And he is the only man who with the last 4 years consistently doing this Indo-Oncology, and now in throughout India, Indo-Oncology conference means, yes, it is a conference from Bhubaneswar and Dr. Biswas, and so I must congratulate him. And you know the quality, the kind of things which I must say that I must learn from him and everybody. Right now, the previous session which was there, it was of Dr. Soumya Surat Panda, and he is having a sore throat, he is having a genuine reason. He has come to show the solidarity, yes, I am there. And immediately Dr. Biswas, without any preparation, and I think everybody has witnessed the kind of presentation which he did, is flawless, as if he has already been prepared. So that kind of things, cushions are there to absorb whatever things, whoever is coming, not coming, still he is carrying on. And to give his backup, I must congratulate one more person, Mr. Rudra, who is BioLegs. He is consistently there, and after us, we the doctors are the most laziest person, I must say, for at least myself. We keep on postponing kind of things. Procrastination is something like we are busy with the patients. That's the best excuse we used to give. But he keep on consistently, and that's why this fourth oncology is on actual things has happened. So I must say that we must take the advantage of this platform, especially Dr. P.K. Das. Usually, he is now our ISO president. You know, his best quality is that we have recently finished our NatCon. His first thing is that whoever interested from Odisha to present their paper, their things in the national forum, please give their name. That's the first thing he has done. Now, the whole idea is that want to promote the Odia people. So that's a greatness, that's a thing. So we must utilize this platform to project ourselves throughout the India that what we are doing. So that's the thing. So thank you very much for all those kind of things. Thank you very much.
Thank you so much, Dr. Sunil. May I please request Dr. Lucy Patnaik, ma'am, to present her address?
Respected and esteemed seniors on the dais, and my teachers, delegates and students of the dais. Respected Director Sir, my Professor Dr. Senapati Sir, Dr. Ghanshyam Biswas Sir, Sunil Bhai, Surya, and Soumya Surat, and Mr. Rudra. I would actually like to congratulate Dr. Ghanshyam for organizing Indo-Oncology Summit for the 4th time with so much of success, and I would also second Sunil Bhai as he said that Dr. Ghanshyam Biswas works effortlessly and seamlessly. We evidenced today how he actually merged into Soumya's presentation without any any prior presentation. And he is a mammoth, actually, the way he has been organizing Indooncology Summit, and I think during COVID, he cancelled once, and last year also it was on online mode, and this time it was it's in hybrid mode, and he has encouraged all of us, all the cancer institutes, both the government institutes as well as the private and corporate hospitals in this oncology summit, as well as overseas from Brunei, Dr. Ravi Shekhar Patnaik, he also participated, and we are actually seeing how much enthusiastically we have participated in this conference, right from the seniors as well as the newcomers and the juniors. What we must learn from him is how effortlessly he's actually marching ahead, leaving his space behind for his juniors to fill in the space, and he's creating newer and newer work for himself. So with immunotherapy, with all these inhibitors, MABs, stereotactic radiotherapy, he's actually leading the traditional work for the youngsters and picking up new things to work upon. So I think we have a lot to learn from all these seniors sitting here, and Sunil Bhai is not lazy, he is also very, very aggressive. Thank you all.
Thank you very much, ma'am. I request our guest of honor, Dr. Lalatendu Sarangi sir, to please present his special address. Thank you.
A very good morning to all of you. Dr. Biswas, Dr. Senapati, Lucy, Sunil, Soumya. I'm really honored to be here today. A few years back, cancer treatment in Odisha used to be either Acharya Hariyar or Panda Curie, and a lone crusader, Dr. Ghanshyam Biswas. He alone was considered as an institution. I'm happy that besides his clinical activities and acumen, he has kept up his academic pursuit, which is culminating in successively 4 national level conferences in Bhubaneswar. What I'm observing from yesterday afternoon, this meeting has all the ingredient with a little bit of refinement to become the Odisha Cancer Congress, because we have people from, though it's heavily tilted towards medical oncology, but it has all ingredient, all the specialities from surgery, radiology, pathology, radiation, they are all together. It's some sort of a rare combination of people from various fields who are working on cancer. The problem in the state is, besides we are talking of cutting edge technologies here, new drugs which are being introduced in the recent past, what is its efficacy, how much benefit it's going to give, this is all fine. But still there are a lot of miles, lot of paths to be covered. Still the treatment related migration from the state is to the tune of 60 to 70%. And people who have got money, they will go out. Even people who don't have means also, they are going out due to lack of a standardized care. The first and foremost in this area, maybe to a large extent medical oncology we have addressed, and even radiation also we are fast addressing this issue. But the main crux is the medical travel is because of high-end surgical facilities and high-end diagnostic and interventional facilities. That needs to be improved. You cannot improve one section of the treatment, leaving the other section behind. And the main thrust, what we have seen in last 3-4 years is number of institutions, small or big, they have come up like Sunil, he's heading a beautiful institution in some hospital, and KIMS also is going to have a comprehensive cancer center. So things are improving, but it should improve in a faster way, faster rate. To stop the medical tourism, we must double up, do it within next 5 years. We are already about 20-30 years behind the national scene. And we must catch up in coming 5 years. Otherwise, we will. If you remember, there is one doctor, if you know, there is one doctor called Dr. Panali Velu. He is a father of laparoscopic surgery in this country. He started laparoscopic surgery at the inception around 1994-95. He failed as a general surgeon to make a mark. Then he entered into the laparoscopy. And Coimbatore, an unknown city of Tamil Nadu, became the global hub of medical tourism and laparoscopic surgery. So even single person can transform the face of cancer treatment or medical treatment. So we must look at that angle. See that our services excel at a cost-effective manner, which will be beneficial to the masses. The government is very proactive, and in another, maybe in 2 years' time, we'll have centers of national excellence in essentially the city of Bhubaneswar, and we may permeate the districts also. So these type of meetings will go a long way in educating the cutting edge and enthusing the young budding oncologists to work in this field. Thank you very much for inviting me for this meeting.
Thank you very much, sir, for that wonderful address. I request Mr. Rudra to please come upon for the unveiling of the proceedings of the conference.
Good afternoon, everyone. So, the time has come to unveil magnificent contents that has been created by thorough shortlisting of more than 200 abstracts under the leadership of our scientific chairperson. A strong committee was established and thorough double peer review was done. And meanwhile, after plagiarism check, these articles were considered for publication in the conference proceeding. The proceeding will be submitted to world-class repositories like Web of Science, Scopus, SCI, because we believe the wonderful content that Indooncology Summit has been creating should be globalized. I express my hearty gratitude to all for unveiling the proceeding. Thank you.
Again, I would call upon Mr. Rudra to give the vote of thanks.
Very good afternoon, everyone. Few lines are reverberating in my mind. We say, Muking Karuchi Bachala Pangulanga Etigiri. So who am I when he drives the soap? We have Lord Jagannath with us on the dais as well. So we'll begin the vote of thanks by expressing my feelings to him. And vote of thanks is definitely a tedious job, I believe, because to make this conference successful, there are a lot of people, those who have made day and night one and have been working relentlessly without sleepless nights over last 3 months to make these 3 days of experience wonderful. Revered dignitaries, most respected Honorable Chief Guest, respected organizing committee members, office bearers, faculties, experts, world-class leading speakers, doctors, oncologists, and students. It's really a wonderful experience of having you all here. The sole purpose behind organizing Indooncology Summit could be defined only in 5 words. The first word is globalization. As academic entrepreneurs, we believe globalizations of ideas, innovations, and research is the utmost need that deals and leads towards capacity building, which is one of the Sustainable Development Goal, SDG of United Nations Organization and World Health Organization as well. My dear colleagues, we all live in a world of baffling contrast and violent uncertainties. At this point of time, when we have come over with a struggle phase of COVID-19, it's high time the healthcare community should be ready with proper capacity building to absorb and adopt the upcoming shocks and threat. As organizations of international reputations and sole responsibility, we organize Indooncology Summit to make the doctors for next 50 years, next generations ready and make them strong enough to deal with cancer. The second thing is liberalization. It's high time and the extreme need of liberalizations of organizations, associations, and societies. The time has come to think beyond the boundaries, limitations of societies and organizations and start networking, connecting with ideas, challenges, and solutions to them. So another most important aspect we deal is with proper networking and connectivity and repositories of ideas and innovation. We are coming up with different technologies and services where thought processes and ideas could be preserved, accessed, and these type of conferences could be available for international access. Coming to the vote of the thanks, I express my hearty gratitude to Honorable Organizing Secretary, Dr. Ghanshyam Biswas sir, everyone, the office bearers, the master of the ceremony, Dr. Romila Tiwari ma'am. We keep changing agendas, we keep changing sequence, and she handles it dynamically and smartly. There are a lot of people involved, my colleagues, especially Ranjan, Siddharth Bhai, Tushar Bhai, and it's very difficult to name everyone who have left no stones unturned to make this conference worth of attending. My apologies to everyone if I have missed anyone, but I believe this conference will give a wonderful experience and we all will stay connected ever. Thank you very much.
Thank you. So that was Mr. Rudra Bhanu Satpathy, founder and CEO of BioLeaks. Next, we proceed towards the panel discussion that is supposed to follow. I extend my heartfelt gratitude to each and every one of you on the desk for this, for being present here and inaugurating the ceremony. Thank you.
Are we going to start the next?
Present the mementos, Dr. Maharana. ये तो बाद में. So I would like to invite Dr. Sanjukta Padhi, radiation oncologist, to please join the desk as the chairperson of this session of brain metastasis in breast cancer. Dr. Prafulla Kumar Das, surgical oncologist. Sir, please come on the stage to chair the session. I'm sorry. You would like to be seated here, or can you please come to the stage? Moderator, Dr. Prasad Narayanan, medical oncologist. Can I have you on the stage? No, sorry, he's joining us virtually. Do we have him there? Yeah.
Good afternoon. Am I audible?
Yeah, you are.
And the slides are visible also?
Yes, they are. Can I call upon the panelists, Dr. Lalatendu Maharana, Dr. Ganesh Chandra Subudhi, Dr. Venkat Pradeep will be joining us on virtual mode, Dr. Lucy Patnaik ma'am, Dr. Arya Kumar Banidatta, Dr. Sutapa Biswas. Can I please have all of you on the stage?
So there is a change in one of the panelists' name, is it? Dr. Arya Kumar is a radiation oncologist?
Yeah, Dr. Arya Kumar is the radiation oncologist.
Sure, yeah.
Dr. Arya.
Can we start?
Good morning, Prasad.
Hello, sir.
Thank you so much for coming. Thank you.
So,
please go ahead.
Yes, sir. So, good afternoon, and I thank Dr. Biswas for this opportunity. Would have wished to be there actually, but many conferences, sometimes commitments are very difficult. And I would also agree to the previous, during the inauguration, I heard that Dr. Biswas is considered as an institution in himself. And we used to consider that when we were trained under him in Tata Hospital as well. So in the next half an hour or so, my job is to take you through some aspects of brain metastasis in breast cancer. So we have Dr. Lalatendu Maharana, Dr. Ganesh Subudhi, and Dr. Venkat Pratap, who are medical oncologists, Dr. Lucy Patnaik and Dr. Arya Kumar as radiation oncologists, and Dr. Sutapa Biswas, a pathologist. I will engage Dr. Sutapa Biswas in certain points, but mostly this brain metastasis topic is something which is core for radiation oncologists, is what I feel. So we will, there's a small change in the name. This was the initial name given to me. So we will start this, maybe we will divide it. We'll take HER2 positive metastatic breast cancer. We'll keep a template case there because that is the most common situation where we see brain metastasis in breast cancer. Then next that is triple negative. We will discuss about local therapy and systemic therapy. Also, whether we take decisions based on the disease being stable or active at the time of decision making, and some few points about other types of metastatic breast cancer, and then leptomeningeal disease, which is not uncommon in our practice. So why we are taking HER2 positive breast cancer? If you see this slide, it very clearly, this is a long-term follow-up data from the HERA trial, the landmark trial which established trastuzumab in the adjuvant setting, which shows that definitely without trastuzumab, the death due to CNS relapse is highest, and trastuzumab significantly brings it down, but still it is not very low. So that is the reason why we are discussing HER2 positive as our baseline case. So with this introduction, let us start the case. So it's let us take a patient who is HER2 positive, metastatic breast cancer, post chemo initially with trastuzumab, pertuzumab, and now on trastuzumab, pertuzumab maintenance for last 1 year. And a routine scan which was done after 6 months is showing that so patient has received trastuzumab, pertuzumab for 1 year, and there is only progression, asymptomatic progression with 5 lesions in the brain. So I will leave this question to Dr. Lucy and Dr. Ari Kumar. I'm sorry your name because I was putting the name which was given to me before. Apologies for that. We want you to discuss about SBRT versus whole brain RT in this situation, and how do you make this decision? Let us start with Dr. Lucy.
Thank you. You see here you are talking about 5 lesions. Now SBRT up to 3 lesions, very small. The previous session was on oligomets, extracranial sites. Now here we are talking about brain mets. Now when you're talking about brain mets with 5 lesions, the number of lesions, the site of the lesion is also going to matter. So if it is about maybe 3 very small lesions away from the critical area, away from the optic apparatus, the midbrain, the brain stem, I would go for fractionated stereotactic radiotherapy. But otherwise, I think if it is going to be 5 lesions, I'll prefer whole brain radiotherapy there. 5 lesions is on the higher side. Arya?
Thank you. So you actually feel that it is based on number and location?
Yes, yes. Yes, definitely, on basis of location. You can think of...
Do you agree with this, Dr. Arya, or do you want to, or you are a more, there are discussions on either side actually. This is a HER2 positive patient as for 1 year, the patient is in like CR with the ongoing anti-HER2 therapy. Do you want to give whole brain radiotherapy based on the number for this asymptomatic mets, or there are situations when even 10 lesions can be given SBRT? What is your take on that?
Yes, as the patient is asymptomatic, we will definitely try with, we will definitely go with the SRS. If at all the lesions are 3 to 5, then also there are studies which say SRS is more curative, and we give better neurocognitive function on SRS rather than trying for whole brain RT. Only whole brain RT can be considered in cases where the GC is not good. But in these cases, depending on location, size, and number of lesions, and the area of involvement and the critical structures nearby, we will give the patient the benefit of giving stereotactic radiosurgery, either fractionated SRS or SRT.
Okay, I think the message is clear there, and I will show some data also which supports this, this statement. We will go to the medical oncology team with this background. Assuming this patient is undergoing SBRT, which is what the patient underwent, I want all the 3 medical oncologists to comment on your change of treatment. Do you change of treatment based on this situation, or you continue? So let us start with Dr. Laltendu Maharana, then Dr. Ganesh, and then Dr. Venkat.
Like a progression is progression, so I would definitely see, I will be inclined towards changing the treatment protocol from trastuzumab, pertuzumab to, if trastuzumab deruxtecan is available, then I would like to go ahead with it. Otherwise, if it is not there, then LAPCAP or tucatinib or capacitabine with trastuzumab, I would like to change to, because progression is I would like to consider it is a progression only. And asymptomatic, I am not very much inclined towards RT now. Unless patient is symptomatic, I am not very much inclined. But if curative intent, SBRT can be done, that is well and good. I will definitely not go ahead with whole brain RT if SBRT is not possible, and I will definitely like to change the treatment protocol.
No, I have to, you have to be clear. This patient is asymptomatic.
Asymptomatic, therefore I would like to change the treatment, like systemic treatment, because it is progression. So systemic treatment I would like to change to either trastuzumab deruxtecan if it is available.
This is post SBRT or without radiation you want to change systemic therapy?
That is what I'm telling, sir. Like if SBRT is feasible, then after giving SBRT, I would like to change the treatment protocol.
Okay.
If SBRT is not feasible, I will not go ahead with whole brain RT. I'll just change the systemic treatment protocol.
I got it. So if SBRT is feasible, you will give SBRT plus change in systemic therapy. That is what you are saying, right?
Yes, sir.
Right. Dr. Ganesh and Dr. Venkat, any opinion on this actually?
Hello.
Yes. Dr. Ganesh, are you there? Are you speaking first?
Hello. Actually, if he is asymptomatic, we can consider TDM1 also. In one of our patients, one lesion was there. Here it is 5 lesions, but one of our patient doing asymptomatic patient doing well with the TDM1. So we can consider TDM1. And
No, the question is change of therapy or not. You will change.
Depending in Indian scenario, always you have to take consideration of cost. If SBRT will be given, then we can continue the trastuzumab pertuzumab also. We can consider with IT, MTX, this type of therapy. If the cost is not an issue, then we can consider change in therapy, TDM1 without RT. Second, if you're considering RT also, we can add TDM1 or lab cap, this type of regimens.
Sure. So Dr. Venkat, quickly on this and then we will move on.
Yes, sir. So I would like to discuss two options with the patient, sir, if you present in the status before SBRT.
Right.
The first option is SBRT, followed by evaluation of the extracranial disease, which was done by PET-CT. If there is no extracranial disease, I would like to continue the trastuzumab pertuzumab maintenance as such. There is no change of systemic therapy if there is no extracranial disease at all. And secondly, sir, if patient is not willing for radiotherapy or SBRT, then one of the good options, keeping in view that it is academic discussion, keeping financial and availability apart, tucatinib plus capecitabine and trastuzumab, that is the best combination where we might consider avoiding SBRT in view of asymptomatic patient and good performance status. That will be my case. So I can't hear you.
Am I audible now?
Yes, sir, you are audible.
But the presentation is gone, is it?
Presentation is gone.
Is it visible now? I'm sorry for this.
Yes, sir, visible.
So I heard you that you will try to, we will go ahead with this. So you will give an option of either continuing the same systemic therapy with SBRT, right?
Yes. Or tucatinib plus capecitabine plus
Got it. We will get into that. So this patient continued the same treatment. And now the question is how frequently we follow up with scans in this patient? What is the imaging of choice? This question I would want to go through the entire panel actually. So the radiation oncologist first.
Hello. In this case, if we have gone with SRS of brain, we generally follow every 2 monthly MRI or else 3 monthly MRI for brain disease. Rest of the time, PET-CT follow-up with after 3 months.
Okay. So, any comment from medical oncologist on this, whether you will follow up with PET-CT or you will follow up with MRI?
Because the site of disease is mainly brain, it will be MRI cells, both to know the response and progression.
Sure. So, you will be ending up doing both an MRI of brain plus a body scan, right?
Mainly MRI every 2 monthly and PET-CT as and when needed, sir.
Fine. Any other opinion on this?
Like both MRI and PET scan every 3 monthly, and otherwise if patient is symptomatic, any suspicion of progression, then only we will go for an imaging.
Right. So the only person missing in this multidisciplinary group discussion will be a neurosurgeon. So when does the neurosurgeon come in picture in such situations?
I think when like intracranial pressure is high, the patient is very much symptomatic, large tumor, there is shift up, midline shift up more than 1 centimeter, and we can decompress the tumor and patient will be relieved of the symptoms, then that is one indication. Another indication is peripherally located tumor, no extracranial disease, and single or I think less than 3 they usually consider, not deep-seated. It's peripheral location tumor, they can operate it out. That is another indication.
So I will go to Dr. Sudapa. I thought of asking her this question. How frequently you get a brain metastasis specimen from breast cancer, and then you have to do some tests to prove that, like in lung cancer, we have seen many times the neurosurgeons have taken out something from the brain and it is diagnosed as lung cancer. Do you have any experience like this in breast cancer also?
Yes, sir. Like many a times we end up getting specimens like pathological, histopathological report operated for the brain lesion and came out to be either lung primary or brain primary. The thing is that when patient ends up with surgeon, they will operate without doing any imaging also. Many times, like it has been the trend, like patient ends up with neurosurgeon, they will operate it out.
Can we get Dr. Sutapa's comment on this?
Hello. Yes, we see brain specimen of metastatic breast cancer very rarely actually. Sometimes we get CSF also. In that also we can detect the malignant cells. But yes, since triple negative cases and HER2 positive cases are known for brain metastasis, so it is always good to go for debulking to see the HER2 status so that the treatment can be modified. If it is negative, again, usually the same thing carries on, but sometimes HER2 can change also. That will be good for the patient for treatment.
Sure, thanks for that. So once a patient undergoes brain metastasis surgery, do we give the patient post-operative radiation or either SBRT or whole brain radiation? What is, I mean, this is the data, I just put it there for discussion, that there is no change in difference in overall survival, whether you give SBRT or whole brain radiotherapy post-radiation. Dr. Lucy, can you take this up?
Yes, the studies and the evidence always says that surgery alone versus surgery followed by adjuvant radiation, the modality using adjuvant radiation is always better, and surgery followed by SRS is always now the standard of care. Instead of whole brain RT cannot be done in say solitary metastasis. So here SRS or maybe fractionated SRT is the standard of care now.
Sure. So we continued this patient on same treatment, and in 6 months time, the patient has, but 6 months is reasonably good time in this patient with the same treatment. We have progression in brain as well as liver. So what do we do now? Do we treat the brain with SBRT? You give whole brain radiation? You give only systemic therapy change, or you give systemic therapy plus radiation? So we will start with Dr. Arya, then Dr. Lucy, and then the medical oncology team.
Hello, in this scenario actually, after 6 months of progression disease, now the what are the size we have, what are the sites for metastatic areas we have to see. In with this regard, we can think of, as the patient is asymptomatic, systemic therapy is preferred in this case, and whenever radiation is required for symptomatic disease, persistence of symptomatic disease, then only we'll try with radiotherapy. Otherwise, systemic therapy is the treatment of choice. If at all the gap is more than 6 months, then we can think of giving SRS or stereotactic radiotherapy to brain.
Sure. Any other comment from Dr. Lucy on this?
Yes. As I answered in your first question, actually, when you are trying SBRT, the selection which matters is the size of the metastasis and the location. If the size is very small,
These are, let us keep this as all confined to a very small part of the brain.
Yes, and here patient is asymptomatic and the lesion is far away from critical organs like midbrain, pons, and your optic apparatus. Then why not SBRT again? Yes.
And the medical oncologist, you will all change systemic therapy, I'm assuming, in this situation,
Yes, sir, like
right?
now, though, definitely I would like to change the systemic treatment. Like in the previous scenario, there was an option of continuing the same treatment if SBRT. Like,
Right. So here we will restrict now to the 3 medical oncologists in our group because we heard partly about the options here. So let us start with Dr. Venkat here. What is your, if all these drugs are now available with you, assuming that, what is your drug of choice and why?
So as medical oncologists, usually we depend upon data to tailor to sequence drugs. But we know that you have to, at this juncture, relapse after 6 months of our 2 exposure therapy, that to dual antibody. There is no ideal scenario here, but because there is a progression in the brain and as well as systemic relapse, I want to use a drug which has activity in both the areas. So tucatinib, capecitabine will be my take, along with trastuzumab, of course.
Fine. And any other, Dr. Ganesh, what is your choice and why?
If the cost is not an issue, then tucatinib, trastuzumab, tucatinib, capecitabine, neratinib option, these are the options. If your cost is not issue, also TDM will also take care of the lesion. One of our patients doing well with liver and brain mets, doing well. Slight modification, LFT slightly derangement occurs. TD1 also, we have a patient of 2 years, more or less 24 doses of TD1 the patient has taken already. So why not TD1? It's we have experience enough.
Dr. Lal Tendu?
Like I would like to prefer trastuzumab deruxtecan first, and after that tucatinib, capecitabine, trastuzumab, and followed by like in this order I would like to keep.
Why do you want to prefer trastuzumab deruxtecan as first step above tucatinib?
It has got CNS penetrance as well as it will act in the systemic disease as well, and it has got the better data as well. So that's why.
Right. Now, same question to all the medical oncologists, because we will not have trastuzumab deruxtecan and tucatinib, even neratinib in our practice. What is your practice? Dr. Venkat, in this situation, what would you have started? This is not based on the data. This is just in practice. What are you doing in this patient?
In my setting, what I do in this scenario with after SRS and with a systemic failure, I usually add chemotherapy to the targeted therapy, so trastuzumab, and then I will continue the same.
Not TDM1.
So,
TDM1.
Sir, in my setting, TDM1 is still not affordable. So
Fine.
that is
Fine. Then Dr. Ganesh and Dr. Lal Tendu.
So practice is like I would, because if I can avail TDM1 also, I will go ahead with TDM1. Otherwise, lap cap. But thing is, lap cap is a very toxic regimen. I find it very toxic. I cannot usually give full dose of lap cap. I usually prefer to give.
Got it. I mean, nobody gives full dose of lap cap. It's impossible to give. Dr. Lal Tendu, last comment from you. Then we will just go through some data on this same point.
Sorry, sir.
No, Doctor, we will proceed, or any other comments from any of the medical oncologists on this point?
One point we can take that we have to liver lesion all there. We should do a biopsy at least now. Again, re-biopsy what status is maintained, or so much of expenditure this will going to add. Then we have to re-biopsy the lesion, liver lesion there is.
Sure. So that's an excellent point, actually. So I will just take you through some small one slide data on all these options, which we have said. So we all have this feeling about lapatinib capecitabine being slightly better than trastuzumab capecitabine in brain metastasis. But this was a phase 3 randomized trial which tried to recruit patients to see whether this is true. Specific question asked of CNS progression. This trial was closed early because of futility in the lap cap arm. So it is not an easy treatment, as the panelists have already mentioned, but the CNS activity specific as compared to trastuzumab capecitabine is not tremendously different with LabCap. That is one point. Second point about neratinib, definitely neratinib is better than lapatinib in this group. There is no doubt about that. We can see the data there. Overall outcome is also better, and CNS-based outcome is also slightly better, but it is not like light years different than lapatinib and capecitabine in terms of CNS control. But here, this is the neratinib may delay the onset and reduce the incidence of CNS metastasis as compared to paclitaxel. So what we see from these two sets of data is that possibly capecitabine combination is extremely important for any anti-HER2 TKI if you are considering them for specific action towards the CNS activity. And here it's a clear winner. The panelists were all very clear that if they have tucatinib with them today, they will use, because we have not seen this kind of graphs in CNS activity specifically in any metastatic disease, and tucatinib definitely, and this trial specifically had patients who had brain metastasis. And if you take the patients who had active brain mets, these are not the patients that get asymptomatically, there also there is an exceptional improvement in outcome, 64% reduction in risk of CNS progression or death if you actually give tucatinib other than placebo. So definitely tucatinib, trastuzumab, capecitabine, if it is available, is the ideal choice for our patient. And time to onset of new brain lesions or death also, there is a flat line after some time. So if the patient doesn't have a progression after 5 to 6 months, they don't seem to progress in brain if you are able to give tucatinib. So definitely a winner there. The TDM1 we all discussed. We use TDM1 in our settings because now TDM1 cost also has come down in India. So, but the incidence or the effect as compared to tucatinib, it is nowhere there actually in terms of brain metastasis. And trastuzumab deruxtecan, though it is the most talked about drug in anti-HER2 therapy, this trial, if you take the brain mets alone, active brain mets control, this was not as prominent as the data is not as prominent as we see about the tucatinib data. It is exceptionally good in terms of systemic control. Our patient has liver metastasis progression as well. So it has to be kept in mind because one of the panelists mentioned that the preference will be to give trastuzumab deruxtecan first. I would agree. Maybe that is the right choice. We don't have a randomized trial, but this is just some comments based on the data. So what are the ASCO guidelines in HER2 positive brain mets? Routine surveillance with imaging in the absence of symptoms is not recommended. Low threshold for performing diagnostic brain MRI if any neurological symptoms suggestive of brain mets. Our panelists have very clearly mentioned this. And if the systemic disease is not progressive at the time of brain mets at diagnosis, systemic therapy should not be switched. This also we discussed. And those who have a systemic disease progression, the choice of therapy from whatever we discussed now should be taken with based on the certain criteria which we discussed. And in India, finance is one of the most important criteria. Now, only another 5 minutes I will take. So this is about hormone positive HER2 negative disease, another group of set of patients where we see here is CNS disease a problem? Do you see CNS disease in hormone positive HER2 negative breast cancers also? We can start with Dr. Lucy.
I think it has to be an individual patient-based thing. We cannot draw a conclusion for the whole. This has to be an individualized patient-based thing.
No, do you think that the CNS disease is a problem in hormone positive HER2 negative patients as well, like what we discussed in HER2 positive patients?
I really don't.
Dr. Venkat, can you take it? Do you see, do you deal with them?
We occasionally see some, not like other two subsets of HER2 and NBC, but we have 10 to 15% patient approximately, you can say but it's majority in the advanced stage, nodal positive and all those patients.
Right. Dr. Arya, in these patients, since the systemic therapy, since it's not a very common thing to have brain mets, a patient who is having brain met has already been selected as a poor risk patient. Is there an early shift to whole brain radiation in such patients, or you still can consider SBRT as a treatment?
Hormone positive HER2 negative disease is a good prognostic marker or good prognostic indicator for metastatic breast disease also. That is why if there is CNS involvement or brain mets is there is no need to early shift the patient for whole brain RT. If patient is symptomatic or single or two brain lesions develop, then we can give the benefit of stereotactic radiosurgery or stereotactic radiotherapy.
Dr. Ganesh, question to you. In hormone positive HER2 negative disease, metastatic disease, we prefer to start on hormone therapy and keep on hormone therapy as much as possible. But if a patient has brain mets, do you think that you will shift towards chemotherapy as the first option in these patients?
Yes, before that, actually we should think that hormone positive and HER2 negative, usually these patients do not have brain mets. So we should think that there is a change of status of HER2 or if hormone or they are not. As for that, we should think about, we can do, if we do a biopsy, then definitely we should consider a biopsy. Second, then treatment, we don't have much of treatment which will penetrate the brain. So definitely we should consider change of therapy. Before that, we can consider radiation, and capecitabine based therapy can be considered in this patient.
Right. So that, since you are on that, let me come to
Can I add a point in the hormone positive?
Sure. I think my time is up, but I will take 2 minutes, please. Yeah.
Sure, sir. So the reason for metastasis in hormone positive is mainly extracranial disease compared to HER2 positive disease, where there is an affinity for the cancer cells to enter the CNS, even when there is no extracranial disease. So if there is extracranial disease, we should add chemotherapy to control the in hormone positive disease.
So last point will be leptomeningeal disease, which we see in many situations. What is the Dr. Sudhapar, do you see CSF samples is coming for diagnosis in breast cancer patients? Do you do some special markers in that to see whether it is from breast cancer? Is there any experience like that you want to share?
Yes, we have seen certain cases of CSF mets in CA breast case, and we have done cell block study, and we have subjected for again ERPR HER2 status, and accordingly the treatment was modified and given to the patient.
So cell block can be used to get ERPR status even from CSF. That's an important point to take. Last question will be to Dr. Lucy. In leptomeningeal disease, role of craniospinal radiation, if you have ever done or you have any suggestion on that, and the newer techniques of radiation like proton therapy in such patients?
We don't have any experience on proton, but what we have seen and what we've read and what we have seen also, when we do a craniospinal irradiation, that is except medulloblastoma, that is only with a proof of CSF positive for malignant cells. Only in cases of CSF positive for malignant cells will we go for a CSI. And knowing the technique proton uses of the Bragg peak, that is the entire high dose is delivered at your site, and beyond that, beyond the target, the dose comes down to 0. So that's the beauty of proton. It's being utilized in some of the centers in India. So yes, proton is an option, and those centers who don't have proton, they also use very good VMAT, volume modulated arc therapy, and IGRT to add on it. So proton is not just the only answer for a CSI. There are other techniques also available also in Orissa.
I think if I don't stop now, Dr. Bishwas will call me and say something. So with that, I thank all of you for a very interactive panel, and thanks for having me today. Thanks a lot.
So thank you, Prasad, so for a wonderful moderation. Dr. Senapati sir has a question.
Good. It's a nice discussion about the brain met. So few points that I can highlight, because basically I am a radiation oncologist. During our early days of practice, when we think that yes, it's a brain metastasis, go for whole brain RT. But the science has been changed. If you go through the guidelines of the International Society of SRS, the guideline is very clear that if patient is asymptomatic brain metastasis and some targeted therapy is available. There is no scope of radiation, very clear. Second option, if patient is symptomatic and having 1 to 4 metastases, then you can go for the SRS. I understand when the time was there, brain metastasis, you are going for SRS. In private setup, it is around 1 lakh or 1.5 lakhs. No, but the science is something different and practice is something different. So if it is 1 to 4 CNS metastases, go for SRS. But if the lesion is increased, if it is more than 30 cc or large size, then you can go for the combined modality, either SRS and or whole brain or combination. So that part is about the radiation. Next, the question is after surgery. Yes, after if it is isolated metastasis, surgery has been done, then you can go for cavity irradiation by SRS. Role of surgery, if the primary is not known, then there is established role of surgery. And second option, that if the lesion is larger or bigger size, then you can go for the surgery. And regarding the hormone positive and also triple negative, the literature is not clear.
Thank you so much. Dr. Sanjukta, anything to say?
Analyst also discussion is very good. This is open for
Pikeda sir.
In CA breast with brain meds, so there is no role of surgery. I am a surgical oncologist, and this concept is there since so many years. But now with the more understanding of the molecular subclassifications, so things are getting into more clarity, and a few subset of patients like luminal A variety, HER2 positive variety, and with coming up of all new agents, very small population might require surgery of debulking versus SRS. So it is all debatable, and literature says data are very far from remote. So I think almost there is no role of surgery in brain meds after the CA breast.
So thank you, Prasad. Thank you, Chairperson. Thank you, panelists. So before we move to the next session, so the quiz, please. So before we go to the Novartis session, so we'll So 3 questions. The quiz one, please. First question. So name the trial. So this is going to be a post-lunch session. So advanced classical Hodgkin's lymphoma, more than 1,000 patients, randomized to a standard ABVD versus ABVD. So B is replaced with a anti-CD30. So what is the trial? From the left-hand side. Anyone? So raise your hand. Please. Pardon me? Wrong. So RATH1 was a de-escalation. So this is not a de-escalation trial. Anybody from the middle row? Anybody from the right hand side? Echelon trial. So Dr. Lala Tindu. So please. So this is an Echelon 1 trial. So we should take out 100 rupees from that 500. So next question, please. So what is the cause of hypercalcemia and lymphoma? So is it tumor lysis, what we normally say? Is it vitamin D depletion, vitamin D overproduction, serum PTH secretion? So again, we start from the left hand side. All backbenchers, anybody? Yes, ma'am, please. PTA secretion. Anybody else? Anybody differ? Vamsi. Absolutely. So, Vamsi. So, next question. So, an hematology question. So, all CML lovers. So, MMR is defined as BCR level below 10%, 1%, 0.1, 0.01. Middle row. एक मिल चुका है ना? एक नहीं कुछ anyone? Sir. Use your mobile, Google. जल्दी कर लो क्या? No answers? So from the pharma friends, there are people from Novartis also, they should tell. So this is also from lab people can also answer. No second prize, that's why I'm not. So anyone, any guess? 10, 1, 0.1, 0.01. 0.1. So Rudra 0.1. So thank you so much. So now we move to the next session.
So the next session is Getting Real with Ribociclib. It will be presented by Dr. Chandrakant MV. Please come onto the stage to proceed with the session. Sorry.
Well, good afternoon, everyone. So we had brainstorming sessions, on brain mets, and then we had debate on whether to use adjuvant CDK4/6 inhibitor, and now it's about metastatic setting, ribociclib, real-world data. So this is one of the second CDK4/6 inhibitors that came into practice, and let us see how it is different from the existing CDK4/6 inhibitors and how real is the evidence with ribociclib. So it's very important that a phase 3 clinical trial data is replicated in a real world data. Unless it is replicated, to accept it in a bigger group of population is difficult. Therefore, real world data is extremely important, because real world data reflects the actual scenario. It doesn't include that selected patient group population which are doing good with an excellent performance status. It does include difficult to treat patients, heavily pre-treated patients with a compromised performance status. Therefore, real world data becomes important before we accept it completely. So let us get real with ribociclib in the coming 10 minutes. Okay. Okay, so when you consider treatment of any metastatic disease, most important endpoint is how long the patient lives. So overall survival is the most important endpoint for any advanced metastatic disease. So it is not just how long the patient lives, it is also how well the patient lives. That is quality of life. So the two gold standard endpoints for any metastatic disease is overall survival and quality of life. So this is one of the rare drugs in oncology where you have got overall survival benefit in a metastatic setting and with a preserved or an improved quality of life. So to get an overall survival is a challenge in the present era, because if you have a PFS1 and you have multiple subsequent treatment options, the first PFS is diluted by subsequent PFS, and the overall survival gets diluted, and there is crossover also. Therefore, if you really get an overall survival, that means the drug is really effective, and it is the test of efficacy and tolerance of this particular drug. So therefore, overall survival is a gold standard endpoint for any of the clinical trials in any of the situation. So for an advanced breast cancer, ribociclib is one of the drugs which has shown persistent and consistent overall survival in all the 3 clinical trials. I'll just show you. So this is one of the wonderful slides we will look into whether you place it in the first line setting or in the subsequent line setting or in the premenopausal setting. This drug has consistently shown overall survival benefit and the magnitude of benefit is significant in contrast to the other CDK4/6 inhibitors. Palbociclib did not show overall survival difference. Abemaciclib did show overall survival difference in the subsequent line Monarch 2, and the Monarch 3 overall survival also is impressive, however, not statistically significant. So, but the magnitude of benefit is really good as far as Ribo is concerned, of course, Abema too. So you have consistent overall survival in 3 big randomized trials of Mona Lisa 2, Mona Lisa 3 and Mona Lisa 7 is significant, and that's the reason why the magnitude of clinical benefit scale recommendation from ESMO is so good with this particular drug. So if you look into the median overall survival at 5 years with first line across endocrine therapy partners in irrespective of the menopausal status. So if you look into the chance that a patient with a 4th stage ER positive breast cancer stays for 5 years is more than 50%. You can see the 60 months mark is crossed in all the 3 scenarios when you use in first line, whether it is Mona Lisa 2, 3 or 7, whether it is in subsequent line or in the first line, or whether in the premenopausal setting, you are able to beat that 5-year mark of median overall survival. So there was a time when we spoke of overall survival for a metastatic breast cancer was 9 to 12 months. But here we are seeing a median overall survival of 5 years, which is a phenomenal achievement in oncology, especially in this HR positive space. So having an overall survival difference is a real test of the drug, of the efficacy and tolerance of the drug. So let's go into what is, so this is the phase 3 data which we had in the subsequent line, first line and in the premenopausal setting, and let us see what is the real world data we have as far as ribociclib is concerned. So these are the 2 real world data which I will be speaking of, and just look into the number of patients that are there in the real world. 3,000 odd patients in the complement study, and in the Ribana study it's 2,500 patients. So large number of patients looking into endpoints just like the randomized controlled trials. So all the scenarios, first line, subsequent line, endocrine partner, whether it is AI, fulvestrant, all these are included in this particular real world studies. So if you look into the patient selection, you know, it is not just confined to the clinical trial strict criteria. It has included pre-chemo treated patients, it has included patients pre-menopausal, post-menopausal, that's included patients who have different endocrine partners. So just reflecting how real the data of these patients, therefore real world data becomes more relevant than that of the phase 3 randomized trial data. So this is what I was thinking, you know, if you look into the randomized clinical trial, ECOG PS2 is excluded, brain mets will be excluded, pre-treated chemotherapy will be excluded, but here you can see all these being included. A diverse large patient population was included, even with compromised performance status and with a CNS disease, premenopausal status, diverse race, age, all these were included. So you can see the safety profile of ribociclib. So ribociclib among the 3 CDK4 inhibitors has the narrowest spectrum of action. What we want is a profound CD4 inhibition and less CD6 inhibition and less off-target effects, which is attained with ribociclib when compared to Palbo and Abema. So Palbo has more CDK6 activity, therefore neutropenia is more concerning. Then when you come to Abema, it has more off-target effects, therefore you see fatigue, diarrhea, being said, it has more of anti-CD9 activity. So if you look into ribo, it is unique among the three in that it has the narrowest spectrum of activity, least toxicity, and relatively less neutropenia, and is well tolerated. That is the uniqueness of ribo when compared to the other two existing CDK4/6 inhibitors. So this is the time to treatment progression. You know, if you look into the numbers, it is just reflecting the randomized trial data, again saying that even you use this drug in the real world, the data is in par with the published randomized controlled trials. So this is the response rate, you know. If you have chemo, so we have evidence of chemotherapy in HR positive breast cancer. The response rate is in the time of 35 to 40%. But look into the response rates with measurable disease, above 60%, you know. 50-60% responses just with endocrine therapy is really phenomenal in those patients who have measurable disease. 40 to 50% responses with measurable disease. So this is much better than any chemotherapy backbone. If you look into anthracycline monotherapy, anthracycline taxane combination, you have response rates of 35 to 40% in the HR positive subgroup. And if you use an endocrine therapy alone, the response rates are much better than chemotherapy. So CNS, so the moment we said of CNS disease, we always thought abemaciclib has an excellent data for CNS activity. However, if you look into the complement study, the CNS activity has been proven even with ribociclib. Ribociclib also has shown promising CNS efficacy. And if you look into the median time to progression in those patients who had CNS mets was not reached. And you can see the median time to progression in different population. In those patients who had received previous chemotherapy, compromised performance status, in all these subsets, the hazard ratio for survival is significant, and it is in par with the published data. So this is the improvement in quality of life. It is not how long the patient lives, it is how well the patient lives. And you can see different parameters of physical functioning, emotional functioning, all these are improved when you use a CDK4/6 inhibitor. And this is the Ribana study. This is another real world study. Again, showing similar numbers. You can see different spectrum of patients who has CNS mets, compromised performance status, menopausal status, and so on. So even this also shows the numbers that are consistent with that of the randomized trials. So you can see the PFS crossing 2-year mark. So you put a patient on tablets, the chance that the patient remains progression free for 2 years, you know, is more than 50%, and that's the data we have when you put these ribociclib in the armamentarium. And this is the toxicity profile, very well tolerated, less off-target efficacy. So this is the data of median progression-free survival of real world and the randomized controlled trial, everything in par, 26, 31, 25, 27, 33. So just to say that we are reassured with the real world evidence, and it is in par with the randomized controlled trial. So these are the guideline recommendations of ribociclib. So all the 3 CDK4/6 inhibitors are approved in the metastatic setting. In the present day, we must offer CDK4/6 inhibitors for all patients with HR positive metastatic breast cancer. So this is the magnitude of clinical benefit scale from ESMO. I would ask you to look into the MCBS score of 5 for premenopausal patients. So ribociclib is the only CDK4/6 inhibitor which has Mona Lisa 7, specifically addressing the premenopausal population and having an overall survival benefit, and that's the reason why the MCBS score is 5, which is highest for ribociclib. And because of the overall survival benefit, it has very impressive MCBS score of 4 in both first line and subsequent line setting. So, are the 3 CDK4/6 inhibitors similar, or are they different? This is what I was speaking about. Very important is the preferential CDK4 inhibition. which is more important, and less CDK6 inhibition. If you have less CDK6 inhibition, there is less neutropenia. So therefore you must have more CDK4 inhibition and less CDK6 inhibition. And number 2, off-target effects, especially the CD9 activity or the other off-target effects which cause diarrhea or fatigue, that should not be there. So ribo is a drug which has preferential CDK4 activity and less off-target effects, and therefore it is well tolerated, in contrast to the other CDK4 where there is more CDK6 activity and more off-target effect. Therefore you will have interstitial lung disease, venous thromboembolism, and so on. So this is the availability of ribo, abima, and palbo. Rough comparison, but looks like ribo has more CDK4 activity and more bioavailability when compared to the other two. These are indirect comparisons and cannot be commented bluntly. So, but this is the data we have preclinically. So to summarize and conclude, so ribociclib is the only CDK4 inhibitor as of now to have shown consistent overall survival benefit in all the 3 scenarios. Frontline in combination with AI, first line setting, overall survival, Mona Lisa 2, and then Mona Lisa 3 is where you have overall survival benefit in the subsequent line, and then Mona Lisa 7 in the premenopausal women. In all the 3 subset of patients, you have overall survival benefit with an excellent ESMO MCBS score of 5, 4, and 4. And the toxicity profile is impressive, and the real world data reassure us that the progression-free survival is in par with the published randomized controlled trials. So with this, I would conclude by saying that we must use CDK4/6 inhibitors for all patients. When you look into a subset of patients of premenopausal with impressive MCBS, ribociclib will score over the other CDK4 inhibitor and has a better toxicity profile. So with this, I would thank all of you for your patient listening, and I would be happy if there are any questions to take.
Thank you, MB. So now we move to the last session before the lunch. So that will be a Eli Lilly session. So Dr. Shyam Agarwal sir from Delhi will be joining virtually, and Dr. Vamsi Krishna from Hyderabad, who was virtual yesterday, today he's on a physical mode. So over to Shyam Agarwal sir. So he will start with disease burden and unmet needs in HR positive, HER2 negative EBC, current trials in the EBC setting. Sir, please unmute, sir. Shyam sir, please unmute. So you are seen, the slides are seen, but you are need to unmute, sir. You need to unmute. Yeah, okay. Right, sir. Please.
Okay, so good afternoon, everyone, and thank you, Dr. Ghanshyam, for this opportunity. So I think this is the last pre-lunch session, as I'm told. We're going to discuss a very important development in the field of adjuvant therapy of early breast cancer for patients who are hormone receptor positive. So the session is divided into 3 parts. I'm going to speak first, followed by Vamshi, and then we will have some brief panel discussion. So can I have the next slide, please? So I think as has been explained, CDK4/6 inhibitors are extremely crucial these days in the management of patients with breast cancer who are hormone receptor positive and HER2 negative. Can I have the next slide? So this is a sort of unmet need which we have, which I'm going to explain to you in the HR positive EBC setting. Next slide. So, this is what has happened very recently across the globe, including India, that in addition to metastatic disease for HR positive, HER2 neu negative breast cancer in the metastatic setting, Remiven or abemaciclib was approved. And now you have the approval for early breast cancer, high-risk patients. Next slide. And that high risk is defined by two things which we will come to in detail. One is, of course, the tumor size or the lymph node positivity, more than 4 nodes positive, or if 1 to 3 nodes are positive, then the tumor size and the grade of the tumor has to be high grade. So just, trying to introduce the risk factors for recurrence in breast cancer. They, as I said, are related to the tumor size, the grade of the tumor on histopathology, the number of nodes involved, the Ki-67, ER/PR, HER2 neu positive or negative, age of diagnosis, and so on. Next slide. So these are various sites of recurrence, as we all know, bones, lung, liver, and brain, and of course the locoregional nodes. Next slide. So these are very preliminary, and now, we understand the biology of the disease much better than before. And luminal A and B, as you can see in this slide, have a high propensity to spread to bones as compared to triple negative or HER2 neu positive. And similarly, there are differences in the CNS involvement, which is relatively uncommon in luminal A and B, and most common in TNBC and even in HER2 neu positive. And liver involvement is also uncommon in the HR positive breast cancer. Next slide. So I think we need to understand that there are subtle differences in the biology and the behavior of the breast cancer depending upon the intrinsic subtype. Next slide. Okay, so although we have, made tremendous progress in the management of early breast cancer, but I think we still have a huge burden of relapses, especially in high-risk situations and depending upon the intrinsic subtype. And as we all know, triple negative and HER2 are the worst. And of course, HR positive do better, but still it remains an unmet need. Next slide. So, this is a very important slide. I think that is where a lot of pharma companies also focused based on this particular curve, because depending upon the stage, you see this hump, which is maximum in the first 2 to 3 years. So, and as you see on the other side of the slide, if the node positivity is there or the tumor size is big, that difference is even stark. So the idea is to bring down this hump or this recurrence rate by attacking the tumor cells, which are, sort of in a dormant stage in the first 2 to 3 years. Because as we understand from tamoxifen and AI, there is likely to be a carryover effect also. So this understanding of maximum relapses happening in the first 2-3 years has driven physicians and pharma industry to join hands and decide on the drug duration and the type of drug to be given. I think that is very critical to understand, and that is more so in high-risk individuals who have more than 4 nodes positive or patients who are in stage 3. Next slide. Next slide, please. Okay, so again, you can see depending upon the histology grade and the tumor size and the nodal status, the relapse rates, they continue to, go higher, especially if the number of nodes are more than 4 or if the tumor grade is high. So, those are very important factors which will help us in designing protocols to which patients should be included in an adjuvant study. Next slide. So I think this is where we are at this point in time, because we use tamoxifen, AIs, LHRH agonists, and use 8-9 year or, instead of 5 years therapy, But still, as we know, as I showed you in high-risk patients, it still remains an unmet need because the relapse rates are fair. Next slide. Almost 20 to 30% patients will relapse. Current trials in EBC setting would include, next slide. So we're focusing on the HR positive, HER2 negative subgroup of patients. And as you can see, the PALAS trial for 2 years Palbo, Penelope B 1 year Palbo, and Natali for Ribo 3 years. And I think what we're going to focus on in the next few minutes is the Monarch E. So the idea is to make you understand a little bit on these 3 inclusion criteria and some results of the trials. Next slide. So this is the Penelope B study in which 2 years of palbociclib was given in the adjuvant setting. You do see here in the first 1 to 2 years the separation of curve, but then towards 3 years and 4 years these curves they start overlapping. Whereas in PALAS the curves are absolutely overlapping in terms of the invasive disease-free survival. So this is an important curve to remember because this is a negative study because the effect of the drug did not last beyond a couple of years. Next slide. So these are like the subtle differences between, so Penelope actually they gave only 1 year of the drug, that is palbociclib, and they included high risk, whereas in PALAS you had moderately high risk and they gave the drug for 2 years. And there was no difference in the p-value or in the hazard ratio. And those 2 trials of Penelope B and PALAS were reported as negative studies, even though you had a follow-up of more than 40 months in Penelope B and 23.7 months in PALAS. I mean, you do have a positive outcome, which we're going to be sharing with you in detail. Next slide. Okay, so this is the Monarch E study where you see the difference which is statistically significant, and we'll talk about it in the next lecture. And the lower part of the curve is actually a zoom-in study or the zoom-in curve, and you can see these curves, starting to separate almost at, almost at 3 to 6 months. So which means that's, giving abemaciclib for high-risk individuals, as we will define, and we've already understood more than 4 nodes positive or with high-risk features, the curves, they start separating at 6 months or even little earlier than that. So that's a huge result for invasive disease-free survival for patients with abemaciclib in the adjuvant setting. Next slide. So I think the previous speaker was also mentioning why is it that Palbo and Abema are behaving differently in spite of giving the drug for 2 years. Maybe we will have the discussion whether it is continuous dosing or certain other features of inclusion criteria in the study which were done. So, but I think, and of course, the off CDK4 effect may also be contributing to the differences. Next slide. So I think the point, this is my last slide, to say that Abema has been reported as a positive study in high-risk HR positive individuals in an early breast cancer setting. And this is really going to be a boon for our patients who present with this scenario. So I think with this, I stop here. And I invite Dr. Vamshi for giving his presentation on the Monarch E study in more detail. Thank you.
Good afternoon, everyone, and thank you, Dr. Shyam sir, for setting the stage for me to go ahead with the real blockbuster trial of the recent times. I think this is one of the first adjuvant trials that has come out in probably the last decade or so that is likely to herald a change in our management of adjuvant breast cancer HR positive. So the importance of this really cannot be overestimated. We are aware already of the studies in the metastatic setting. Okay, so this is as usual. Is it not working? Could I get some change? Okay. So the idea of the CDK4/6 inhibitors has been around now for the past few years. Again, 4 years back we were just talking about, is a CDK4/6 needed, is it needed in the second line, and by now we know it is mandatory in the first line. The logical progression of this is to use the CDK4 inhibitors in the adjuvant setting, and possibly 5 years down the line we are going to be talking about neoadjuvant setting as well. I mean, that's what I feel. So the adjuvant setting, as Dr. Shyam had told us, the first of the block was palbociclib, where the results are, well, kind of mixed. And now we have the Monarch E data, which is possibly going to, which I'll be presenting now. Now the idea of why abemaciclib should be used. Adjuvant abemaciclib will probably add to the efficacy, and this Monarch E study, initially we found that there was a statistically significant improvement in the outcome, but the criticism was that the median follow-up was only 15.5 months. Later there was a second analysis which came at 27 months follow-up, and after that we also know about the whole Ki-67 story, which is being included as a kind of a follow-up. So this is the design, and for me the entire part about Monarch E is kind of summarized in this single slide. For me, this is the most important slide that explains where abemaciclib has to be used. Look at the population. HR positive, HER2 new negative patient. There are two cohorts. 90% of the patients were in something called a cohort 1, which includes patients at a high risk of relapse. What is this high risk? Logical, something that we know instinctively, patients who have more than 4 lymph nodes positive. Right now, again, it's sometimes difficult to count the number of lymph nodes if you're giving neoadjuvant therapy. By and large, you have multiple nodes palpable, you know it's more than 4. You have a scenario where you would like to give a neoadjuvant status, neoadjuvant chemotherapy based on nodes, you do expect them to be more than 4. Or you have 1 to 3 lymph nodes only in the axilla, but you have one of 2 risk factors. What are the 2 risk factors? Size more than 5 centimeter and grade 3. Okay, so these are very, very crucial things. Grade 3, size more than 5 centimeter, 1 to 3 lymph nodes, anything more than 3 lymph nodes. That group is 90% of the entire population, and that group is where we will be focusing on. The second cohort is more of a regulatory cohort, where they included patients with key index of more than 20%, and that whole subset is still not mature, so I am not going to talk about that today. The randomization was fairly simple. Give 2 years of abemaciclib. Dose is standard, 150 milligram twice a day, continuous dosing, no need for a break, along with endocrine therapy, which could be either tamoxifen or AI with ovarian suppression or without ovarian suppression. In effect, a very standard treatment. You want to get for 5 years, you are good. You get 10 years, that's good. But start the abema, and in this trial, they actually allowed it to be started for more than a year. So almost 16 months after surgery, you could still start the abema. So that was allowed in this study. Follow-up period was there for a longer period of time. The primary objective is something called IDFS, which is invasive disease-free survival. Now, again, a lot of discussion has happened on this. We need to understand that when there are endpoints used, overall survival is simple. But a lot of other endpoints have been used, and by and large, over the last 5 to 6 years, we are now seeing this thing called an IDFS. What does this IDFS mean? Go back to older trials. They have used any description of DFS, which includes things like locoregional recurrence, things like contralateral breast recurrence, second primary breast cancer. Multiple things were included in different trials. So it's not that everyone followed the same definition. Now, since 2007, we have this so-called STEEP criteria, which is essentially a standardized definition. Now, in that, they have included around 6 to 7 different kinds of endpoints and recurrences to define this IDFS. So, IDFS is not something new, it is not something unusual, it is pretty logical, and that endpoint is what has been used for the Monarch E study. People who have been following trials will know that a lot of the metastatic setting, many of the adjuvant settings are using the same IDFS. So in fact, all our immunotherapy trials have kind of gone into the IDFS criteria now. So IDFS is a pretty standard endpoint, and again, as an endpoint, I am pretty confident about the IDFS. So with this IDFS, when the trial was done, this is the way the trial progressed: an interim analysis, then a primary analysis, and an additional follow-up. Time of follow-up 15, 19, 27 month. We could argue that you would want a 60-month follow-up or a 100-month follow-up. You know, you can keep on talking, but end of the day, we need to have some result somewhere. You can't simply sit on data without getting a result. And for me, this additional follow-up seems reasonable. You had 27-month median follow-up. That means almost everybody would have completed the endocrine, would have completed the Abema therapy. So the study treatment was completed by 90% of patients. Gives you a reasonably good figure of what has been happening. And this was the initial baseline characteristics. Again, what really strikes me, premenopausal 43%. You know, we keep talking, in India we have premenopausal bigger population, we have premenopausal population. Well, this is what it is. You have 43% premenopausal. Then number of lymph nodes, 1 to 3 in 34%, more than 4 in almost 65% of patients, which is again, possibly over time in elderly you are not going to see this, but in the younger population, certainly this is what we are seeing. So a higher nodal burden. Then coming to the grade 3 in 40%, and then pathological tumor size more than 5 in 24%. So by and large, forget about the trial definition, any of us would say that these are high risk patients. You see a T3 and a T4 disease, you see a grade 3 disease, you see a more than 4 lymph nodes. All these are patients where we would say, let's go and give chemotherapy first. You know, that's our reaction. And precisely a high risk population where the drug has been studied. So this is what happened when you had a median follow-up of 15 months, a 2-year IDFS rate, 92.2 versus 88.7, 3.5% absolute difference. Again, along expected lines, you give adjuvant endocrine, we know that 90% will do well. But as we keep telling our patients, 3.5% is not small. It's a big number. When you compare thousands of women, 3.5% is not a small number. It is a big number. And it is significant clinically if you are able to address that thing. Now, over the next time, the next follow-up, the number of events is still 230 versus 313 with a HR of around 0.69. You know, in this trial, everywhere it's around 0.6, 0.69, 0.7. That's where you're getting. The absolute benefit is 5.4% in 3 years. 5% is significant when we talk of adjuvant therapy. 5% is significant when we talk of hormonal therapy. So 5.4% difference at 3 years cannot be scoffed at. More importantly and more interestingly, look at where the curves are diverging. You know, they start off almost together. Within that 6 to 8 months, they start moving apart, and then they keep on moving apart. You know, that tells you that logically, the relapses which occur in 1 to 2 years in endocrine positive patients, that is being prevented. So that's an interpretation. I mean, I'm not saying this is what is proved, but that's an interpretation. These relapses which we see after 1 or 2 years are the ones being prevented by abemaciclib. So it is doing something there. And remember, you're giving it for only 2 years here. What about the subset analysis? Now, difficult to, you know, keep arguing this, and there's a busy slide. By and large, what we notice is that all the subsets seem to benefit. So any subset which is a high risk particularly is shown to benefit. And your hazard ratios, again, 0.7, 0.72, it's in that range, which is what we expect. So in this so-called cohort 1, finally, when you saw the relative risk of an invasive disease is reduced by close to 30%, absolute number wise, it's pretty standard. The difference is maintained at the 2 follow-ups. We take this ahead to the next 40 months or 60 months, I think we are going to see a continuation of this. Again, that's a guess. We have to wait for the results, but that is what I feel is going to happen. What about the clinically meaningful disease distant relapse-free survival? Now, this is a slightly convoluted topic. You know, you say IDFS and say that's enough, and then you say no, a new thing called DRFS. Essentially, you're looking at distant relapses and saying that, okay, it can control both local and distant relapses. Even in that setting, the benefit seems to be clinically significant, 4.5%. And again, your hazard ratio is coming to that same 6.5, which is in the range of what we get. More importantly, what are the relapses which are being prevented? You have bone which is reduced, you have liver which is reduced. Not a surprise to me, liver is somewhere we know that Abema works. They're shown in the metastatic setting, so that's what we are seeing here as well. One thing we are not seeing here is the CNS, but I guess the numbers are too small, and then CNS relapses do not occur so commonly in the early stage. So probably that's something we can wait for in a few years, but otherwise, there is a reduction in the distant relapse in multiple places along expected lines. Side effects. Again, the side effect profile is there with diarrhea. It cannot be wished away. It is there. 17% discontinuation rate, which is significant, but again, in putting with the trials that we see. So over time, all of us know how to manage diarrhea. We are not very uncomfortable with it. With dose reductions, by and large, they are managed pretty easily. Something that we have to look at. Other side effects, not so significant. Slightly increased risk of thrombosis, slightly increased risk of ILD. Again, clinically I have not seen it personally, but in the trial it is there. Dose reductions were seen in 43%, which is a bit on the higher side, but by and large it is acceptable. Personally, the way I look at it, most of our patients are going to be younger because they are the ones we see all these higher risk features, and in them I think it's going to be not that difficult to manage. So from the monarchy, if we conclude, the adjuvant abemaciclib combined with ET continues to demonstrate meaningfully significant benefit for this group of node positive high risk EBC. IDFS and DRFS both are maintained beyond 2-year period, and the safety data is pretty mature. So though we can question the safety, we have issues on that, but it is still a manageable thing. The interesting point is about Ki67, which is prognostic, as of now not predictive. So as of today, we are not going to use Ki67 as a predictive marker, we are going to use it only as a prognostic marker, which means if you have high Ki67, you are likely to do worse, which is something we already knew. So that's the data about the abemaciclib, and of course, we need to do what we can for these patients. So if there are any questions, I would take them at this point. If anyone has any doubts or any questions, and I think Dr. Sham is still there, we can.
Thank you, Vamshi. Since you are physically there, if there are any questions, they are most welcome. Otherwise, we have a couple of case scenarios which we can discuss.
Sure, anybody has any doubt, we can always talk, because this is again not a topic which is very straightforward. We need to look at the groups, and that is for me the most important subset. Every patient is not going to go in for adjuvant abemaciclib. I think that's a lesson we are very clear about. You have an early breast cancer with no nodes. As of today, we are not going to give Abema in that subgroup. We are going to give it for the high risk patients. I think that's the biggest takeaway as far as I have seen this trial. So
let's go to the first case scenario, Vamshi. So this is, I think straightforward. Can we have the slides? So this is a 38-year-old premenopausal lady who has undergone bilateral mastectomy, and the tumor is T3, more than 4 nodes. Lymph grade is 3. So all the high-risk features are there. We don't know the Ki67. Oncotype DX is done, which is 32, and the patient has received standard adjuvant chemotherapy of dose-dense AC followed by docetaxel. So, are the slides shown?
Not visible here, sir, but please, I think it's straightforward.
You can. So I think to sum it up here, a very high-risk individual with T3, more than 4 nodes. So the question is on Monday morning when you go back to clinic, what is your, for this premenopausal lady, what are we going to do? The options given to me are tamoxifen, AI with ovarian suppression, tamoxifen with Abema, or AI, ovarian suppression, and Abema.
So I think we can we have a audience here, some of whom are still eager for lunch. So basically the idea is for such a patient, sir, I think all of us would agree it's a high risk patient. And this is a patient where we need to be strong in our endocrine therapy. That is really going to be the reason or the driver for the cancer. So definitely an ovarian suppression has to be there. Now, whether you want to give the ovarian suppression with tamoxifen or letrozole, I think that's a bit of a debate. Personally, I use AI. Tamoxifen is perfectly fine. But in this patient with high risk features, certainly I would want to add my abemaciclib. So definitely this is a patient where you would want to add abemaciclib. So Dr. Sham, your thoughts on this?
Yeah, great. So I think you did make a fairly relevant point regarding the selection of whether it should be an AI or it should be tamoxifen in a premenopausal lady. Maybe the house would be sort of divided, but whatever you do is perhaps correct here. So I think an ovarian suppression is essential because this is a high-risk lady. So you have to use an LHRH agonist in this premenopausal lady. And this lady is definitely on for abemaciclib. So are there any comments from the house?
Sir, one question from the house. One question.
You have divided it into early breast cancer and metastatic breast cancer.
No, for the Monarch E?
There is a subset of LABC also.
Okay, and LABC, yes.
And what your high risk defines, 3-node positive, 4-node positive, T3 tumor, they come into LABC category. And we don't operate LABC upfront.
Yes.
So in this scenario, how to consign this patient for adjuvant treatment?
So the Monarch E allowed neoadjuvant therapy. So in a Monarch E allowed a neoadjuvant, almost 30 to 40% were neoadjuvant. So again, the idea is you're not changing your therapy and substituting it with abema. You continue your standard therapy, that is the neoadjuvant chemo, surgery, radiation, and then along with the endocrine, you have to add abema. So definitely a LABC, you will offer neoadjuvant as of today. The abema comes
Dr.
later.
Vanshi, his question is, how do you decide whether this patient is 4-node positive because you have not done the surgery before the, and a neoadjuvant chemotherapy can bring down the nodal number at the end of 6 cycles of chemo?
So for me, the answer is very simple, sir. I think the doubt which Dr. Sham is asking, the same thing which I addressed. How do you know that you have more than 4 nodes? So luckily, if you have a risk factor, you have T3 that is more than 5 centimeter, or you have a grade 3. Automatically, whether it is 1 node or whether it is 4 nodes, they are going to go into your abemaciclib protocol. So I think that is the answer. And nobody is going to sit and count the nodes in a PET or anything, but that's how we look at it. Grade 3, size bigger and node positive. You will be putting them on the abema any which ways. So that's how I would look at it.
Right. So I think let's go on to the second case.
So we have 30 seconds, so let's just, yeah.
So we'll finish this case, This is contentious a little. 68-year-old post-menopausal, a lumpectomy with sentinel node biopsy done. It's T2, 1 node positive, grade 3. A patient has had chemo and radiation. So what is your adjuvant treatment for in terms of hormonal? Whether it is simple AI or it is AI plus abema?
So again, this is one more thing we are going to face. Single node positive, you could argue that this patient is a single node positive. Why on earth would you even give chemo? You would simply say we can give hormonal alone. We do have some data on that. That was not addressed in the monarchy. So we don't know the answer. Should you do a molecular test and then decide not to give? Or should you give the AI with abema? Personally, I would still be tempted to give if the patient's performance status is good enough. If we know that they can tolerate the drug, 68 is not that old as we used to consider. Average life expectancy is close to 75 to 80 nowadays in India. So if a patient has good performance status, they are fitting the criteria, I would offer abema. But I will be careful about the side effects because that is known. Diarrhea is a complication which we need to be a little careful about. So personally, I would offer it, but for a 30-year-old patient, the previous patient, I would insist on it. Here, I may not insist as hard on it. Dr. Sham, your thoughts?
Right. So, this patient does fulfill the criteria as for Monarch E because 1 node positive and grade 3 would, constitute the cohort 1 as they call it. So therefore, this patient would be a candidate for abemaciclib along with an AI. So I think this kind of discussion will keep happening because the scenarios are going to be even furthermore, especially when Ki-67 data comes in, because that's also going to be a little confounding factor. But I think I'll just end it up by saying that we have a new drug in the adjuvant setting for high-risk early breast cancer patients. and we must, keep looking at the data as it evolves. So your last comment, and then we can close, Vamshi.
Thank you, sir. I think I completely agree with you. It is an old drug, but it is being used in a new setting, and definitely it's something we need to start discussing with our patients. We may not do it for everyone, but certainly where the patient is fitting the criteria, we should be offering this drug at least and having that discussion with our patient in the clinic. So that's how I look at it. So thank you, sir. Thank you very much.
Thank you for the invitation, and thank you everyone. Enjoy the meeting. Thank you very much.
Thanks.
Thank you, Shyam sir. Thank you, Vamsi. Thank you, Chairperson sir, Dr. P.K. Das sir, and Sanjukta madam. So we are already late. So people can go and come in and after lunch. So we'll start the post lunch session at 2:15. So lunch is served upstairs. So where there are सर बड़े ये तो दे दे वैसे इंटरव्यूटर तू सर वो नहीं तो सर ने तो नेक्स्ट डेट रेडी कर सकते हो आप मोमेंट तो कहाँ के दिया नहीं तो संजय तो मैडम सब आई वामसी भाई तो नहीं तो वामसी भाई बलदेव তোমরা গিয়ে এক একটা দিন গিয়ে লাঞ্চ করে চলে আসো ঠিক আছে না
You had, Mr. Sir. Thank you, sir. He wants to meet you actually.
Thank you so much.
Very good conference because you are on the center stage actually.
और छोड़ के जाता नहीं लग रहा So like every year, so we are also coming up with our 4th session of Indooncology Summit. So last 2 years, everybody has been affected throughout the globe with COVID. So that's why we could do only the virtual one. So this time we are coming up with the physical also and the virtual. So it will be hybrid mode. The theme of this year's conference will be Cancer Care Era Precision. So last month in the ASCO 2022, so there was a buzz about cure in cancer in rectal cancer, and that was MSI high rectal cancers, where out of 18 patients, so 41 had no evidence of disease, and that made a huge impact in the whole society. So that is what about precision. So we want to discuss it out with you all and bring out what's new in this cancer field.
The success story of last 3 conferences gives us an inspiration to do this 4th one. Yes, this conference will be a unique one because we are meeting physically at Bhubaneswar. After so much of restrictions of the COVID, this conference will be having enough things for the entire oncological fraternity, which involves the radiation oncologists, medical oncologists, surgical oncologists, young oncologists, research, PhD peoples and industry people, those who are with the new technology.
Carcinoma, brightening star in cancer care.
गोटे जगार सबकि चिकित्सा सबकि सुविधा पाइपर से आरंभ है कार्सिनोवा कैंसर हॉस्पिटल। एठी हमें फास्ट करिकिनी आनिलु हाल्सियन रेडियोथेरापी जोटा पूर्व भारतर प्रथम टार्गेटेड हाल्सियन रेडियोथेरापी मशीन।
3 प्रकार ट्रीटमेंट एक्चुअली कैंसर हुए सर्जरी केमोथेरापी एंड रेडियोथेरापी 3टा एक सुविधा आम कार्सिनोवा रे अवेलेबल करेचु।
आजिका दिन में जहाँ बाहर ट्रीटमेंट होची बॉम्बे हो कलिकता हो बेंगलोर हो हैदराबाद सबू से ट्रीटमेंट एबे एई कार्सिनोमा हॉस्पिटल हे पर
लोक मान को फ्री रहिबाटा भी सुविधा दउचु आउ सब्सिडाइज फूड इवन दरकार पड़ले हमें फ्री फूड भी दउचु से मन को।
Carcinoma, brightening star in cancer care.
sessions. We'll have some virtual sessions as well as physical sessions. We have planned some workshops also in this session.
Some Ultimate Medicare is a realization of that dream brought to you by Siksha O Anusandhan, a formidable name in the sphere of professional education and healthcare in Eastern India. Some Ultimate Medicare promises a new dawn in the healthcare landscape of the region and is another step in a healthcare journey that began with the opening of IMS and SUM more than a decade ago. This multi-super specialty quaternary care hospital is one of the largest hospitals in Eastern India, bringing together the finest medical talent and technology. In over 30 specialties here for patients from all walks of life, from pediatric to geriatric, with an objective of transforming lives in the region and beyond. The building has 9 floors for the best patient-centric care. Basement 1 houses the medical records department and billing and for parking. Basement 2 is dedicated for onco-sciences, assuring comprehensive cancer care with the latest available radiation therapy systems. True Beam Linear Accelerator, HDR Brachytherapy, PET CT scan and gamma camera. Moving up the ground floor is where we receive the emergency patients. It has the emergency OT, OPD, trauma ICU daycare, the physiotherapy and executive health checkup, the radio diagnostics and imaging services, and the Center of Excellence Department of Cardiac Sciences. First floor has the administrative department and the OPD, critical and sensitive departments of laboratory services, dialysis, transplant unit, transplant OT, TICU. Second floor is the zone of silence, 9 OT complex, a cardiac intensive care unit, 2 medical intensive care unit, 1 surgical intensive care unit, a high dependency unit, 2 cardiac cath labs, and the central sterile services. Third floor has gynec, OT, pre-OP and post-OP with a delivery room near the neonatal intensive care unit to make childbirth an enjoyable occasion. Our patients have the option to choose from room types available as per the requests and convenience. Third, fourth and fifth floors have comfortable twin sharing rooms specifically designed to accommodate 2 patient beds. We understand the need for comfort, tranquility, luxury as much as safety and security. Comfortable executive and single rooms and the presidential suites provide the most restful experience. The 6th floor houses the kitchen, from where a variety of nutritious food is offered. Some of all care, some ultimate Medicare. In our commitment to truly transform healthcare across the country, as the hand in our logo symbolizes care and lotus with energy circles reflects perfect healing care. We stand with one goal, one passion. Every patient, anytime.
वो तो चलता रहेगा, वो उसको वो डिले हो जाएगा नहीं तो. Let's just join, waiting for Reena madam to join. Hari has already joined. Welcome back. Join, not join. एक संगे पटे तो जाएगी जो बारी बारी में जाओगे. So 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good to start? Yes, sir. So welcome back after lunch. So we have two back-to-back hematology sessions, and we have chairpersons, so none other than my teacher, Dr. Reena Nair, so presently from TMC Kolkata. So she will be on the chair for the next two sessions. And the first one is a debate. So for a Hodgkin's lymphoma, ABVD versus ABD. So Dr. Hari Menon has joined from Bangalore virtually. So he will be the expert. And so for the motion, so will be Dr. P.K. Jayachandran from Chennai. He is there with us. He will be joining physically. And Dr. Lingaraj Naik from TMH, so he will be joining virtually. So over to you, Dr. Hari Menon and Reena madam.
Reena ma'am, we
yes,
can't hear
thank
you. Yeah. Yeah.
Yes. Hello. Can you hear me?
Yes, you're audible, sir.
Yes. Yeah. Yeah. Thank you. Thank you, and welcome to this to the debate on Hodgkin's lymphoma in this first session. An important topic, debated all around, but still the pros and cons of the newer modality of treatment for Hodgkin's lymphoma is still good enough for debating further. So I think we can have a discussion after the debate is completed. And for speaking for the motion, I invite Dr. Jayachandran, who is a senior associate professor, the Department of Medical Oncology at the Arya Cancer Center, and that will be followed by against the motion by Dr. Lingaraj. Yes, I invite Dr. Jayachandran to come on and make his presentation.
Hello. Am I audible, sir?
Yes, you are.
Yes, very much, very much. Yes, yes, Dr.
Can I have a slide? Okay. So, good afternoon to everyone after lunch. I am going to speak on the notion for ABVD in first-line Hodgkin's lymphoma. So, I think, next slide, please. So, ABVD is the current standard of care and will be the current standard of care in advanced Hodgkin's lymphoma. I can easily convince this audience because more than 95% of the audience who would be here virtually or physically would accept the current practices ABVD, and about 99% of the newly diagnosed fit patients in India receive ABVD only. So, next slide. The IPET-2 is prognostic and predictive. So, 75% of our newly diagnosed patients receive PET guided therapy in India. So nowadays the PET has become more cheaper to get PET for all patients. About 5 years ago the PET was costly, so people were not very much into it. But now PET guided escalation to BACOP and de-escalation to ABD, especially a standard BACOP option after the Athel trial has opened up a lot of people practicing this escalation and de-escalation based current ABD and BACOP in India. So I will come on to this. So ABD was, next slide please. Next slide please. Okay. So this is for the trial which has brought into this debate. So I have data. I am just going to pull down the legs of Echelon-1 study. I am going to pull down the leg of the Echelon-1 study. That's how I am going to speak my debate. So issues with the study design. It is an open label study. So easily randomization could have been done in this with blinding. But open label has been introducing more bias. There was no central review for radiology. And there were issues with the endpoints. Initially they fixed PFS as an endpoint. Subsequently they went out and differentiated to modified PFS, introducing the failure at end of treatment as one of the events additionally. So a lot of confusion in the trial design. And data was analyzed by pharma-funded statisticians. That is very important to keep in mind. So these are the issues with the trial design in Echelon-1. So let us see the incidence of IPET positivity in advanced Hodgkin's lymphoma. The real world data says that IPET positivity in the real world is varies from 13 to 25% across various countries and various data. The Athel study, which was one of the very large study, has shown about 16.3% had IPET2 positivity. But unfortunately, Echelon study did not match this thing. They were having only 8% of them being PET positivity. It is about 8 to 10% lesser than the real world average. So keeping in this mind, so I don't know whether they have kept randomized only very good patients, even though it's a randomized trial. I'm just doubting it. So let us see the next slide. So let us see the IPET positivity outcomes in various trials. So the real world is about 65%. In the real world data, various data shows that about 10% were only escalated in this study. The rest of them were not escalated even. In Rathal study, the escalated Bierkopf arm or standard Bierkopf arm had done about 67.5% as EFS. But if you see the Echelon 1 data, the EFS in the ABVD arm was only 45% and the AAVD arm was only 60%. The Rathal study showed 67.5%. It was, both the arms were inferior when you do a cross-trial comparison, even though you do not do cross-trial comparison. Here, if you do a cross-trial comparison, even the study arm did poor than the escalator or standard Bierkopf arm. Even though the Echelon 1 study allowed escalation of treatment, less than 5% only had escalation of treatment. So the arms, both ABVD and AAVD, were inferior, and ABVD in the ABVD arm, less than 5% only had a allowed escalation really. So what if ABVD followed by iPad guided therapy was used as a comparator arm instead of only ABVD? If this has been used as a comparator arm, I am pretty sure that this trial would have been a negative trial. So coming on to the, I'll just take another 2 minutes. So coming on to toxicity, the grade 2 neuropathy was higher, the grade 3 neuropathy related discontinuation of therapy was higher with AAVD, and persistent neuropathy after 5 years was also higher with AAVD. 19% had a persistent neuropathy. So next slide. So let us dig into the Echelon 1 results. So let us see the number needed to treat. If you look at the first primary PFS, 2-year PFS, the number needed to treat was 1 in 20. If you treat 20 patients, only 1 would have benefited with AAVD. And if you treat in a 5-year OS, the absolute benefit was 4.5% and the number needed to treat was only 1 in 22. If you treat 22 patients, 1 would benefit with the AAVD arm. So let us see the cost effectiveness. So ABVD is just per cycle is about 6,000 rupees. And if you look at escalated Bierkopf, it's about 12,000. Standard Bierkopf is about 6,000. If you look at the AAVD procured legally, it is about 6 lakhs per cycle, which is about 100 times costlier than the ABVD regimen. So let us put ourselves into policy makers' shoes of policy makers. Sorry, the slides are moving. Sorry. Yeah. So if you look at the AAVD arm, if you take 22 advanced lymphoma patients and ABVD arms, the cost is about 7 crore 92 lakhs for treating these patients. If you take AAVD, about 7 lakh 92,000 if you take ABVD. About only 1 patient is additionally alive if at the end of 3 years if you give AAVD, and you spend about 7 crore 84 lakh additionally spent to keep 1 out of 22 alive in this group. So let us go into statistics. About in Globocan 2020, 9,221 patients were newly diagnosed Hodgkin's lymphoma. Let us assume 50% of them were advanced stage. To give AAVD to everyone, the government or the policy makers have to spend 1,645 crores to keep 200 patients alive additionally for 5 years. So this is what the amount of revenue which will be wasted if you are going to use this. So ABVD is the current standard of care and will be the standard of care. It is time tested, more than 3 decades of experience, vast experience, more than 5 lakh patients have got ABVD. Numerous data, clinical trials, prospective studies and retrospective studies have clearly shown the ABVD is the standard of care. ABVD with iPad-based escalation and de-escalation approach is feasible and less toxic and will be the standard of care, and it is very cost effective, I have showed clearly. Thank you.
So, can I please request Dr. Lingaraj Naik to put his arguments
Next slide.
against what Dr. P.K. Jayachandran told? Dr. Lingaraj Naik, do we have you? He's supposed to be here.
Yes, I have my presentation recorded. I think I request organizers to play the presentation.
Okay. virtually. Dr. Linkraj, do we have a pre-recorded video or are you going to go live?
So I have sent the video, ma'am.
Okay, fine. I'll just figure it out.
Yeah.
Fine, now we have it. Audio.
That AAVD is new standard of care in advanced Hodgkin's lymphoma. Good afternoon. At the outset, I wanted to thank the organizers for inviting me to this meeting. I'm here for a debate on advanced Hodgkin's lymphoma. The debate is about AVVD or AAVD. So I'm here for debating AAVD. So in next 7 to 8 minutes, I will convince you all that AAVD is new standard of care in advanced Hodgkin's lymphoma. I have nothing to disclose. So before I move on, I wanted to show some Indian data of outcomes of Hodgkin's lymphoma, and this is the first data from a multicentric registry that is called OncoCollect. You can see almost 900 patients with good median follow-up, and the results look promising in terms of overall event-free survival and overall survival. Most of the patients, like 50% patients, underwent CT-based planning, and the patients who didn't attain a CR, that is no CR, the outcome is almost 35%, as opposed to 88% in patients who attained a CR. So we have a group of patients who may not do well with just AVVD. This is the data from our institute, that is TMH. And this data is more for patients who are in the age group of adolescent and young adults. Close to 220 patients. All patients underwent a PET-2, that is after 2 cycles a PET response. And those who attained a CR, the outcome was excellent as expected. But look at the outcome of patients who are PET PR after 2 cycles. That is close to one-fifth patient, and you see the outcome is around 50 to 55%. So you have much work needed in the group of patients who didn't achieve a PET CR after 2 cycles of AVVD. So how can we improve the outcome? We have 4 approaches. You can use escalated backup in a response-adapted manner. You can add indooncology to AVVD. You can use checkpoint inhibitors to AVVD, and you can use upfront transplant in few group of patients who are progressing as a primary progressive disease. So I'm here to debate about brentuximab. So before I go on to brentuximab data, I wanted to show some data of accelerated backup. Most of you are familiar with this 3 study, which got published in last 4 to 5 years from 3 different centers. So UK RATHEL study is from UK group. Now SD18 is a German study, and AHL2011 is a French study. So basic design was similar. The only difference was whether you start with AVVD or you start with accelerated backup. After 2 cycles, every patient underwent a PET response, and based on the PET Deauville score, they either underwent escalation or de-escalation approach. So I have summarized the results of all the three studies in one table. You can see that RATHEL approach was AVVD first, and rest of the 2 studies started with backup. Now you see the PET positive outcomes. So I've enlisted the 3-year progression-free survival to compare all the 3 studies, and you see that 3-year PET positive outcomes are close to 68 to 70%. SD18 may look better, but there is a probability of stage migration there because Deauville 3 was taken as positive as opposed to RATHEL and AHL2011 studies. So you get 15 to 16% absolute gain in PFS if you escalate to backup. But important to note is that you still don't have an overall survival benefit at the end of 5 years. So if you do a cross-trial comparison, either you start with AVVD or backup, both are valid options, but is it okay to expose to backup to everyone? Because we know that most of the patients will be cured with just AVVD. So can we use baseline IPS to determine which is the best approach. So we are doing a study on that in TMH. So you got the outcome what you needed with escalating to BACOP, but what is the price the patient has to pay? So if you see the toxicities, so I have enlisted the acute toxicities of BACOP, and this is 10-year follow-up data of German Hodgkin study group ST9 study. You can see the grade 4 leukopenia, 19% versus 90%. Grade 4 thrombocytopenia, 2 versus 47%. Infections, mucositis. If you want to replicate this kind of protocol in Indian setting, the toxicities will be much more than this. And risk of secondary AML and MDs. Now coming to some important toxicity of BACOP is infertility. And this is an interesting data from Rathel study where they have compared the anti-Mullerian hormone level, that is AMH level, after each cycles of ABVD or BACOP, and they compared it till the end of 1 year. And what they found was that good number of patients have recovery of AMH level even after ABVD, but if you use BACOP, little recovery was seen at the end of 1 year also. So these patients are going to develop permanent infertility or severe or premature ovarian failure on the long run. Now coming to the study that I am going to present is Echelon-1. So this is a study on advanced Hodgkin lymphoma. You can see the number of patients, 1,334. It's a US cooperative group study done, it's a multi-center study. The experimental arm was addition of brentuximab to AVD, that is omitting bleo and adding brentuximab. Comparison was with standard ABVD, and the primary endpoint was modified progression-free survival, which was defined by disease progression, death, or something called as modified progression. That is, the patient didn't achieve a CR or they received a next line of therapy because of inadequate response. Now the earlier data was little controversial because of this particular endpoint of modified progression survival. But when they analyzed the investigator assessed PFS, that is death or progression, and they gave an update at the end of 5 years, and you can see the difference in terms of PFS in the overall population, that is 82 versus 75. Almost 7% improvement in the progression-free survival. And you look at the subgroups of PET negative and PET positive, close to 6% gain in PFS in PET negative group and 15% gain in PFS in PET positive group. Now when I compare this this data with the Rathel data, that is with escalated BACOP, and you compare the 3-year outcome of both the studies, it's almost similar. You get similar kind of progression-free survival at the end of 3 years if you use AAVD with much less toxicities that you encounter with BACOP. Now if I just put the Echelon-1 data in the same table that I have shown you, you can see that the PET positive outcomes looks almost similar whether you look at Rathel or Echelon. But the good thing about Echelon is you have an overall survival benefit which other studies have not shown yet. So this is the data that was published this year, the overall survival data of Echelon-1. Before I show you the OS data, now the 6-year PFS data. So what happened to PFS first? You can see that the gain of PFS is maintained even at the end of 6 years. And you can see these outcomes of PET positive and PET negative here. And you can see the patients who are above 60, so you still get a benefit of almost 6%, even in the patients who are elderly Hodgkin, which is a difficult population to treat, specifically when there are concerns of using bleomycin. Now this is the OS data I was discussing. So you can see the Kaplan-Meier curve. 39 deaths versus 64 deaths in ABVD. And you look at the causes of death, good number of patients are in that group of Hodgkin's, this death due to Hodgkin's lymphoma or its complications, 32 versus 45. Now look at the subgroup analysis. The group that benefited the most was stage 4 disease, high IPS, that is 4 to 7, and extrarenal side. And these are the group of patients that you often see in our country, that is advanced stage, high IPS, late presentation, and poor performers. These are the poor performers with ABVD also, and they did the best with AAVD. Now coming to toxicities, I have shown the toxicities of BACOP, now you see the toxicities of AAVD. So these are acute toxicities, these are the first paper that was published for Echelon-1. And you can see the risks of neutropenia. So when they are not using GCSF, prophylaxis GCSF with AAVD, there were concerns of neutropenia, but after addition of GCSF, only 35% patient develop any neutropenia. Infections again are 7 to 8% here. So the acute toxicities are quite favorable as if you compare with the BACOP. The only long-term toxicity that people are concerned with BACOP is that brentuximab is about neuropathy. Good number of patients did develop peripheral neuropathy, but you can see the resolution. 70% patients have resolution of their neuropathy. And at the end of last follow-up, only 10% patients had grade 1 and only 5% had grade 2 neuropathy. So the neuropathy is there, but it is resolving in almost 3/4 of the patients. So if I have to conclude in terms of, and I have to compare in terms of efficacy, tolerability, long-term risk, OS benefit, and cost, you can see that in efficacy wise, both the approaches are fine. You get similar kind of progression-free survival in the poor performers especially. But if you look at tolerability, long-term risk, and OS benefit, here AAVD outperforms the BACOP approach. Now cost is something which probably the opponent will discuss in detail. So cost is a country, but if you see in terms of the outcomes, it looks promising, and if cost is not an issue, I have no doubt in my mind to choose AAVD over escalated BACOP in my patients. With that, thank you.
Thank you, Dr. Lingaraj. Can I request Dr. Hari Menon to give his expert comment? I'm sorry?
I just wanted to know whether there is Dr. Jayachandran would like to.
Yeah, Dr. Jayachandran would like to speak.
Yes. Yeah.
So, a few things I would keep in concern from my colleagues' talk. So, one thing is PFS is a very poor endpoint of choice in Hodgkin's lymphoma. It misses out few events like patients who are stable disease or a partial response at the end of treatment are not considered as an event in PFS. So, any lymphoma, we consider these patients as failure. If the patient has a stable disease at the end of treatment, or the patient has a partial response at the end of treatment, we don't consider them as a successful treatment. So, those events are missed by the PFS, whereas other studies included as EFS. So, only there are confusion. So, PFS I don't buy in any lymphomas. PFS is not a good endpoint. It is for metastatic solid organ tumors. Second, so before the RATHAL trial was published, people were very much concerned about the toxicity of the treatment, escalated BACOP. It's a nightmare. But once the RATHAL trial was published, it had a standard BACOP option in that. And standard BACOP is very well doable, and a lot of patients, even 45 plus patients, do tolerate standard BACOP beautifully. So toxicity is not a concern when you are going to use standard BACOP. If there's a young patient less than 25 years, you go and use escalated BACOP. If you can use, if you have an older patient who may not tolerate escalated BACOP, go and use the standard BACOP. So still BACOP is doable in India. After the publication of the RATHAL trial, a lot of people have started using escalation and using standard BACOP in various, even second tier towns also they have started using standard BACOP as an option. And again, this neuropathy is a persistent neuropathy. What I mentioned is 19% of the patients have persistent neuropathy at the end of 5 years, which is bothering for any lymphoma patient. So, which is not together. This is what, from my side, I would rebut on my colleague's talk.
So, Dr. Hari Menon, your expert comment, please.
Thank you. Thank you. I really enjoyed both the discussion on for and against ABVD, for ABVD and for AAVD over here. And thank you for that, both Dr. Jayachandran and Dr. Lingaraj. But as a reviewer and also as an expert over here, what I would like to consider is not an applicability for all patients, but to review what the data has to tell us as far as ABVD and the AAVD is concerned. And we are looking at a pretty large study, which has also got long-term follow-up, and the more recent 6-year follow-up has been published also over there. I will agree that it's very difficult to move away from ABVD, which has lasted for close to 50 years, for 45 years in terms of its existence and in terms of its effectiveness in treating patients. But we also are always grappling with a 30% population who are not likely to do well with standard therapy. And we are talking about advanced stage Hodgkin's lymphoma. We are not talking about early stage Hodgkin's lymphoma over here. So it may be well worth for us to be discerning about what is the kind of treatment we want to use, rather than saying one is better than the other. So what would be the merits of using ABVD? It's got an excellent, timeline, and wherein we have had excellent results, and the ability to understand its toxicity and where it works, and also understand who are going to work, for whom it's going to work, and also having surrogate markers for us to predict its outcomes. But we also know that there is a good number of patients in the ABVD who do not do well either with standard therapy, and wherein we may want to use, and this was the Echelon study was probably the first study to actually challenge ABVD's premier role in the management of Hodgkin's lymphoma. So, what are the things that we do understand as far as the use of brentuximab is concerned? The results would suggest that yes, it has got an edge in terms of patients who have stage 4 disease. It may be useful for patients who have a lot of extranodal sites and who have a high score and number of extranodal sites, where it may have a better outcome. The number of patients who would probably require a second-line therapy in those who have been selected out for treating with brentuximab vedotin in combination with the AVD, we would consider them as probably an advantage for using the brentuximab plus AVD, the AAVD regimen over there. So I would probably disagree a little bit with Dr. Jayachandran's equating a standard BIACOP with the escalated BIACOP. I think they are two different regimens, and we should not mix it, because if we are thinking about using standard BIACOP, we might as well use ABVD over there in terms of dose density, etc. So standard BIACOP is probably as equivalent as an ABVD regimen over there, and may not replace escalated BIACOP as a salvage regimen, or for those patients who have not responded to treatment in the first line ABVD regimen after 2 cycles of ABVD. So in terms of toxicity too, we do understand we have to be discerning, and that's why probably it's not a great regimen for the older patients who may not tolerate the neutropenia that's associated with brentuximab and the AAVD regimen, and probably the patients less than 60 years of age. But we do understand that those people who died in the brentuximab with the AAVD in the AAVD arm were those people who did not receive growth factors actually due to hematological toxicity. And we do understand also that the number of patients who required a second line approach and who did not require a salvage approach in the form of an autologous stem cell transplant were much higher in the brentuximab vedotin arm. So I'm not saying that it should not be misconstrued that probably AAVD is the one that is used because of its of the cost structure that is associated with the brentuximab arm. But certainly there are signs over there in terms of discerningly using brentuximab with the standard, adding brentuximab with the AAVD regimen to the arm in some of the patients wherein we anticipate they're not likely to do well. And it would be interesting to actually look in the future as to whether, just like how we have been able to improve upon the outcomes in those patients who did not respond to first 2 lines of ABVD and salvaging them and putting the arm of brentuximab over there as a salvage regimen as against the escalated BIACOP, whether we can do justice to those patients. I think in that situation, we may have a winner in using brentuximab over there. But as of now, it's still difficult in the Indian setting or in our setting to actually recommend the AAVD regimen for all patients, but it is certainly the first time that we have had a regimen that has consistently shown an improvement in terms of the progressive survival and also to a certain extent the overall survival of about 4% at the end of 6 years when we have seen the data over there. So, and also in terms of the toxicity in form of peripheral neuropathy, one thing encouraging is that peripheral neuropathy is much higher in rituximab arm, but they are also significantly reversible, and the toxicity that we talk about are to the tune of about grade 1, grade 2, and never grade 3, grade 4 over a period of time. They tend to subside. There is some reversibility quotient over there in terms of the peripheral neuropathy that looks at. So in a nutshell, well discussed, and I would fully equate with all the points projected by, particularly the cost factor, which has been so beautifully shown by Dr. Jayachandran in terms of the cost that is involved in that we can never compare with the ABVD arm. And from that perspective alone, it is going to continue to be one of the standard regimens that we are going to use for a long period of time. But from a scientific perspective, it is important to be discerning where we can use brentuximab, and in those situations, we need to use it. Yes.
So, thank you, Dr. Hari Menon. Can we have some comments from Dr. Reena Nair, ma'am, the chairperson? Ma'am, do you have to say something?
Yeah, so I think Hari has very beautifully discussed both the aspects and has summarized it also. And like he says, it's not a yes-no debate. I think it is times of precision medicine. And so we have to actually pick up on the patients which would benefit maximum and then actually give the newer treatments. We will gradually, eventually, but definitely move into chemo-free regimens, and the costs will come down. And at that point of time, these targeted medicines are going to make the largest impact on patients. Presently, if we understand even out of the advanced stage diseases, it is the patients, like we have heard the speaker as well as Hari say, that it has to be very limited. Look at patients with very advanced disease, stage 4, multiple extranodal sites, and otherwise use it if they don't respond well to the first 2 lines of ABVD. So the cost will come down definitely, and it is only a matter of time. The regimen is definitely far, far more easier to give than escalating to BACOP. Escalated BACOP is no joke, even in patients who are 20, 25, 28, forget beyond 40. And to give brentuximab, you can go up to almost any age. The toxicities are all handleable, and at the same time, like we just heard, even the neuropathy which we worry is kind of limited, and you can easily take care of these patients. So today ABVD wins, but tomorrow AAVD will win. So we have both options. It's only the cost that is keeping us behind. So very interesting. Thank you both for an excellent presentation, and maybe Hari, you can take it to the next session.
Thank you. Thank you so much, ma'am. Thank you, Dr.
Thank you.
I would request Dr. Reena Nair and Dr. Lingraj Naik to be present with us for the following panel discussion. May I please invite Dr. Priyanka Samal to moderate this session on CML, and as panelists, Dr. Jogmaya Patnaik, Dr. Rakesh Reddy Boya, who will join us virtually, Dr. Asutosh Panigrahi, who will come. May I please request you to come on the stage as panelists, and Dr. Lingraj Naik, who is already present with us. So, over to you, Dr. Priyanka Samal.
So good afternoon, everyone. After the lunch, I think the panel discussion should be interesting enough to have a break. And thank you to the organizers at the outset. Thank you to our most beloved elder brother, Ghansyam Bhai over here. And I welcome to my panelists, and thank you chairpersons for chairing the session. Reena ma'am will be there. And slides are not... We'll start with, this will be a case-based discussion. I'll introduce my panelist, and the discussion is on CML. We'll be going through 2 cases, and I request the panelists to be very brief and precise so that we have time a little bit for more of discussion along with the chairpersons. So my panelists today are Dr. Jogmaya Patnaik. He is a medical oncologist at KIMS Hospital, Bhubaneswar. Dr. Rakesh Reddy, he is at Visakhapatnam, medical oncologist. Dr. Lingaraj Rai, he is at Mumbai TMH Hospital. Dr. Ashutosh Panigrahi, Associate Professor, AIIMS Bhubaneswar, and Dr. Pritish, he is joining from Delhi. At presently, he is undergoing a stem cell transplant training program at Delhi. My slides are not clear. So first case, it is a 50-year-old male, and these are all real-world cases. So we will be exactly going through the discussions, what will be our approach while we are treating a patient with the limitations we have presently in India. So 50 years male, Mr. A.S. is a businessman by profession, diagnosed as CML-CP in 2019, BCR-ABL quantitative done from peripheral smear at that, from peripheral blood at that time is P2-110 positive. Please, the slides are not at all proper. Comorbidities, type 2 diabetes mellitus, started on imatinib in 2019, 400 mg OD. So my question to the panelists will be, any further investigations required at this point? What would have been your approach regarding therapy? Dr. Jogmaya.
My approach will be, I also would like to do a bone marrow study for this patient, a bone marrow aspiration and biopsy with a cytogenetic study from the bone marrow aspirate sample. That will be first. Second point, because he is 50 plus and has diabetes as comorbidity, I'd like the whole cardiac checkup to be done.
Right. So we have FISH RT-PCR also. Earliest is by FISH, so many centers also ask for FISH. And what is your opinion regarding RT-PCR? Would you like to do a qualitative or a quantitative PCR at the outset?
I definitely like to do a qualitative RT-PCR at the baseline.
So, Dr. Ashutosh, what are the advantages of having a qualitative PCR and not having a quantitative PCR, and what are the current guidelines? What do you suggest?
So
and how would you approach for your patient?
So I usually do a qualitative RT-PCR because that is quite effective in identification of the disease. Quantitation till now is not recommended as a routine practice, but obviously definitely when we are targeting a early molecular response or that type, so we can consider, but in my regular practice, I usually do not do a quantitative PCR baseline.
Dr. Lingaraj and Dr. Pritish, would you like to add anything to it?
Yes, I agree with Dr. Ashutosh that initially we have to identify the protein BCR-ABL, whether it is P190, P210 or what is the type of it, and because the monitoring is standardized for P210 only, and apart from that, quantitative, though it's not recommended by the guidelines, but still, if we want to know the speed of decline of the BCR-ABL status, then it will definitely help us in monitoring.
Right. Apart from the fact that we are doing it from a peripheral blood, that there is an update of 2022 written by Jabbar and your Kantarchinian, where they have mentioned that bone marrow aspiration is now being mandatory for patients, because it not only provides what is the actual blast percentage and whether the patient is in progression, but apart from that, we have a cytogenetic sampling done, and we can look into what are the additional chromosomal abnormalities in order to say whether the patient is in progression. So these are the investigations, and baseline RT-PCR is needed to identify the rearrangement. That is also important, that if a patient has a P210, apart from the P210 mutation, P190 or P230, for which we do not have quantification as of now, we need to do an the qualitative RT-PCR to know these subsets of the patient. Slides not. So what will be your approach to this patient? Now that the patient is positive, would you like something else, or you would like to start directly with a TKI? And which will be your TKI of choice for this patient?
This patient is a 50-year, so I'd like to continue with imatinib.
I also still agree, because in
Before
my
that,
routine
would you like to risk stratify your patient?
Yeah, with Sokal score.
Exactly.
Yes. So SOCAL ELTS score is now what we are looking into, because ELTS has now come up with these TKIs being available. It is a better way to estimate what is the long-term survivability in these patients. So if we look into the data over here, these are again the updates, the latest update 2022, September only published. You can see that the complete cytogenetic response, which is one of the very, very important factors, because a patient with a complete cytogenetic response at the end of 12 months is almost thought to have a normal lifespan as a normal counterpart. And the EFS and the PFS are almost the same with any of the drugs. So you are at ease of choosing of whatever is available TKI, but then it is up to you how you counsel your patient and what are the other things you need to consider. So aims of the frontline therapy, as I said, normalization of survival in patients of CML, equivalent results with imatinib and second generation TKI, achieve a deep molecular response so that we can have a treatment-free, the TFR or the treatment-free response rate and the survival. Age and comorbidities have to be taken into account, cost, affordability and the CML risk profile. So kinase domain mutation, how many of us would do a kinase domain mutation at the outset? Dr. Rakesh?
No.
You have to unmute yourself, Dr. Rakesh.
Yeah, I don't do a kinase domain mutation at baseline. I agree with the rest of the profile investigations, and I would do a bone marrow aspiration and biopsy. I would do a quantitative RT-PCR, but not a kinase domain mutation at baseline. Yes.
So only in patients who are high risk, having an accelerated phase or a blast crisis or in the relapse setting, it is only indicated. So that is to be kept in mind. Toxicity spectrum, I won't go through it. All of us almost must be knowing how we choose our patients, and since this is a type 2 diabetes mellitus, which is the drug you would not like to prescribe to your patient?
Nilotinib.
Right.
Nilotinib.
Okay. So next to Dr. Rakesh.
Yeah.
How frequently would you monitor your patient or ask to follow up? Any other suggestion you have for this patient at this point of time? Your opinion regarding dasatinib 100 mg versus the low dose dasatinib of 50 mg. If this patient would have been high risk.
Yeah, so first I would do the ELTS scoring, the risk stratification of the patient, and suppose if the patient is high risk, my initial discussion with the patient will be imatinib versus dasatinib, keeping the toxicity profile that you already mentioned of type 2 diabetes among the options that we have. My counseling will be regarding the disease, the duration of treatment, the long-term duration of treatment, the need for taking the tablet continuously, as well as following up for side effects clearly. So one of the very important goals that I'm going to discuss with the patient is a treatment-free remission. So if this patient is a high risk, he's fairly youngish, 50-year-old, if he understands well, then I will definitely propose treatment-free remission as a realistic goal for this patient. And the first goal will be to achieve a stable non-malignant hematopoiesis. So I would follow the patient after 2 weeks of starting, and then again at 4 weeks of starting of treatment. And once the counts have stabilized, I will follow him up at second month and third month, and do a RT-PCR quantitative at third month as well. Right. And regarding 50 mg versus 100 mg of dasatinib, I'm fairly, initially I had started a good number of patients on 100 mg, and for the last few months I have fairly shifted my practice. If I'm starting dasatinib, I fairly shifted to 50 milligrams.
Yeah. So recent data regarding the low dose dasatinib, there is again an update, and this is by the MD Anderson Cancer Institute, where they have been now practicing as upfront low dose dasatinib, and in those cases you can see with the low dose when compared, low dose 50 mg and 100 mg, almost the MMR, the complete cytogenetic response, the OS and the response are almost comparable. The p-value was highly insignificant, and the EFS and OS, there was no difference, and the grade toxicities, if you see pleural effusion, it is 10% with that of, the 100 mg OD dose, but it is only 3% with the 50 mg OD dose. So for them, it is now MD Anderson, they have taken up as 50 mg OD dose as an upfront therapy. But I think we have less of data as of now, and still 100 mg remains the standard. So dasatinib, another study, just I want to mention, this is again an update, 20 mg OD. There is a small data coming up where more than 70 years of the patient, they had less of cytopenias and pleural effusion, and that is also being studied, although the cohort is only up to 120 patients. So, yeah, that was it. So continuing with the case, 2019, post that in Jan 2020 when the patient has come, the BCR-ABL is 0.041%. May 2020, you can see the TLC has gone up 32,000. Patient was then advised 600 mg imatinib. In June 2020, again he complains of blurring of vision, headache and generalized weakness. And 5 days of his visit, when he came to us, the patient has diffuse tenderness of the abdomen along with, on CNS examination, there is right third cranial nerve palsy. So in this patient now, the MRI brain was done, which was normal. Flow cytometer of the CSF study showed there was blast in the CSF, and the bone marrow also showed there was blast crisis with a BCR-ABL of 20%. So what next investigations would you ask for? What I mean to say, this is a patient who has relapsed with cranial nerve involvement and the patient has a blast percentage high in the bone marrow.
So this is the usual scenario that most of the patients who are on TKI, they usually go into a lymphoid blast crisis, and definitely it will be dealt just as a new case of ALL, that will do a bone marrow cytogenetics. Then we'll do a mutation analysis, because we have to change the tyrosine kinase inhibitor, and it will be better if we will target, if we will choose a TKI which will be specific for the mutation. And third thing, I will choose a TKI which will have a CNS penetration, because it is a CNS disease also. So that means I will definitely do these investigations including bone marrow and all other comorbidity assessment for this
So
process.
investigations done showed 95% atypical cells, conventional karyotyping, 922 translocation, and it was complex karyotype with few more additional aberrations, and the kinase mutation domain study was negative. So now with this diagnosis, how will you manage your patient, and would you follow the same guidelines for monitoring this patient as it was when the patient was in a CML-CP phase?
So my management will be, I will prefer
Yes, you spoke about
ALL.
that. So we started, would you like to go for an intensive chemotherapy, or what will be your approach for this patient?
I will definitely try with the intensive chemotherapy, try to put the patient to CP or into remission, and I will go ahead with transplant. Because complex karyotyping, CNS disease, so that will be my approach.
So we started the patient denied for an intensive chemotherapy regimen. Patient was started on dasatinib and steroids because the data suggests that even with this you can have at least a 70-80% remission, but the chances of relapse is still 40 to 50%. And he had also a younger sister. We had counseled that even if the patient enters into remission, we might go for an allo-SCT without going for an intensive chemotherapy. And day 86 you can see BCR-ABL of 0.3098% with less than 5% atypical lymphoid cells, which came out to be hematogens on flow cytometer. So patient continued 50 mg BD of dasatinib. The dose was reduced because of relative lymphocytosis and cytopenia, and as a consolidation, after giving triple IT intrathecal therapy, we consolidated with a cranial RT. So this was the management we did for the patient. And then again, after that, this was the second relapse. The first relapse following which the patient did well, but again the patient relapsed in February 2022. And you can see again there was a CNS relapse along with BCR-ABL, and this time there was an IRMA mutation positive. Same workup done. So now for Dr. Lingaraj, how would you manage this patient at this point of time? What are the new drugs you would think of as monotherapy or combinations, and where do you place these new drugs in the treatment paradigm?
Thank you. Am I audible, Dr. Priyanka? Am I audible?
Yeah.
Yeah, okay. So I think coming to the last question first, I think both the drugs are not available to us currently, but I think we are getting ponatinib and asciminib by compassionate access, and we have a couple of experience with both the drugs, and I think asciminib data is promising and the drug tolerance is quite better. Now there is issue with ponatinib in terms of tolerance, so you have to place both the drugs and choose one of out of the two. I think probably I will be more comfortable with asciminib unless there is a T315 mutation where probably ponatinib may outweigh the asciminib. Now coming to management of this patient, it will all depend on whether we can put this patient into a CR and preferably at least a cytogenetic response. Then only you can think about going ahead and doing a transplant. But of course, doing a transplant in CML, BC and CR3 is the outcomes are not very great even with allogeneic stem cell transplant. But that is the only thing that is we can do for this patient. And my goal will be to choose a better TKI, put into MRD negative and cytogenetic remission, and take this patient as soon as possible for transplant to have a good post-transplant strategy as well, because this patient has high likelihood of developing a relapse within, on post-transplant. So maybe a post-transplant TKI maintenance or a DLI, prophylactic DLI will be okay for me.
So next, Dr. Pritish, what would be the transplant conditioning regimen if at all the patient comes into a remission with ponatinib or asciminib being used? Dr. Pritish?
The patient is patient is having a CNS involvement at the outset, and the conditioning regimen should include, I think, in my view, should contain a TBI contain regimen like flu TBI, the myeloablative dose, and with or without PTCY depending upon the type of the donor, whether match sibling or haplo. So I think I should include, or otherwise some may think about thiotepa also. But I think the flu TBI would be a preferred regimen targeting the CNS, apart from PTCY as per the donor type.
So right, so for this patient what we did, we started him on ponatinib, though it is not available, but on compassionate ground asciminib was also obtained. First we got a response with ponatinib, and because of the affordability issues the patient was shifted on asciminib, though this should not be the real practice, what I am discussing regarding what have been done to the patient. But ideally this patient should have been taken up for an upfront transplant because he has a sibling, and since their finances was an issue, we were not able to do it. So the slides are not moving, but I'll just discuss regarding my second case. It is actually a 20-year-old female presented with CML-CP in 2019, and post imatinib she was a low risk patient, counseled regarding all the drugs available. Patient was started on imatinib because he denied dasatinib or nilotinib because of the financial issues, and post 1 year of her imatinib, patient was in complete cytogenetic response, and she had a major molecular response of approximately 0.38% of BCR-ABL. In the meantime, the patient has undergone a marriage, and after that she is inquisitive regarding having a child. So my questions to the panelists now is, how would you approach a patient who is a young female, unmarried, presents to you in CML-CP phase, and then how do you counsel, and what is your way of going ahead with the disease, and what do you discuss with them in the OPD? Dr. Jogamaya.
Patient is married?
Yeah. She comes to you when she is 22 years of age. After 1 year, she gets married. So at 22 years of age, when it's your first visit, what are the things you would like to discuss with your patients?
Yeah, we definitely, because younger patients, we need to counsel them related to TFR, whether we can achieve a good response, good deep molecular response, and we can try to take them off the TKI. So definitely in younger patients, we would like to use the newer generation of TKIs like nilotinib, dasatinib, etc. So
this is most important, that even if the data show that the OS is similar in both, it is the same in both imatinib and the second generation TKI. The young patients are the ones where we think of the TFR, treatment-free remission, and second is to achieve a deep molecular response so that a TFR can be attempted at the earliest. So next is, if the patient now, she wants to conceive. So what are your, what will be your suggestions regarding how long she will take her medications, and what are the steps she should know when she is opting for a TFR?
Whenever we start the patient with TKI, we always try to achieve deep molecular response. After achieving deep molecular response only, we can tell that she can plan for pregnancy if she wants. Because after achieving the best response, then if any discontinuation or anything will be there, that can be again, we can get her back onto that.
Yes. So now
that has to persist for at least 2 to 3 years.
Yeah, so
that
there
you
are
can stop
specific
it.
criteria to which when you can ask a patient to go for a TFR. It should be at least 5 years of exposure to a TKI. Some study, there are 2 groups. Some say that it should be 8. The Europeans actually go for a longer exposure. The Americans, they go for a shorter exposure. At least 2 years of undetectable BCR-ABL level by the Americans. By the Europeans, it is at least 3 to 5 years of undetectable. But do you think that it is possible in our setting where we have a little bit of, you know, there are peer pressures, and from the maternal, the in-laws side, they come that I want to take up a pregnancy. This is what actually happened with the slides are not moving at all. So this patient also had similar, she was undetected for approximately 6 months, and then she herself opted to undergo a pregnancy. While trying, we tried to counsel her that every month we will be doing a BCR-ABL. For 2 or 3 subsequent months, it was undetected, but 3rd month when she comes, the CBC, it has jumped up, the levels have gone to 30,000 or 70,000, and the BCR-ABL has again jumped up. So now at this point of time, what would you suggest? Would you ask her, she has not conceived yet, would you like to start the TKI, or you would ask to continue with her pregnancy?
It's actually very difficult.
Very difficult. So this is what is we face in the real world scenario, though there are a lot of guidelines and we discuss a lot about them. So the patient herself opted, she would go for again a imatinib. So at this point, would you like to go for a dasatinib or an imatinib? Or a 2nd generation TKI or a 1st generation TKI?
I'll like to continue imatinib.
Right, she had a very good response with that, but still dasatinib would still be an option because we will have it a little bit earlier. So that was it regarding pregnancy. And what would be your approach when a male comes to you regarding he wants to father a child?
We have to tell that even if the patient is on imatinib, if he wishes to father a child, there may be some genetic abnormalities or congenital anomalies with the child. So that
as of now, for males, it is not mandatory to stop it. They can continue with it, but for females, definitely throughout all the trimesters, it should be stopped. Breastfeeding should not be allowed because TKIs, they come, they are also secreted in the breast milk. And there were some actually take-home messages which was regarding what we practice in India rather than what the West does. We have a lot of generics available with us, so 2nd generation TKIs are not a barrier to us to start the therapy. Second, we should have a lot of centers to take up transplants so that this disease, which has a lifespan of almost the same as that of a normal human being, patients, we are seeing a lot of failures nowadays to TKIs, isn't it? So these are the ones, they are not the ones who are in blast crisis. Patients who are in blast crisis or accelerated phase, they may again come up with the disease. But patients who are not able to, or failures of second generation TKI, at least 2, they should be given an option so that they can have a normal life. So that was it. I'm very sorry the slides didn't move and it was not a smooth session. But thank you to all my panelists right out there. Pritish and, yeah, you can add up something.
Yes, I just wanted to add that if a male person is on TKI like imatinib, dasatinib, bosutinib, there is no need of discontinuation. But there is scarce data regarding those patients who are on ponatinib or asciminib. So in those cases, we are not very sure whether the male need to discontinue or continue with the TKI. And apart from that, in all cases, we have to make sure that patient strictly adheres to taking the TKI from the very beginning, because compliance is a definitely matter of concern whenever we want to change the TKI. So many times we see that patient is not taking the drug properly, in the proper dose. And third thing, I would like to know from Dr. Lingaraj that what conditioning would he prefer for this type of patient what was presented in the first case.
I agree with you, Dr. Pritish. So any regimen which includes a TBI with some flu and PTCY depending on whether it's haplo or not. But my more important thing will be the post-transplant strategy that is more important.
Yes, exactly. I do agree with your
I will not intensify the
initial
conditioning
case,
much.
he got the cranial artery. So I don't think TBI would be possible to give 12 gray in that setting. He already got a cranial artery. Probably thiatiba based should be the way to go in that particular case. Otherwise, I really agree with you. Flu TBI would be my go-to.
So thank you to all my panelists. Reena ma'am, I would like to have your inputs regarding the cases and a gist of it.
These are like, the real world cases also. We all have these problems daily, and patients can't go on to second generation TKIs. They very quickly start showing progression of disease, and we need to think quickly for these patients. Our patients are younger. We have a lot of young patients. Pregnancy becomes a very important thing. So I think all the way it is counseling, counseling and counseling. And once we keep discussing with them and take them through treatment, by and large, all CML patients must lead a normal lifespan, no doubt about it. So good cases, good discussion. Most of the points have been covered, and I kind of congratulate both the panelists as well as the moderator for putting the whole session together.
Thank you, ma'am.
Thank you, Reena ma'am.
Thank you. Thank you.
So there is a saying, so we are near, but yet so far. So that is story of Pritish Patra and Priyanka Samal. They work in the same department, but again, physically and virtually at two different places. So really Priyanka brought out certain issues, though the slide did not move, but the essence was important. So thank you so much for joining as a panelist. Thank you, Reena ma'am. As always, need your blessings. So we move to, moving away from hematology session, so we are moving into session number 9 on the day 2 of the Congress. So gynecological cancers. So our chairpersons will be Dr. Bhagyalakshmi Nayak, gynecologist from Acharya Hariyar Institute, and Dr. Jaya Ghosh, colleague of mine from Medical Oncology, TMH Mumbai. Next. So the panel discussion will be, the first will be on advanced ovarian cancers. So we'll be focusing on a BRCA positive because that's the essence. You can take the chair. So it will be moderated by none other than Dr. T.P. Sahu. So you know him as Tarini Prasad, but the whole oncology community knows as TP or TP Sahu. So Soumya, if he can join, Sophies is going to join virtually, Dipti Madam, Ashok Padi, surgical gynecologist from Regional Cancer Center, Dr. Amitabh Jena, surgical oncologist, and Dr. Amit Verma, molecular person. He'll be joining straight from Delhi. So over to TP.
So over to you, Dr. Tar. Please take it ahead.
Thank you. One more chair. One more chair. Two. That's okay. It's okay. So this is the up and down. Okay, thank you organizers. So let's, the chairpersons want to say something before we move on? Nothing? Yeah. So there is no video. I don't have any video. Please, let's start off. Okay. So in the next 30 minutes, so we are 3:30. So 4 o'clock is the time when we hand over the stage. And let's go into, I'll just taken the liberty of little bit modifying it to also include ovarian cancer, the surgical part, because I have two surgical oncologists and it was very unfair to them just talk about BRCA positive advanced ovarian cancer. So when I looked at the panel, I did do this things. So are the virtual persons on? Excuse me.
Yeah, Dr.
Yes, Dr. Saud. Yeah.
Okay. So we have Dr. Shafiq, who's there?
Yeah. Yes, sir. Yeah.
So Dr. Shafiq is the only one who's virtual, no?
He is on virtual, yeah.
Yeah. So rest all are
And
physical.
Dr. Amit Verma, the molecular biologist. He is
Amit, you are there?
Yes, I'm there, Dr. Saud.
Hi, Amit. How can we have the panel without you? Yeah. so let's jump into the case. Okay. So we have a 57-year-old upper socioeconomic strata. So basically, we just take out the financial problems which you always want to discuss in our panels. And it is the patient who had abdominal distension for a month, ECOG, PS1, ascites positive, pelvic mass, and we have a serum albumin quite adequate of 3.5. The CT scan showed moderate ascites, adnexal mass, omental thinking, liver surface deposits. For my surgeons, I would like to make them very clear what I am looking at, because for my medical oncologist, I know they will tell it's all about chemotherapy. So these are the pictures. So Amitabh, would you think of operating this patient first? The CA is normal, the CA of 25 is quite high, above 1000, and the CA 90.9 is borderline up. Yeah, please.
Tarin?
Yeah.
What I feel, this looks like 3C. So because of omental technique, liver surface deposits, I still think of giving some neoadjuvant followed by surgery.
So you are thinking to refer to a medical oncologist for this. Is there a difference of opinion?
Yeah, I need a little more evaluation because say 19.9 also raised. So I will book more GI evaluation. So this seems to be a advanced ovarian cancer with upper abdominal diseases, omental thickness.
So you are referring it for chemotherapy.
So better to go for a NSCT.
Okay. So when I did this case for quite some panels, most of the gynec surgical oncologists did opt for even upfront surgery. So that I want to tell you, because nothing in this actually makes it inoperable. You can go for and operate it, but fair enough, you can do it. You can do it both ways. It is disease related, patient related, infrastructure related. If you look at the Cochrane analysis also, you would not find much of a difference if you go for chemotherapy upfront versus surgery upfront. And this is majorly that survival is not different, but you need more morbid surgeries, more dissections, more colostomies, more bowel dissections, probably when you do upfront ovarian dissection. So that could be the one of the cause, but I think anyone wants to operate it upfront is fair enough, provided he or she gets a R0 resection. That's something which you want to look at.
That's the whole motto, that we have to achieve a CC0. If you are not able to achieve, then better not to go for upfront surgery, rather to go for
so it's the skill of a surgeon, how confident he or she is to take it to a optimal sat reduction. Okay. So this patient did go for a primary debulking surgery. Optimal sat reduction was achieved quickly. Any role of HIPEC in this case? Quick, because we want to go to BRCA positive cases. Anyone?
Yes, I think there is a role of HIPEC is there. If first thing, we'll have to do a complete peritoneal stripping. Has to be done.
Done. Optimal sat reduction was done.
So still some microscopic disease will be there.
So you would opt for a primary.
Yes.
Can you tell me any evidence of a HIPEC in an upfront debulking?
No, I don't.
No, you would not. No. Sofik, being a medical oncologist, would you refer it to a surgical oncologist, even bother to refer it back for HIPEC?
So 5 groups. Group 1 is Dr. Priyambat Das and Abhilipsa Das from Regional Cancer Center. Group 2, Dr. Santosh and Dr. Sushil from Sam Hospital. Third is Dr. Asutosh Sahu, Dr. Sugyan Mahanti, again from Regional Cancer Center. Group 4 is Dr. Manas Ranjan and Abhishek Kumar Sarangi, again from Regional Cancer Center. And the 5th group, which is qualified for the final round tomorrow, is Abhishek and Antara from Sam Hospital. Ganesh, over to you.
Hi, good evening to all. We have now recently talked about the molecular things of HR and HRD. Now it's the talk of the era. We are thinking about olaparib, rucaparib, and niraparib. So I am talking about a case. It is about rucaparib in platinum sensitive relapse. Please scroll the slides. Scroll the slides, please. Okay. We have a 68-year Tara Manjula patient, Chaudhary, she has name, no comorbidities and postmenopausal, no comorbidities and no family history of malignancy. She has abdominal. She presented in 2018 August with abdominal pain and distension. We have done investigation, CT scan and CA125. In July 18, CA120 1323, and we have done FNSA followed by biopsy, serous papillary. In the scan, we have 5. Next, we have 5.5 and 6.3 and 5.1 right ovarian mass, and there is omental mets that around 6.5 centimeter mass. It's a stage 3C disease. We have planned standard guideline, nab-paclitaxel and carboplatin based therapy. After 3 cycles of therapy, there is partial response. The right ovarian mass from 6 centimeter came to 4 centimeter, and omental mets that is around 6 centimeter came to 1 centimeter. Good response was there. Then we have opted for interval cytoreductive surgery, in which its residual carcinoma in omentum microscopic metastases were there. Then after a fast follow-up, after 1 month of therapy, we did CT scan. There is those 2 lesions were mainly lymphocyl. There is no update activity, and CA125 was normal. Patient was followed up from 2019 to 21. Fast serological progression was seen in July 21. It's around 2 year and 3 months. There is the lymphocytes were there, which were gradually reducing, no enhancing lesions. So as there was serological progression, we are ready. There was no tissue, so we went ahead for germline testing. Germline BRCA was negative. Then from July to next September 21, then we followed up with PET-CT. There is a bilateral internal mammary nodes and outer nodes, so which suggestive of recurrence. We can't do a cytoreductive surgery at present. There is as internal mammary nodes were there. Where you can see last left side, we can see outer caval node and internal mammary nodes. NCCN guideline, we can see that when there is more than 6 months of relapse, platinum sensitive, we can go for a cytoreductive surgery if there is option of surgery, but as there are internal mammary nodes, we can't go for surgery. Then we opted for, we discussed with patient that what the treatment option, there is a treatment option of chemotherapy, and we can talk about the treatment era, what we consider tablet therapy, that is PARP inhibitors, recurrence therapy. As the patient was not willing for chemotherapy, actually, so we considered for rucaparib. We can see the NCCN guideline. Now the rucaparib, all PARP inhibitors category 3 indication. If you are not opting for second line or re-challenge with platinum chemotherapy. We started rucaparib on 4th of September 21. CA125 before the starting of the therapy is 337. Serially we did CA125 monitoring. After 2 months of rucaparib, it's 126, then 18 after 5 months of rucaparib. After 5 months, clearly we can see that PET-CT is CR, complete remission. So it's a good response. Before I was practicing in Delhi, there we talking about olaparib. Hardly we are seeing the response in the platinum sensitive relapse cases. Where much of data was presenting, but actually in clinical practice we are not seeing the response. But here rucaparib did a marvelous thing. After 5 months of rucaparib, we achieved a complete remission. Here you can see that the internal mammary nodes and outcaval nodes were not present after 5 months of rucaparib. We continued with rucaparib. Post 10 months of rucaparib, patient also doing well with CA125. Patient doing well, no radiological imaging done that present, but clinical patient are doing well. And C125 is 66.1. There is slight serological progression is there. Then we continue to follow up. We did a patient actually complained persistent headache for last 10 days. So no neurological deficit was there. There was just 1 centimeter lesion in left frontal lobe, 10.2 into 9.7 millimeter with perilesional edema, and there is altered signal intensity in the right transverse and sigmoid sinus, transverse and sigmoid sinuses. Though a patient followed up and CA125, then we did it gradually increased to 146. Then we did the PET-CT for confirming and if there is apart from brain mets, there is any systemic disease or not, but there is no active disease, and PET-CT confirmed actually that previous what the brain lesion is actually inactive and the size was similar only, and there is no disease elsewhere. So are we actually dealing with a rare complication of rucaparib? I have seen there is no, actually we don't consider about thromboembolism things in PARP inhibitors, and olaparib there is no thromboembolism, and scroll down the Medscape and found that in the less than 20% of cases in rucaparib there is thromboembolism data. Okay, then it may be the thromboembolism which may be causing. But otherwise, I think at present we are not dealing with progression. We may be dealing with progression, but only serological progression is there, but no imaging data. And apart from brain, there is no other recurrences. And in the ovary, you don't see usually actually a brain mets. So are we dealing with the progression? Are we dealing with the rare complication of rucaparib? We will monitor the patient, and presently patient received low molecular heparin plus all steroids and all paracetamol and glycerol. That only we are continuing. And the last 2 to 3 days patient has not called up, means actually patient may be responding. We'll see. As per the rucaparib, we have seen as per the data, Ariel 2, it is PFS around 12 months. We have achieved the PFS around 14 months. Actually, its patient is doing well as according to rucaparib. So niraparib also there is data with BRCA or without BRCA mutation also we can give niraparib. So rucaparib actually did well in this patient, and we should consider rucaparib if a patient is affordable with or without BRCA mutation, as we are thinking apart from BRCA, there is CHEK2, ATM, PAL2, all these mutations also also play a role, and there is actually response apart from BRCA to all PARP inhibitors. So definitely, if cost comes down, then the olaparib, rucaparib and niraparib, these are the talk of the day and we should consider. Thank you.
Right, asciminib. But he has failed actually. So no prize. Thank you. So what, Saurabh, please.
So there was one character in this Ramanand Sagar. There was one character. So you could see him everywhere, right? Someday he would be kodine soiniko hoithibo, kodine rakshasa hoithibo. So we used to joke, "Aaj ye rakshas bane hain." So today this is my second avatar, right? So shifting gears. So PICC line is something which is very, very important. So one thing I have always done, and this is very close to my heart, wherever I have gone, I have tried to use PICC line more and more. So my journey started with some hospital and subsequently Emory, Apollo and AIMS. Everywhere I have gone, I have tried to use PICC in any number of ways I have possible. So today we will be discussing mainly about global guidelines related to PICC, Indian practice patterns, understanding and resolving barriers. Most important thing, take home message, if you want to know, it is that use PICC line as early as possible. These are very, very important, especially for patients planned for chemotherapy. Takes care of so many troubles. So venous access is a problematic thing, especially when we are planning chemotherapy. Just imagine a breast cancer patient is planned for 8 cycles of paclitaxel and anthracycline cyclophosphamide. One of the hands you cannot use, the other hand you are using. And when one hand you are using, after first cycle of anthracycline cyclophosphamide, next time when the patient comes, there is a problem, no venous access. So the most important thing here is that at the outset itself, we have to discuss with the patient, you are going to get 8 cycles of chemotherapy, your one hand is going to be used, probably by first cycle we may not get a venous access. Would you like to go for a central venous access device, chemoport or PICC line? It has to be discussed. Otherwise, always trouble. In the mid, you cannot find a vein, you cannot give chemotherapy, and it is very difficult for the patient at that point of time. So the main context of this topic is that at the outset, when we are planning chemotherapy, especially prolonged chemotherapies, we should discuss PICC line insertion with the patient clearly, very clearly. If he denies, if he doesn't want to do that, fair enough, but a discussion needs to be done. So the global guidelines, as very clearly you can see, when we are planning chemotherapy for cancer patients, the recommendation is either a PICC line, tunneled catheter or port. So that's very simple. When you are planning chemotherapy, because there are multiple sessions which are going to happen, please discuss these things with your patients. Subsequently, let us understand the Indian practice. Whatever is written here is understood. More important thing here is PICC line is a costly option. You just cannot give everyone PICC line. You cannot provide a PICC line to anyone and everyone. And second thing, PICC line care, PICC line insertion, that's something which needs expertise. We do not have that thing in all centers. So what is essential? It is essential that staff, doctors, nurses should be trained for PICC line insertion and PICC line care. That is the most important thing. And if you ask me what is the Indian context, that is what I will stress upon. That we should train our staff how to insert a PICC line, how to take care of the PICC line, and that becomes very, very easier. In my center, the PICC line is being inserted by a radiologist under ultrasound guidance. Previously, when we were at other centers, we had trained the nurses to put the PICC lines themselves. So nurses used to put the PICC lines after they had undergone a proper training. They used to put PICC lines by themselves without ultrasound guidance. In blind techniques they used to put, and we had a very good result. I'll show you at the end. So because PICC line will take care of this, most of the drugs we are using, breast cancer, vesicants, irritants. And just imagine the pain of a person who has undergone an extravasation. With PICC lines, you can avoid that. So this is just an idea. So since the patient is not only getting chemotherapy, he is going to get supportive care, he is going to get blood test. Just imagine in your lifetime, in a patient's lifetime, around 100 pricks he will get. If you have a single PICC line, give chemo, draw blood, give blood products, everything taken care of. So as simple as that. So one PICC may be one prick in a patient's treatment journey. That is important. Four international authorities have endorsed use of PICC line for 12 to 24 months. Suppose palliative chemotherapy also, multiple cycles can be given. Why not use a central venous access device? Now coming to the peripheral, what is the availability of data? So we can see here the median duration 184 days, 6 months, very good. The patient can completely complete the chemotherapy. Now coming to the understanding the barriers. So nurse-led PICC insertion, this is what I was talking about. If you can train your nurses in the best practices of using a PICC line, no one better than them. You need not insert a PICC line, just train them. There are centers who are training PICC lines insertion. In Tata Memorial Hospital, they do it in a blind fashion. In Tata Memorial Cancer Center at Kolkata, they do it under USG guidance. So there are setups how you can send them across there. So nurse-led PICC team, cost reduced by 60% compared to doctor-led insertion of PICC line. Insertion rate 90% successful, complication rate only 4%. So very well said here that in our routine Indian practice, this could be a practice-changing thing which we can do. USG guided insertion reduces all complications. So nowadays most centers go for USG guidance, but as I said, to train the nurses to put a USG guidance is a legal problem, technical issue, all those things are there. So for nurses, blind technique is good enough. If at all doctors and availability of ultrasound is there, then we can consider ultrasound guided insertion as the gold standard. We are doing that at our center now. So these are the centers of excellence where you can send your nurses and team to get trained in PICC line insertion. Now this is the type of PICCs. So something we will talk about the Grosong PICC line. This is a most commonly used PICC line which we do in our routine practice. So important thing is that it is a Grosong is a PICC valve function which is there present. It's not an open thing. So there is one way blood going, one way blood coming in. So when you push, one valve will open one side. When you drag, another valve will open. So there is no issue with this. So this is a very good system about that. So this is a closed system with a valve, and therefore we prefer Grosong for our patients. Dressing requirements, most important. You are planning to keep it for 6 months. Who will do the dressing? So again here comes the role of the caregiver. So if I can train my nurse, the nurse can train the patient's attendant. Every week they can do their own dressing. The patient can go to their home, they can do their own dressing at home and come back for chemotherapy. They need not come to the center. But again, this needs extensive training for our patients. So these are all the things. They have also support for the home-based care, and the PICC benefit here is that for many PICC lines you go for stitching, and when you put a stitch to fix a PICC line, there is chance of infection, and this is somewhere where the stat lock comes with Groshong. This is like a sticker. Every week you can fix this sticker, put the PICC line, it is immobilized, and when you go for the next dressing you can remove it. For these PICC lines you usually use a 10 ml syringe, not a 5 ml syringe. So these are the summary of what I just said. So the central venous access devices are recommended for all vesicant and irritant infusers. Need to check the documents venous status. PICC should be considered for both continuous and thing. So thank you.
Thank you, Saurabh. Thank you, BD. So we move to the last topic of session 11. So clinical impact of diagnostic lab in advanced ovarian cancer, routine or just an add-up. So this is Dr. Garima Sarawgi, surgical oncologist. So this was supposed to be a thesis, and so all the best, Garima.
Good evening, everybody. I first like to thank Dr. Ghanshyam Biswas and the entire Indooncology Summit team to let me present and give me the opportunity to talk about a topic which is very close. So I'm talking about the clinical impact of diagnostic laparoscopy in advanced ovarian malignancies. It should be a routine or just an add-up to the diagnosis. Ovarian cancer is the second most common cancer cause of cancer death worldwide. We all know that. 70 to 75% presence in the advanced stage, and there is a very high recurrence and leads to very high mortality. The single most important prognostic factor in advanced epithelial ovarian cancers is the completeness of cytoreduction. So the completeness of cytoreduction is the most important thing on which I am focusing today, because that is the focus of my practice as well. The dynamics in the surgical concept has also changed accordingly. Initially, Dr. Sugarbaker's papers told us about the debulking surgery, in which debulking of the gross tumor was done. Then it shifted to optimal cytoreduction, in which the tumor, visible tumors, which is less than 1 centimeter, was sufficient. Now the concept is of complete cytoreduction, where all the visible macroscopic tumors should be resected. And that gives us the maximum benefit and prognostic in the lifespan of the patient. So imaging alone in triaging the patients, including in the selecting of the patients before sending the patients in advanced ovarian cancers for NACT, is what usually is used in this part of the country most commonly. So my topic of discussion is on this point more. Initial primary cytoreductive surgeries with the intent of removal of all the visible disease, followed by adjuvant chemotherapy, followed by complete reduction, cytoreduction, gives the most substantial improvement in the survival. This has been proven in many of the studies. Interestingly, there is no universally established criteria to predict the resectability. The local practices depends upon the local guidelines, logistics, cost effectiveness, and the surgeon preferences. Although ESCO, ESGO, NCCN guidelines all recommend laparoscopic, diagnostic laparoscopy in advanced malignancies before the surgery, there is no criteria mentioned even in those guidelines as the selective criteria to decide when laparoscopy is supposed to be done in a patient. So as a surgeon, to be able to do a complete cytoreduction, we need to first quantify the intra-abdominal disease. So to quantify the intra-abdominal disease, the concept of peritoneal carcinomatosis index came. Now, because of the advancements in radiology and imaging, there is radiological PCI indexes and there is a laparoscopic PCI indices. There is a meta-analysis that was done Cochrane meta-analysis that compared the various PCI indices that are available, and on comparison with the predictability of resectability in a patient, it was found that the Fagoty modified scoring and the Sugar-Baker's PCI index was the best to predict resectability in any advanced ovarian malignancies. The other mentioned in the slide, like SNCOP, Fagoty score, Fagoty modified, LAT, all the other are basically radiological PCI indices. So what I want to emphasize here is a Fagoty modified scoring system is also based on a diagnostic laparoscopy to assess the PCI index, and the primary PCI index that was devised by Sugar-Baker was also the same. So the direct visualization by a scope tells us about the tumor distribution, morphology, and the burden of disease exactly. That is why the predictability of resection is much more higher and accurate in the scoring system. So this meta-analysis also led to the thoughtful process of doing a scopy in as much patients possible before sending to a neoadjuvant chemotherapy, so that the ability to resect the disease maximally is feasible in the interval debulking surgery that we do after neoadjuvant. So an interesting article was published in 2022, this September, the bumpy road of peritoneal metastasis in ovarian cancer. So peritoneal carcinomatosis and the spread of ovarian cancer inside the peritoneum is very interesting. It does not make the disease non-resectable. Because if all the metastasis, even the omental nodules and the peritoneal nodules, if removed completely, it is still stage 3, and the longevity of the patient, the survival, both overall survival and the progression-free survival are very high. So in this article it was mentioned, bumpy, as the mnemonic says, bowel, upper abdomen, mesentery, and peritoneal metastasis. These are the sites which decides the factors on which the resectability is majorly depending. And the small bowel involvement is also an increased risk. Why? Because these sites, if bulky diseases are present, then they are the reason for suboptimal cytoreduction in the primary setting. So the further classification, as a surgeon, the sites of difficult resection for all the surgeons in the primary setting are these. So resectable diseases are which in the upper abdomen, in the peritoneum, the nodules which are present are scattered, or they are present along the superficial layers of the mesentery, or present on the superficial part of the subdiaphragmatic, or in the liver subcapsular region alone. Whereas the lesions which are difficult to resect are when there are multiple clustered of nodules on the mesenteric surface which are infiltrating into the mesentery, or multiple nodules on the serosal surface of the small bowel, or there is infiltration of the nodules into the serosal surface of the small bowel. When there are multiple nodules in along the mesentery, going in the center part of the mesentery, very close or infiltrating into the vessel, or along a long segment of small bowel, causing kinking or infiltrating into the bowel wall. Coming to the upper abdomen, along the porta hepatis, along the gallbladder fossa if the lesions are there, along the gastrohepatic ligament if a big mass is there which is more than 4 centimeter, along the lesser omentum, just on the surface of pancreas in the superficial surface, going to the retroperitoneum. In this area, when we come below, the retroperitoneal nodes which are suprarenal in position, and the lesser sac along the splenic hilum or close to the splenic hilum. So as a surgeon, if these sites have bulky disease more than 5 centimeters, then upfront in imaging, in cross-section imaging, then I can prefer to send the patient for a neoadjuvant chemotherapy, so that after the chemotherapy I can assess the resectability of the disease. But even if these things are present on a cross-sectional imaging, a PET scan or a CT scan, then also I would definitely like to know what is the spread of disease in the superficial parts as well, and what is the order and bulk of disease infiltrating in actual. Even in these conditions, the preference is to check the spread of the disease and then send for NACT so that in later IDS we can do a complete cytoreduction, which is the primary goal. So PET scan in advanced ovarian cancers, the sensitivity specificity is shown over here. What I want to emphasize is all those difficult resectability criteria that I had mentioned in the previous slide. In all those, the PET scan has variable, very much variable negative predictive value. And that depends upon the stage of the disease, that is between 45 to 96%. So the variability is on the stage in which the patient is presenting, also on the expertise of the person who's doing the scanning reporting. So that cannot be reliable unless we have a direct visualization completely. So diagnostic lab itself also has definitely many bad and good effects, because of which it is not in routine practice as of now, despite of the recommendations. So the yin is the positive part, the yang is the negative part, as I'm showing. It shows the direct visualization, morphology and the burden of disease. The tumor biopsy, for medical oncologists presence over here, a tumor good biopsy, the specimen amount, so that we can send it for a molecular, genetic and other testing is very important. The yield of biopsy by image guided biopsies is not very high. In 30% of the image guided biopsies that is done before NACT of the patient is negative, or the yield is so small that we get only the biopsy reports, but we cannot send the sample for molecular or genetic testing. Now this is the era of precision. We are targeting every molecule level, so we definitely need better amount and yield. For that also diagnostic lab definitely helps. The futile laparotomies that were happening will be less. Futile laparotomy means you open the abdomen and close the abdomen. That is much less when we do a diagnostic laparoscopy, because then we know when we should not open the abdomen, at least for sure. Maybe we will not be able to assess to open or not. So the negative value is much high than the positive prediction of diagnostic lab. The overall cost of diagnostic lab and a futile laparotomy when added is almost similar. So if we are considering the cost of diagnostic lab as a bad effect, we should think the cost burden it is causing to the center in terms of the cost burden it is causing to the center in terms of futile laparotomies that are happening because of not doing the diagnostic lab. So it is done under general anesthesia and there is 1 to 5% risk. So the patients who are poor patients criteria for general anesthesia are not ideal candidates. Cost increase, as I mentioned earlier, if we look at the overall scenario, the cost effects are not much. The complication risk, the complications of blood loss, stay in the hospital when compared to a simple biopsy is much more. Port site recurrences are 2 to 22%, but the port site recurrence does not change the stage of the disease. The stage of the disease will still be stage 3 itself. And when we are planning for a interval cytoreduction after NACT, then we can go for a complete resection of the port site as well. The presence of adhesions and presence of frozen pelvis. These are two places where a diagnostic lab does not have a very good effect, because the index that we want to see, the burden of the disease, the morphology, will be difficult to visualize. In these cases, when we combine a diagnostic lab with a CE-CT abdomen pelvis cross-sectional imaging, then the results are much better. A few studies have shown the intra-abdominal CO2 usage in diagnostic laparoscopy sometimes causes increased dissemination. Yet again, yes, there is 1 to 2% chances of increased dissemination, but the stage of the disease remains the same, stage 3. So the outcome after this is still the same. So all the yangs in diagnostic lab is actually a yin. It is not causing any harm to the patient, it will rather cause benefit when we look into the larger picture. So the NCCN guideline, as I started with my point, the ESGO, ESMO and NCCN, all of them recommend the usage of diagnostic lab in the diagnosis, but during the clinical staging part. And there is no clarity between the selection of the patients. So from stage 1A to 4, they are mentioning we can use diagnostic lab in select patients. The patients in which diagnostic lab should be used routinely is what I'm presenting. So the question was, which subset of patients with advanced epithelial ovarian cancers are ideal candidates for diagnostic laparoscopy? I have answered the question. Sites of difficult resections. For a surgeon, I will always prefer putting a diagnostic laparoscopy and a PET scan, compare the PCI scoring of both radiology and laparoscopy to get an exact PCI score and the burden of the disease. This helps before sending the patient to neoadjuvant chemotherapy. This will help me to know the exact disease burden, the location of the peritoneal or serosal disease that cannot be picked by the cross-sectional imaging, which are smaller than 0.7 centimeters. Specific location of the expected response to chemotherapy. If the response is very high, there will be certain scarring over where redundant or dormant cells may be present. Those has to be removed during the interval cytoreduction. The sites to be rechecked for assessment of response again on metabolic scans. And if planning for HIPEC during the interval cytoreduction, breast predictability will come when I will know the disease is exactly and completely resectable. So same thing again, then NCCN guidelines shows after NACT also, we should always put a scope before going for an interval cytoreduction. So the take home message from my side for our state, because I've come recently back from Bangalore, and there we used to practice a routine diagnostic laparoscopy for all the patients in which there is clear no indication is, even if the patient volume is high, even if there is no availability of the centers, refer to somebody else. If you are unsure of resectability, if there is doubtful, should we always put a scope or not? We should. Thank you so much.
Thank you, Garima. So now we move to the last session of the day. So the chairperson is Dr. Niharika Panda, Radiation Oncology Head at Acharya Hariyar Institute of Postgraduate. So Madam.
So we have come to the last session of the today's, and this is regarding the palliative care session mostly, and I'll call the first speaker, Dr. Sunil Agrawal, and he will speak on future in healthcare beyond telemedicine. So Sunil, please.
So, respected chairperson and dear colleagues, a very good afternoon to everyone. We talked throughout the day about the curative one. Yes, we love to talk about the curative. We, the doctor, wants everything get cured up, because the palliative care is it's not a rewarding in terms of value for time and money, definitely. So I'm really thankful to Dr. Biswas, who has given this importance on this palliative care and given an opportunity for me to present something about this topic where something innovation can happen. So first of all, as I said, we the doctors love to treat that curable disease, treating the patient because it brings name, fame and money. We don't want to treat all those patients who require a lot of attention of ours and the end result is zero, because that's not value of money, by value of time. We the doctors are only having one thing in our hand, that is our time. So, and we have been trained also that utilizing our time, that is a triage system is also there. That's what sorry, we have been trained. So here comes the focus, who is looking after all those patients. So there comes the solution. So let us talk about these things in three prospective point of view. What is the current problem based on these patients? What are the current solutions? And what next I am going to bring about and talking on this forum. So what inspired me to talk about all those kind of things? In my OPD, I have seen, this is a case scenario where a 50-year-old female has come with a CA ovary stage 3. So the problem of getting her ovarian cancer is not because of its fate, because she is a female, but the agony is more because she has been paralyzed. She fall from a roof at a young age and she became paralyzed, and to add on to her agony, she is having a 3C cancer. Yes, definitely as per the protocol, we are very much investigated and given a neoadjuvant chemotherapy. Now her husband is a betel shop owner. Her ascites is not going to come down within a day or two. It will take some time. So what kind of time she will require? She may require a 1 month time, and each and every time the husband says that I have to close my shop, bring my wife, come to the hospital, at some hospital, and drain the ascitic fluid. Won't be it's a pity kind of things that you take the credit of treating the patient, but who is going to look after these kind of things? So that's bring a thought to my mind. And next, this is the patient, not only from the cancer one, he is not on ventilator, simply on tracheostomy. Now who is going to look after this one? Now who is going to look after this paralysis patient once he been discharged because of stroke and everything? Kidney failure patient, heart failure patients. Now we talk about health for all. What is the definition for the health? It's a mental, physical and social. So what kind of mental peace you are giving? You might be treating the patient physically as a mechanical. You are a mechanic, the disease lies, you are just treating some kind of purja and helping him out to get rid of her pain and everything. But what kind of psychology when the patient is having? So I don't consider that the holistic, this health definition we are able to deliver to the patient. Again, I'm not blaming to the doctors because of the lack of time. So, and this problem is not confined only to the cancer, but to the cardiac one and COPD, AIDS, diabetes. So all the chronic diseases, yes, we do have these kind of problems. So when I gone through the literature about what kind of things are happening, I found very statistically, very astronomic sorry, data. So India is 145th position among the 180 countries. Thank you, ma'am. Thank you very much. So in bottom 1/3 of the in terms of health care and palliative care. So just giving some kind of figures so that you will come to know how important these kind, because without data we are scientific people. Without data we are not going to understand the things. So now when I come to know about this kind of things, India is one of the worst place to die. I mean, what is worst place to die? And in terms of accessibility of the health, affordability to the health, and how we deal with our chronic patients. You know, we are sitting at Bhubaneswar, Bombay, Delhi. We said like, yeah, health is quite a nearby. You have something, call ambulance, the things will come. But what about our Malkangiri or tier 2 or tier 3 cities where the things are not been that kind of, what the things which we are getting at Bhubaneswar. I'm telling you, if a problem occurs in a medical problem, suppose you are not a doctor and suppose some problem occurs in your family, God forbid, it's very difficult to tackle all those kind of things in a in today's area, having so much of facilities. So in the present module, so we talked about the problems, we talked about the statistics. Now the present module in our state, what we are having. If a patient says that, yeah, I don't want to come to hospital because of its whatever XYZ reason, maybe the COVID reason, initially it was there, and patient cannot come because of the paralysis or the physical conditions, and the hospital has got a limited role. No hospital wants a palliative patients in their ward because the number of turnover increases their revenue. Not a single patient staying for 10 days that brings the revenue. No. So the hospital also don't want. That's why they used to call us, sir, kebe chutti hova. Patient, when you are going to discharge the patient. So that brings the more revenue to the patient. So presently we are having e-consultation. That's the government, which is from the government side also. We are having a video consultation, audio and text. Video has got its privacy and that kind of module and internet and the availability of the concerned doctor has been required. Audio, definitely you don't have anything to see. Text message, you don't have that kind of interaction. So everything has got its limited role. And in the healthcare, that is the only industry where your physical presence not only give as the patient, so sir, aapki baat sunke to mera aadha dard दूर हो गया, आपका टच से मेरा आधा दर्द दूर हो. So that kind of thing is only happening with the medical. So nobody can replace our physical presence. So that's what, this is not the thing. So what is the solution? Can this new technology which we thought, and with the help of the technology we built, that is VKRU app technology, whether this can help. So let us see how this is going to. This is a two application. One is there, it's like a based on an Ola Uber service kind of things, where the partner is having our doctors, nurses, physiotherapists, pharmacists, and lab and chemists are there, and patients are definitely are there. So partners are voluntarily registering themselves to this platform, and patients are putting their request and getting their service. That's the partner application, and that's the patient application is there. So let us see how the patient is doing a booking. So once the application is being downloaded, that's the patient application. All the services which is been shown over here are being shown to the patient. Suppose a patient wants a doctor at their home. So he click on the doctor, the first thing is will come as a select the patient. So if you don't have any patient which has been previously been there, you have to add the patient. As we are taking in the OPD, the histories are there, name, age, and whatever the comorbidity is there, they have to put it down, and the patient has been added. Now once the patient has been added, you have to select the patient, and you have to write down the problems. You have to choose whether you want a specific doctor or a random. Any doctor can come and see your patients. So basically, this is a basic health care, not a specific health care. So, and then patient chooses the date and time, and the price also will come. So the patient has got everything clarity before them, before booking a service. So he is getting a clarity over this one, and then he put his address and then book. So with 3 easy steps, selecting a patient, writing the problem, and date and time. That's the 3 steps. He is booking his services, and within 2 minutes, somebody will accept, whoever the doctors have registered with this application, accept this one, and that's after the, suppose some doctor has accepted, so everything will come before that one, his registration number and experience, and he is going to visit, and then he can see from my booking chart what are his previous doctors are there, he can see, and the services can be completed, and it's an OTP based services that can be completed. So what is my take home message to this one is that human touch is definitely a must in healthcare, and any intervention by technology, if possible, yes, it should be done. But at the present moment, we thought of the telemedicine is the last one. Why not to go beyond that one? Because right now, the supply, we do get more than 3 lakh doctors yearly in India, adding up to the volume, and all are coming to the Bhubaneswar or metro cities, because there is not much opportunity is there at this one. And you believe these doctors have been joining. First of all, their aim is to serve the patient. Second thing is that the incentive. For 15 minutes of service, they are getting 700 rupees. That means 1 hour service, they are getting in 1 month 1 lakh rupees. 8 hour service, that's a 8 lakh rupees. So the initial doctors, those who are preparing for the exams, those who are retired doctors who don't have any job to do, yes, they can utilize 1 hour of their time and can give service at their own locality, and serving the patient from that locality, giving the service by the partner from that locality. So that's the bridge. And I invite, since we have completed more than 5,000 services in Bhubaneswar, I invite to visit to the upstairs, the outlet is there. You just visit and have a practical experience on that one. And we want to move outside Bhubaneswar. So alone cannot be done by me. So if anybody can be interested, yes, we are eager to share and partner with them. So come and visit to this one. Thank you very much.
Thank you, Sunil. Definitely, we are going to tell our patients to download your app and get the benefit. Thank you.
Thank you.
Our next session is of end of life care. Sunil showed one slide that India is the worst place to die. So this session will deal how we can make death peaceful and dignified. So Madam Professor Sumita Mahanti will talk about end of life care in oncology.
Good evening, everyone. My sincere thanks to Dr. Ghanshyam Biswas for giving us this opportunity. My topic is end of life care. So it's a very vast subject, but the time is allotted to me is only 15 minutes. So, like there is dignity in life, there is also dignity in death. So this slide you can see, this is about quality of death index. So according to the latest 2021 data, you can see here the India rank only 59 out of 80 countries. So it gives how well we die. So definitely we are not doing so well there, and in spite of although we have a very healthcare resources with us. So if you look at how do most people die, die in India, I mean to say, it's a majority of them die in ICU, in hospital and in ICU. And according to the 2016 data, 58.17 lakhs death is due to non-communicable disease and cancer being a part of it. Out of which 78% of patients leave the hospital against medical advice, who don't get the continuity of care without any symptom relief. And those who die in hospital, they are subjected to inappropriate intervention, and major expenses are from the out-of-pocket expenditure. And you'll be surprised, Lancet Commission says 55% of Indians pushed below poverty line because of this healthcare cost. So, most important that neither the public nor the healthcare profession are well aware about the concept of end of life care decision. And so it is very essential that we should talk about it, and we should educate and train ourselves and see how best we can improve the quality of dying in India. So I'll be touching only the basics, what is end of life care and how you are going to provide it. So what is end of life? Is it the care in the last few days of life, or during the last few hours of life, or is it the same as palliative care? So here is the definition, which includes also the after death care and the bereavement care, and it is not only for the patients and also for the family members. So the next question comes, what is the time frame when we are supposed to start this end of life care discussion? So is it really important to know, because when we search the literature, there are different schools of thought. So in UK and US and in India, the nomenclature are a little confusing, but ultimately the same means it is last 12 months, last 6 months, few days and hours. So here you can see we have palliative care, end of life care and terminal care all together. So if we going to address palliative care, it should be addressed at the little early at the time of diagnosis, where we address the disease treatment. We aim at disease treatment along with supportive and symptom control. But when we enter the end of life care, the disease has already advanced and it becomes incurable. So the care of focus changed to supportive and symptom control. But when we enter the terminal care, it's few days or hours, then the focus becomes only symptom control. So primary objective is to have a good death, and there is equal emphasis on quality of life and as well as the quality of death. And every individual has a right for a peaceful and dignified death. So this is about good death. And we need to understand different trajectory of the disease. Here you can see these are the three trajectory where the end of life should be initiated. Like first one is for cancer, second one is for organ failure, third is for frailty or dementia. So these are the 5 important steps to for end of life care process. And there is surprise question. So when we decide that we are going to start end of life care process, we need to recognize whether it is really end of life care, patient has reached really the end of life care or not. So there are few surprise questions, like if you ask, will I be surprised? And if the question is no, then yes, you should go ahead with and start with end of life care discussion. And there are few general indicators and few specific disease indicators or prognostic indicators. And here I'll just highlight about the cancer, where the indicators being it should be a metastatic disease, and the single most important predictor is the performance status. If the patient spends more than 50% of the time in bed, then it is the time you should initiate end of life care. And there are other prognostic indicators for COPD and chronic and heart disease and renal disease and other neurological diseases, and for frailty and dementia. So there are few early late signs of those who are dying few hours and days of life. So if there is at least 4 symptoms present, then you can tell that this person is imminently dying. And next comes the end of life decision making. So this is so very important. There should be a general consensus among the medical team members, caregivers, all the team members, and after that, once they have arrived with a consensus, they should communicate it to the patient and family member in a very sensitive, honest and empathetic manner. And one should have a discussion what are the preferred place of care of the patient, preferred place of death, so that you can have a system in place so that patient can die at the preferred place of choice of place. And all these decisions should be very, information should be consistent, and all the team members should be at the same page, and the care which have been provided should be shared among with the primary oncology team and also the specialist palliative care team, and even to the primary care physicians. If patient opt to die at home, then they will also know the patient's choices. and there should be a continuity of care. Like if patient opt to die at home, there should be some local doctor to look after the patient, and all the medications should be available, and there should be accessibility to the palliative care team whenever necessary. So all these things, these are the points would be discussed about end-of-life care. And I'll tell that if we will integrate palliative care early, all these points becomes easier to discuss, and the transition will be smoother. And as we all know that end-of-life care is symptom relief is the priority, because we need to see the comfort of the patient. So it should be treated adequately. I'll not like pain, dyspnea, and death rattle and delirium, and all these things should be addressed appropriately, and all the emergency situation like stridor, seizure and hemorrhage, where the family members need to be educated properly and empowered to deal with the situation at home. And nursing issue is very, very important. After death care, there should be a timely and a dignified transfer of the body once the death occur. After that, it should be transferred in a timely and dignified manner to any place wherever they want. And bereavement care, it should be for the family members till they are out, they have completed grief. And few people, they enter into the complicated grief where they need a help of healthcare professional, mental healthcare professional. So to summarize, good death is possible, and we as healthcare professionals, we have taken the responsibility of treating the disease. So the same way we should lead the conversation about end-of-life care, and we should empower them and help them to die peacefully in their preferred place of care. So now the choice is yours, and whether you want to die in the peacefully around your family members, or you want to die alone with unrelieved pain in ICU. So thanks, Seema, for sharing your slides. Thank you.
Thank you, madam. Thank you, madam, for your nice presentation. Next speaker is Dr. Seema Rao. She is from Bagchi Karunasrai. She will speak on co-creating quality in palliative care.
Good evening, everyone. Can I start? Yes. Yeah. Good evening, everyone. The topic given to me is co-creating quality, the interface between oncology and palliative care. So, greetings. I bring greetings from Karunashraya. This is the 73-bedded hospice that we have. Okay. Thank you. 73-bedded hospice that we have in Bangalore, and we also have recently are building a 100-bedded hospice in Bhubaneswar. We already have started home care services, and many of you are referring patients to us. So thank you for that. Coming to what we talk about, I will be speaking about the oncology palliative care interface, the current evidence what is there, and what are the existing models of delivery that is there, and how we can move from interface into actual integration, and how beneficial is it. So coming to, before I proceed, this is a song, The Chocolate on My Tongue by Wood Brothers, and the last line of it, and if I die young, at least I got some chocolate on my tongue, embodies the ethos of palliative care, how important quality of life is for individuals. It is not about the length of the life, but about living life as well as possible until the end. That sort of quantifies what quality of life is all about. So when we look at quality cancer care, there are three aspects that you look at. One, you improve the health of the person by cure and controlling the disease. Second is about improving the experience of that individual. And the third is about the cost of it. And since the last 2 days, I've been hearing a lot about genetics and precision medicine. This article published in the Lancet on 25 years of precision medicine in oncology talks about how far oncology has progressed. Right? It talks about the various treatments that have come in and how cancer has now become a chronic disease. But it is also important to note that the other aspects of the individual is not lost in genetics and cellular techniques. Coming to quality, improvement in quality of life has been the hallmark of oncology care. But you also have to understand the main drivers of quality of life are also psychosocial aspects, economic, lifestyle, and preference-based care. And that is where palliative care comes in. While oncologists try to control and cure the cancer, we can look at this part of quality of life. So when we look at quality of life, it has 4 dimensions: the physical, the psychological, the social, and the spiritual. And you have to understand that the well-being, as previous speakers have said, have multiple trajectories. As you can see, the psychological trajectory, the one in green, does not normally follow the physical trajectory. For example, a 68-year-old patient, woman, very healthy, comes to you with probably early breast cancer, ER positive breast cancer. What is going to be the prognosis? Good or bad? Going to be very good, right? Now, provided she comes to you for treatment without, falling in between, isn't it? Now, suppose this woman comes from a very poor socioeconomic status, has recently lost her husband, has poor social support. Do you think the quality of life would be as well? Absolutely not. So when we focus only on the physical aspect, we are missing out on a lot of things. So we have moved from the traditional model of palliative care, which was only when no cure is possible, you send the patient to palliative care, into a more integrated need-based care. Wherever the need is, whether it is early on in the stage of cancer or in the advanced, you can incorporate palliative care. So there are various, ESMO has come up with supportive care. Supportive care is nothing but palliative care for patients who are in the curative state. You have palliative care and then you have end-of-life care. All different components of palliative care that looks at different stages of the disease. The evolution in palliative care started in 2010 with Timmel's study of how early palliative care was beneficial. There were a lot of RCTs which was done after that in 2014 to 15, which finally sort of proved that palliative care, integrating palliative care for patients with cancer was actually beneficial, right? So the tumor-directed approach by the oncologist, the host-directed approach by the palliative care physicians produced the best patient outcomes. What did it do? It improved the quality of life of the patient as well as the caregivers. It provided good symptom control, physical as well as psychospiritual. It improved survival, surprisingly, and the likelihood of respecting patient preferences and family satisfaction. It also was beneficial to the third aspect, what we discussed, the cost. Aggressive treatments were less towards end of life and patient satisfaction was better. So not surprisingly, then once these trials came out, ASCO, ESMO, NCCN all came up with guidelines how imperative it was that we integrate palliative medicine into regular oncological practice. So, but what is the reality? So this study was done in 1920, in the Indian context. We had around over 250 cancer treatment centers in India under the National Cancer Grid had been registered. About 102 centers were surveyed on how integrated palliative care was with them. And what did it show? It showed that the majority of the NCG centers have facilities to provide but suffer from poor implementation of existing policies, funding and human resources. Palliative care was there, but the implementation of palliative care was very poor. Globally also, most of the patients are referred in the last 30 to 60 days before death to palliative care. And who are the gatekeepers? Who are the gatekeepers? All of you sitting out there, the oncologist. All the more imperative you understand why it is important to refer so that the quality of life of the patients can be looked into. So what are the existing models? We have what we call as the solo practice model. The oncologist provides oncology care, manages symptoms, and also looked after the end of life. Possible in our settings? Is it possible given the time constraints and the number of patient load you have? Not possible, right? And that is where the difficulty comes in. The second is the Congress model. You have the oncology clinic, you have the plain clinic, you have the psychiatry clinic, so you keep referring patient to different clinics. Possible? The patient will not go anywhere. Finally, will stop coming to you also, right? So what happens is care becomes fragmented, care becomes unstructured, and care is not accessible equally to everyone. Does that provide quality oncology care? No. Now, what is the model that is most likely to work? Is what we call the ideal model is the integrated model. You have the oncology setup, you have a palliative care co-located in the oncology, palliative care is integrated into the tumor board, located inside the oncology building, and there is collaboration, communication between the two teams, oncology and palliative care teams, so all patients get the care that they require. There are 38 indicators of integration. It includes education, oncology team rotating into palliative care residents rotating into oncology. There are clinical structures and processes in place, and the administration is on your side. And that is how you achieve integration. Coming to the integrated model, it standardizes patients' access to timely, comprehensive, concurrent palliative care, normalizes the introduction of palliative care. So palliative care is not meant for only dying patient. It is meant for patients who have complex needs. It minimizes the demands from the oncologist. We play the supporting actor. You are the main actor, we are the supporting actor. In the movie Anand, between Amitabh and Rajesh Khanna, right? Both had equal prominence, isn't it? One supported the other. That's what we will be. And it reduces the need to refer to multiple, like the Congress model, patients having to go from one doctor to the other. So in conclusion, patients with incurable cancer have palliative care needs along the continuum of their disease, and there is level 1 evidence to prove that palliative care integration into oncology has benefit, and it is a moral and ethical duty or responsibility of every oncologist to, ensure that patients have access to palliative care. And it's also your duty to equip yourself with the basic competencies to provide care. And the goal of oncology extends beyond reduction of the tumor burden and deferral of death to help patients live as well as possible for as long as possible, right? And my last slide is about the IAPCon 2023 to be held in Bangalore. We have one full session on oncology palliative care. I'm requesting all oncologists to please register for this conference. Thank you.
Thank you, Dr. Seema, for that elaborate presentation. Our next speaker is Dr. KVS Rao from palliative care. We are switching over to early detection. So you'll speak on oncovarics, detection of women cancer from blood.
Thank you so much, ma'am, and thanks also to the organizers for this invitation. So basically, I'm a little bit of an anomaly here. I'm not a medical doctor, I'm a PhD, and I'm representing a startup company called Proteomics Technologies. And the reason I'm here is our fundamental goal is to develop completely new technologies for detection of cancer in the early stage. Okay, so just to give you a little bit background, when we talk about diagnostic, prognostic markers, etc., we're fundamentally looking at the different classes of molecules that are involved in information transfer in biological systems. So we've heard a lot about genes, that's one. Although they're extremely popular, the problem with genetics or gene mutations, etc., is their information content in terms of function or functioning is extremely poor. You know, we end up just collecting more and more mutations. This becomes a stamp collection exercise. But if you sum up their contributions to a disease process, you don't get very much, right? This is also the story with BRCA1, BRCA2, and so on. RNA, of course, is challenging. It's very versatile, and you also need to go to the tissue, so it's non-invasive. It cannot be non-invasive. Proteins, we have a few protein markers, very poor specificity. You can't look more deeper into the proteome because it's technically challenging. But when you talk about metabolites, these are the small molecules in the blood. They are the endpoints of the body biochemical reactions. Examples are glucose, cholesterol, steroids, lipids, etc. These are all reflections of the biochemistry that's happening in the body, and they are very easy to profile at very high depth, and you can get a lot of information about metabolites, right? So that's what we focus on is in this area called metabolomics, which is sampling or mapping all the metabolites that are present in, and we use blood, so in the human blood. Why we do that? Because they are extremely important. They're the heart of biological reaction. So if you capture the profile of metabolites, you're essentially getting a snapshot of the health state of an individual. And importantly, they also integrate genetic, lifestyle, influences, and environment, which is all. And because they are biochemical readouts, they provide the most accurate descriptors of the health state of an individual, and also function as proximal reporters for disease, right? And in fact, they are the most accurate reporters for disease of all the classes of biological molecules in the human body. And this is particularly true in cancer because cancer fundamentally is a metabolic disease. So, you know, there is alterations in metabolism because cancer cells have to continuously divide and so on. And therefore, you will find signatures of cancer within the metabolic profiles of biological samples of individuals. And we focus on blood because blood samples all the tissues. So in a sense, it's sampling the biochemical activity that's occurring in tissues, right? So, okay, so in the context of cancer, I'm just going to run through this. I don't need to, we know that the fundamental problem of mortality in cancer is primarily because diagnosis occurs too late. You cannot, if you catch it early, particularly in the early stages, the prognosis, at least 5-year prognosis, improves dramatically, and you can reduce cancer mortality by as much as 70% if you can detect it very accurately in the early stages. Yeah? Now, so that's what our focus is to detect cancer, especially in the early stages with high seeing. And currently, we don't have any efficient methods for this. You know, you have all of these various procedures, but all of them lack in sensitivity and specificity. So you really don't have very good methods to detect early stage cancer. So what you actually need is new methods, new technologies, which should be non-invasive, which should be very, very accurate. And importantly, if you can actually simultaneously detect multiple cancers in a single test, then you obviously are able to deploy it much better as a screening platform in the population, right? So, like I said, our approach is So this is a recognized need now. There are a lot of companies and academic institutions developing multi-cancer detection tests, and the bulk of them actually focus on this technique called cell-free DNA or circulating tumor DNA. And this approach is based on the principle that as cancer cells multiply, some of them die, and these dying cells release their DNA into the blood. So if you collect a sufficient amount of blood, about 20 ml or so, you can then isolate the DNA and identify it. Basically, these are epigenetic changes, methylation and so on, identify it as a marker for the presence of cancer. But the problem here is early stages, it still is a major challenge because very few cells are dying, very little DNA is being released, so the sensitivity is really terrible, and the best of techniques in the world can only achieve about 30 to 40% sensitivity. Whereas on the other hand, in our case, like I said, we monitor metabolites, and I'll explain the method in a minute. We only need a very small amount of blood. And in fact, the test we use serum, which is hardly less than 0.01 ml, and we can actually get an accuracy, as I'll show you, of more than 98%, particularly in the early stages. Okay. I just want to explain the principle. I won't go into this at all. This is basically the metabolic pathway, this is glycolysis and so on. The point I simply want to make is any perturbation in these pathways changes the concentration of all of these metabolites in the whole network. And what you do is you can look at it, and if you can profile all of these metabolites, there are thousands of metabolites I'm talking about, and if you can profile them, you can think of, you can generate a landscape of metabolites which includes, say, what metabolites are present and the relative amounts that they're present in. And so in a disease situation, whether it's cancer or any other disease, some of these reactions would be affected. So the contour of that landscape will change, and you can actually, if you have a way to analyze those landscapes and patterns, different pattern landscape, you can come up with a very, very accurate method to detect the change in landscape that corresponds to disease, and that's exactly what we do. So what we do is, to get the landscape which is monitoring all the metabolites in the blood, we use this technique called very high resolution mass spectrometry. So we generate profiles of about thousands, about 8,000 or so metabolites, what metabolites are present, what the relative amounts are. And then to capture those changes in so-called landscape, we use a set of 3 artificial intelligence-based algorithms. The first one actually does a quality control check, makes sure that the sample quality was okay and so on. The second one, then the second algorithm comes, which actually identifies landscape changes that are related to cancer. So it will identify whether the sample was from a patient with cancer or not, or did not have cancer. And in case if the patient had cancer, then the third algorithm comes, which then tries to identify what type of cancer it is. So this basically is a snapshot of our technology. So this is the serum we use, like I said, 10 microliters or 0.0, less than very small amount. We map all the metabolites, and that below is the landscape profile that you can generate. Then after a quality check algorithm, we have another AI algorithm. This is something we have copyrighted and patented this technology. It analyzes whether it is cancer negative or cancer positive. If it's cancer negative, it throws out a report saying negative. If it's cancer positive, then we have a third algorithm that comes in and identifies what type of cancer it is. And this just summarizes the work. And in the initial phase, we focus on identifying the 4 women-specific cancers. These are the 4 cancers, and I'm just highlighting the importance, particularly in terms of early stage cancer detection. 2 points in terms of it covers all the adult age groups from over 20 to 80 plus. The important thing is the stages. As you can see, these are all early stage cancers we're looking at, and the results are there. The results are there, and you can see we get a very, very high sensitivity, 98, ovarian slightly lower, but otherwise 98 to 100%. And importantly, the specificity is also very, very high. So there's very few, less than at the most 1 to 2% of false positive calls, right? Then, of course, we have also done field trials with partnering with Panimalar Cancer Hospital in Chennai. We got a double-blind validation done. We got samples blinded from the US. We analyzed it, sent it back, and it was decoded by 3 independent referees in the US. and that again you can see they got a 98%, confirmed a 98% sensitivity and specificity. Following this, we also did a field study with, in partnership with a hospital in Chennai. The first thing is we wanted to confirm that the algorithm works in patients, so we got a small set of samples and tested them with our algorithm, and you can see we got very high. Following that, we did a blinded study. We got 1,000 blind samples. We analyzed it, sent it back, and you can see the results. The sensitivity is 99.6 with the specificity. This is remarkable. I mean, so what this tells you is the approach that we employed, the perspective we employed is kind of very powerful and gives you unparalleled accuracy for early stage cancer detection. And below you can see identifying tissue of origin or the cancer type. Again, that is achieved with very, very high accuracy. Yeah? So this is basically the construction of our software. This is the heart of our product. This is, it's really the 3 sets of AI algorithms that come in. Like I said, the first one identifies quality check criteria. If there's any failure, it identifies what the failure criterion is. It suggests to the operator what he or she should improve. Then, of course, once it clears quality check, it identifies cancer or no cancer. And if it is cancer, it identifies what type of cancer. And the software analysis hardly takes a couple of minutes for each sample, right? So in principle, anybody who has the right machine mass spectrometer and the protocol can analyze in their lab, and we put the software up in the cloud, so directly you can upload the data on the cloud, get your results back on your server. So this is basically, we have tested it for robustness over a year, and this is the summary results. We have over 5,000 samples tested. Just want to emphasize again the very high sensitivity, very high specificity, and importantly the remarkable positive and negative predictive values, when you correct for incidence rates in the Indian population. It's quite remarkable. So we have an international PCT filing across 180 countries for this. We have the copyright, and currently we also have the software registered with CDSCO, and we're currently bringing this out as a laboratory developed test, okay, within the next 2 to 3 months. But while that is going on, we also are now expanding the scope of tests, realizing that this is a very powerful test to cover multiple other cancers. So we can now detect over 15 cancers in women simultaneously. This is the accuracy that you can see here. Again, it's quite remarkable. It's all just single run, a single drop of blood more or less. And we're now doing clinical trials across the whole country to actually include both male and female cancers, with prostate cancer also for males. So this is going on. So I think by the second half of next year, we'll actually come up with a test that covers all of these cancers in both men and women. Yeah? So really looking at metabolomes, developing innovative strategies, to interrogate the data, you can actually come up with very, very, this just shows we are the only company in the world now which can actually meet the minimum criteria for a threshold for a screening platform, and that I just wanted to introduce the product here. Thank you so much. Yeah, thank you.
Thank you, Dr. Rao, for that piece of information, and we'll definitely like to send our patient for early detection who are interested. And our next speaker is Dr. Nikita Naik. She will talk on how telemedicine helping the patient and doctors to bridge the gap.
Timer.
Good evening, respected doctors, researchers, and organizers. Myself, Dr. Nikita Naik from Team Swasth Bhumi. We are a technology-based healthcare service provider in a preventive healthcare. As we all know that past 2 years we all have suffered because of pandemic. Our life was on standstill. It is manageable for the normal people who is not having any disease. But for the patients, it is running out of time. It is mainly for the cancer patients, it is racing against the time. It was a difficult task for them to go to the doctors to do their test and to take their treatment on time. So, sorry. So to breach the gap between the doctors and patients, there the technology come at the help, and the idea of OncoDG care evolves. So we are here to provide you a hassle-free doctor and patient on board on the single platform. We have seen that it is very difficult for cancer patients to finish their test and to take their treatment, cycle treatment. Many of the chemotherapies or the surgeries or the rehabilitation physiotherapy were at halt. So and then this is how the idea of OncoDG care comes, and we provide end-to-end technology-based solution for the cancer patients. Like cherry on the cake, the revised Telemedicine Act 2020 reinforcement make our things very easy for all of us. So OncoDG care is, please run the video. There's a small video for the concept of OncoDG care.
Hey there. Now, get easy cancer diagnosis suggestion from home. OncoDG Care, a unit of Swasthbhumi Private Limited, is a second opinion solution managed by oncology experts and cancer doctors. Just create an account, connect with an oncologist. We review your medical records, suggest personalized treatment. We are specialized in cancer diagnosis using slide review, genomic analysis, biopsy review, CT scan, ultrasound and MRI reports. Our expert opinion with 2 decades of experience educates you in cancer management. Contact us for the right treatment plan.
So this OncoDG Care is a platform where we provide you many services under one roof. So the real challenges are like when we want some patient's data, so we have to go for many chats or many folders we have to open, but here we are giving in one. It is a cloud-based service that is what we are providing. It is useful for patients, for doctors, for hospitals, for researchers, everybody. Like for patients, they can use this platform for a virtual consultation, and as we all know that cancer is such word that everyone wouldn't like to believe that and would like to go for a second opinion. So it is very useful for the patients. They can avoid the long queues, or whether the doctor are in that city or not, they can use this platform. For doctors also in their busy schedule, they can give easily at any place from anywhere. They can use this platform and give their respective views. For hospitals and nursing homes, those who doesn't have a oncology on board, or all services in their hospital, they can register with us and they can use our services. And for clinical, as we are a cloud-based service provider, all the data are stored in one place. So research, it is very useful for the researchers. You don't need to go backward or find your data anywhere. So the nowadays it is I can say it's an era of teleconsultation, and we are a HIPAA compliant service provider. So right from your appointment booking to a scheduling to a notification to e-prescription or a chat box or invoice generation or a report storage, everything can be done under one cloud. And since it is a HIPAA compliant, your data is secure at one place. This is useful for the admin, to the patients, to the cancer care coordinators, doctors, pharmacists, and to the diagnostic people also. We have certain, it is very useful for the hospital people to increase the revenue, as they can onboard all the doctors or the oncologists, whether it is a chemotherapy or a surgical oncologist. They can provide all the services under one roof. Overhead costs are less, the data is more accurate, and better diagnosis and treatment. You can also manage the work-life balance. Patient satisfaction is there. There is no long queues or a cancellation, and no chance of infections are there. There are many advantages to patients also, where they can easily contact any specialist at a very low cost, as it is a virtual platform. They don't need to travel, or they don't need to spend on traveling or anything. Patients are in rural area, they can easily contact us and access it. Online payment and auto alert, we provide all kind of services. Whenever patient comes to you, you just need to give our number, and they can dial our patient coordinator, and we will take care of everything, right from booking an appointment with the doctor, on scheduling it, and lab reports, and prescription and wallet management. Everything can be done under one platform. This is our dashboard for the patient, where you can see everything, right from the patient's history to the current treatment, or all his reports and everything. It is patient can communicate via messages, or you can also communicate via any messages or anything. This is your doctor's dashboard. it is also like the safe for, I mean, other than anybody, other than you, and no one can manage this dashboard. So for doctors, it is very beneficial as the easy, I mean, we can schedule on your behalf tracking of the patient's health chart and prescription and diagnosis, and I mean a diagnostic test and everything. So it is very useful. Right now we are working on a 2 module. It is a revenue sharing module and an annual subscription module. You can contact our coordinator upstairs. Right now we have 475 plus patients and thousands of online consultations we have done with that. These are the benefits of using our platform and doing this online consultation. There is some small video again for you, just for the information.
शीतल कैसी हो? मैं ठीक हूँ मीनू, तुम बताओ। आज आकांक्षा काफी फ्रेश लग रही है। लग रहा है उसकी तबीयत में सुधार आ रहा है। बिल्कुल सही कहा मीनू, उसके कैंसर का पता चलने के बाद तो हम टूट ही गए थे। डॉक्टर ने कहा अब सर्जरी के अलावा कोई और ऑप्शन नहीं है, लेकिन मेरी एक फ्रेंड ने कहा कि किसी और डॉक्टर का सेकंड ओपिनियन लेते हैं फ्रॉम www.oncodigicare.com और हम बेस्ट ऑन्कोलॉजिस्ट से सलाह ले सकते हैं। और ऊपर वाले की कृपा से उसका कैंसर आगे बढ़ नहीं रहा और वो धीरे धीरे अपनी नॉर्मल लाइफ जी रही है। शुक्रिया मेरे दोस्त का जिसने मुझे www.oncodigicare.com के बारे में बताया। सही है यार। For more info, visit us at www.
For any queries, please visit on our website. And at present, we have a web availability plus Android and app development also. Thank you.
So thank you everybody. Thank you Niharika madam. So that was the last session of day 2. So sometime from now, so we can join today's dinner, banquet and entertainment program. So tomorrow, day 3, Sunday. So let us make it a super Sunday. We start at 9. So we'll finish up with lunch. So you have more sessions coming up tomorrow. Till then, join us for the banquet. Good night. Take care. Sabba khair.